disease. GVHD is protective. It gives a graft versus leukemia effect, and decreased incidence of relapse, that is with GVHD of grade 1 to 3, is associated with decreased incidence of relapse, and chronic GVHD is seen gives better survival. So taper and stop GVHD prophylaxis between day plus 60 and plus 180 after transplant in the absence of acute GVHD. This is the response criteria that is being used after HSCT in GMML. And so post-transplant monitoring, so we have to monitor the recipient donor chimerism at close intervals, especially in high-risk disease, to as close as almost weekly. So this is a flow chart showing a day plus 30 post-transplant assessment. If there is molecular response, full donor chimerism, follow-up. If there is a relapse, take up for second transplant. Those patients who relapse after transplant, around 30 to 40% can be salvaged by a second transplant. And if there is no molecular remission or a mixed donor chimerism, then modulation of GVL can be tried even after, like, if we have tried decreasing GVHD prophylaxis, then azacitidine or escalated doses of donor lymphocyte infusions can be tried. But if there is refractory disease or transformation to AML, second transplant is needed. Although transformation to AML, the prognosis is really bad, with only 5 to 10% making it after the second transplant. So post-transplant prophylaxis, there is 50%, more than 50% risk of recurrence with high-risk GMML. There is no systematic data to what post-transplant prophylaxis to be used. Yes, but seeing from the adult data, the low-dose AZA plus escalated DLI may be tried in high-risk cases. So this is just a table, just to conclude that the patients with germline, NF1 and somatic PTPN who are mostly high-risk patients, they require swift transplant with a low-intensity GVHD prophylaxis, and the patients with germline CBL are the patients with a wait-and-watch policy, and they can be taken up for transplant, and they do well after transplant with stable mixed chimerism. And the rest all patients, depending upon their risk profile, they can be managed with azacitidine like somatic KRAS or for transplant. So this is a recent, this was published a year back by the French group. They did a predictor classifier for poor prognosis. They presented a data of 119 patients, and they saw that they had a 5-year event-free survival of 66% and a 5-year overall survival of 73% with a 25% of relapse rate. So they identified 4 independent adverse prognostic factors for overall survival, which were age at diagnosis 2 years and more, time to transplant 6 months, monocyte count at diagnosis more than 7,200, and presence of more than 1 additional genetic mutation. And they predicted this proposed model that patients with none of this had a 5-year overall survival of 100%, and patients with having 3 or more of this had a 5-year OS of around 34%. So the results of the most awaited trial are here, that for trametinib among newer therapies, and it was a phase 2 trial with 10 patients. The pediatric patients with relapsed refractory GMML, 3 were those who relapsed after transplant and 7 were refractory to chemotherapy. The intervention was trametinib with age-adjusted doses given oral daily for 28-day cycle, maximum up to 12 cycles. The comparator was standard treatment options, and the outcome analyzed was objective response rate. So this trial had objective response rate of 50%, with 3 patients going into partial and 2 into complete remission. Overall, 4 patients, they proceeded to transplant after receiving protocol therapy and are alive in CR till last follow-up. 3 patients, they completed 12 cycles of trametinib and they continue to receive off-protocol treatment, and they have a stable disease. There is no change in the variant allele. And 3 who had progressive disease went off protocol because of molecular evolution. So yes, it can be used as a bridge to transplant, as 7 patients are alive with a median follow-up of 24 months. So the promising results of this trial led to this risk-stratified therapeutic trial of trametinib, which is still in its recruitment phase. So they have divided the newly diagnosed patients of GMML into 2 groups, low risk and high risk. The low risk one, those with having 1 somatic alteration and a low DNA methylation profile, they'll be giving a combination of trametinib with azacitidine without transplant. And the high-risk group will receive a combination of both trametinib with azacitidine in combination with fludarabine and cytarabine as pre-transplant therapy. So the results of this trial will be interesting to see whether actually we can bypass the toxic transplant in these patients. So just to conclude, the key messages is that with extensive molecular workup in the NGS era, no longer it's a uniform one-size-fits-all approach. Panel sequence analysis for 5 primordial RAS pathway genes still holds true. DNA methylation class and presence of recurrent secondary mutation to aid in clinical decision making and risk stratified treatment. And pre-transplant therapy, yes, it definitely reduces the disease burden. Thank you.
Thank you. Fantastic, Dr. Varsha. I think before we move on to the next talk, as we all know that molecular workup is very important when it comes to JMML. There was a time when every patient of JML was taken up for transplant, but now with the molecular workup coming up in a big way for diagnosis, for treatment, for prognostication, it is very important. So if I have to ask you, Anuj, if you can answer, what initial test would you recommend? Because you can have a germline mutation, you can have a somatic mutation. What initial workup would you recommend in a patient, for the youngsters who are sitting over here, to diagnose and to risk stratify when a patient comes to you?
Yeah, thank you. Fantastic presentation, Dr. Varsha. And in JMML, the problem is the diagnosis. So we have seen the mean time to diagnosis from the onset of presentation is at least 2 to 3 months. First of all, it is not suspected. We continue to have high count, fluctuating monocytes. They are being evaluated for all the common infections, but the diagnosis is often delayed. And the family is one, we are able to do the marrow, and then the situation known as diagnostic test fatigue. I've seen families often break down when we say we have to do one more genetic, wait for 21 days more, and it's a lot. So the basic test which you need to diagnose is first look at the trend of CBC. Look at how the patient's profile is progressing. It's persistent. That's the single most test which should make you suspect in a young child, less than 2-year-old, monocytosis, splenomegaly, monocyte count more than 1000, that should make you suspect about JMML. Then bone marrow is mandatory. You have to rule out that the blast percentage is less than 20%. It's not more than 20%, which will fit into the definition of AML itself. And then sadly, this is the disease in which, as per WHO also, we have to have a genetic diagnosis. So a panel sequence, as suggested by Dr. Varsha also, which covers common 5 mutations, RAS pathway mutation, CBL, PTBN, is mandatory. Once you get that, the one more test is there then to check whether it's a germline. So again, you have to send a somatic tissue, either a buccal mucosa swab or a hair or a skin fibroblast for culturing. But we can start the patient on therapy at that time. HbF is usually not done. These patients are getting frequent transfusion. It's very tough to interpret HbF. GM-CSF hypersensitivity is available at very few labs. I think only in Mumbai there is one lab, NIH, which does that actually. Yeah, thank you.
Once you suspect JMML, do the molecular workup, send the blood test and the buccal mucosa together. That means if you do it together, you can save some time and you can decide on the therapy. Then Dr. Arun, if you can tell everybody, the people sitting over here, role of splenectomy. How important is to remove the spleen or to just keep it before you take the patient for transplant? That's a controversial thing.
Yes.
People have got big spleen, massive splenomegaly. You are always worried with a massive splenomegaly. The patient is going to engraft or not. Whether to take a young patient, less than 2 years of age, or splenectomy, subjecting them to risk of infections. So that's a controversial stuff.
So Dr. Varsha also highlighted in the presentation that splenectomy before transplant is controversial. So, and we have now chemotherapeutic agent which lead to your decrease in the spleen size. So we can go with spleen and the reduction of the disease burden by chemotherapy. And so I think it is still not very useful modality before, but few centers are still doing it.
Yeah, we have to assess the risk-benefit ratio when planning for splenectomy.
With medicines like azacitidine with you can give a trial of azacitidine that will help in bringing down the spleen size, and then the patient can be taken up for transplant. Thank you very
Dr.
much.
Varsha, any center is doing methylation study for JMML?
Methylation study, no. That's why I said that still we rely on the old these things. The presence of germline mutation is very much important because there are only very few subset of patients who can do well, who can follow wait and watch policy. So still it's not widely available.
Thank you.
So Asta, from your side, anything specific for these patients? So Asta is the head of hematology lab.
Thank you, ma'am, for such a wonderful talk. I have two questions actually. One is when we say persistent monocytosis, what is that minimum persistence you are looking for?
Persistency, ma'am, as per the diagnostic criteria, it's 1,000. But
The
yes,
duration, because you
duration
say na, that many patients they go undiagnosed or
4 weeks.
underdiagnosed. Yes.
So yeah, mostly studies have given a persistence of, I mean, for diagnosing, they have given 4 weeks. But this is, it's not very clear, you know. At many places, this has been used upfront at the time of diagnosis, persistence for more than 4 weeks, as there are many infections also who present like this, who will mimic completely. I mean, they will mimic GM hypersensitivity, they will mimic complete clinical picture.
Even
So
in the
it's
marrow,
difficult.
yes. Even
Even in the marrow,
yes.
absolutely. That is why, as Dr. Anuj rightly pointed out, the diagnosis is very frustrating. So 4 weeks is the time that most of the trials have kept it.
Yeah. Okay, and the second question is that blast count less than 20%. If it is less than 20%, does it make a difference? It is 10, 15, 12, 18, whatever.
No,
To
it
the
doesn't.
prognosis?
No.
Okay.
Actually, blast percentage is mostly important to rule out leukemia, as I had also shown in my slide that blast percentage more than 20% at the time of diagnosis is associated with poor risk. That doesn't mean that the child is leukemia, because it's also associated genetic signatures that are present in the
Yes.
child. So
But
yes.
less than 20% doesn't
Yeah,
make a
yeah.
difference.
I think Asta, if you have if you have a blast percentage of more than 20 in a patient of JML, that means the patient has already progressed to AML and the outcome is
Poor.
zero.
That's it.
Yeah.
That is pretty clear. But less than 20%, do we have any
No,
difference
no,
in the
no,
prognosis?
no.
Okay. Thank you.
Only for relapse they have kept a cutoff of 5%, but otherwise no.
Thank you, Varsha.
Thank you, sir.
very
Thank
much.
you.
Thank you, Dr. Varsha Mishra. Can we have a round of applause for her, please, for giving us such an insight? And thank you, Dr. Anuj, Dr. Arun, Dr. Vikasu, and Dr. Astha for such a knowledgeable discussion. Next, we have the future of ALCL care, high dose to high tech. And I would like to invite Dr. Himani Basin on stage, please. She's an assistant professor in Vardhaman Mahavir Medical College, New Delhi, and she's going to speak on the topic, the future of ALCL. Can we have a round of applause for her, please? Thank you.
Good afternoon, everyone. At the onset, I would like to thank the organizers for giving me this opportunity to be a part of this extravaganza. So the topic for me to speak is ALCL, that anaplastic large cell lymphoma. As the name suggests, it's a great masquerader, the anaplastic. So I would be briefly talking about the initial clinical presentation, the workup, and later on I would be discussing the recent advances in the management of ALCL. So without any wasting time, moving ahead, the entity was first described by Steen in 1985. As we all are aware, it's a type of mature T-cell lymphoma with a characteristic CD30 present expression, and it accounts for roughly 10 to 15% of all childhood non-Hodgkin's lymphoma, and of these 95% are ALK positive. This is very important. It plays a crucial role in the management and also the prognosis sometimes. And the majority of the patients have advanced disease at the time of the presentation with a high incidence of extranodal involvement. This is a recent WHO classification which broadly divides ALCL into 4 categories: ALK positive and negative. As I've said, the pediatric ones are out of these 90% are ALK positive, and the third one is, which is seen in adults mostly, is like breast implant associated ALCL, and the last is primary cutaneous CD30 large T-cell lymphoproliferative disorders. Of those who are not ALK positive, they have mostly show rearrangement with DIS P22 in nearly 90% of the patients, and less than 1/4 have a TP63 rearrangement. And a small proportion, roughly 42%, neither present are ALK. They are neither presenting DIS P22 or they are not having TP63 rearrangement also. So this plays a role in the management later on. Coming to the clinical presentation, the median age of presentation is 12 years, and this ALCL is rarely seen in the children before 1 year of age. the males have the proportion of this entity, and 70% of the patient presents in the advanced stage, stage 3 and stage 4. The GIT and the CNS involvement at the time of presentation is rare. Nearly only roughly 2.6% of the children have CNS involvement at the time of presentation, and 10% have concomitant HLH. Now, coming to the pathology, this is characterized by the presence of classical, bizarre, large horseshoe-shaped nuclei cells, which are known as the hallmark cells. This is seen in 60% of the classical variant which we have, which is the most common variety, which we will be seeing in the histology. So this is the histological variants of ALK-positive ALCL, the commonest being the common variety, which is seen in 60 to 70% of the cases, and the hallmark cells are seen in this. The next are lymphohistocytic variant, small cell variant, which holds a poor prognosis. And the last one is the Hodgkin's lymphoma, and the rarest is the composite, having a mixture of these. Coming to immunophenotyping, these cells show positivity for ALK, CD30, and EMA. However, the B cells markers are negative. It is a pure T cell lymphoma, and characteristically they are CD15 negative, which helps us to differentiate these cells from the Hodgkin's lymphoma. Important to note is that the ALK positivity by IHC, which is commonly available in the government setup, there is a 98% correlation with ALK rearrangement. As in the resource limited country, India, we are sometimes unable to do those rearrangement studies. So we can proceed ahead and look for the ALK positivity using the simple method IHC also. And we can get a hint about the nature of the translocation and the partner gene with which the ALK is fusion. If there is a nuclear as well as membranous positivity, we can think that there is an NPM-L translocation, which would be can be confirmed later on by doing the genetic rearrangement studies. And only if there is membranous positivity, we can suspect that could be a non-NPM partner, which I will be telling later. So the classical translocation which we see in ALCL is translocation 2 and 5, in which there is a fusion of NPM1 gene with the ALK gene, which is seen in 72.5% of the cases. Apart from this, there are also non-NPM fusion gene partners, such as we have TPM3, TFG, ATIC, and CTCL. So this holds, if possible, we should always get a molecular study and a rearrangement studies. If not, then we can rely solely on the IHC method, the availability at a center. And these are the this table highlights the silent difference in the molecular patterns which we can see in the ALK positive and ALK negative ALCL. There is a difference in the genetic. However, the prognostic factors which are important later on as a clinician we would be treating this is more or less the ALK positivity. If you're able to categorize this as a ALK positive or ALK negative, that is more than sufficient, rather than if we tell which gains are present or which deletions are present. We can keep a study and investigation being limited, being broadly classifying it as ALK positive and ALK negative. Now, coming to the stages, earlier the traditional classical staging system was a stent-induced staging, and recently there is an international pediatric non-Hodgkin's lymphoma staging system which has come up, and the stark difference between the two, more or less it's same, but there are two main differences in the recent staging system which we are following right now. In the CEN2 stages, the extranodal tumor environment, when it was above the diaphragm or below the diaphragm, that was on the same side, it was staged as stage 2, but now in the recent classification, it has been shifted to stage 3. And secondly, the involvement of the primary GI tumor. In CEN2s, if it was with or without involvement of the mesenteric lymph node, it was labeled as stage 2. However, if if it was an extensive primary intra-abdominal tumor, it was categorized as stage 3. However, in the recent classification, any intra-abdominal involvement has been classified as stage 3. Now, coming to the prognostic factors, there are basically the majority of the work in ASCL was done in the European continent, and there is a European intergroup study which showed that I followed these children for around 10 years, and in the univariate analysis, they have classified and identified certain disease presentation patterns which they would later on have associated and found that they have a prognostic factors implications. In the urine variate analysis, they found B symptoms, mediastinal involvement, skin visceral involvement, stage 3, stage 4 involvement, and increased LDH as a prognostic factor. But later on, when they did multivariate analysis, only the mediastinal involvement and the visceral involvement could become eligible to be classified as a significant prognostic marker. And the classical trial AACL 99 results, which also showed a 10-year follow-up, in the multivariate analysis could have identified CD3 could not be tested, which is important. They have classified MDD positivity, small cell, and NH histopathological subtypes, which are although rare, but still they have a poor prognostic implications in the disease pattern. Recently, we have a concept of minimal disseminated disease and minimal residual disease in ALCL as well, like leukemias. The techniques which we are using for assessing and quantifying MDD is RT-PCR, and recently we are having a droplet PCR also for doing this thing. So MDD is generally we look for MDD at the onset. When the patient is diagnosed, we can check for MDD either in the peripheral blood or in the bone marrow. The correlation is same. Rather, some studies have said that peripheral blood is a much better sample in which we can assess for MDD. So we will look for MDD, and MDR is assessed after, in majority of the studies, after the first cycle of chemotherapy, that is before the second cycle. So it has been concluded that the children who have only MDD positivity, irrespective of MRD positivity or negativity, they fare better. If the MDD is, they feel less better as compared to the MDD negativity at the time of diagnosis. The children who are MDD positive, they have a cumulative incidence of relapse of nearly 50%. Half of the children will relapse, and in the children who are MDD negative, of these only 15% of children will be facing relapse later in the course of the illness. This MDD was initially, it was a qualitative thing, present or negative. Then the more research work was done, and they came to a concept of normalized copy number ratios. So initially it was like more than 30 and less than 30 was the standard, which a study which was reported around a decade back. But later on, they have further standardized this thing with respect to ABL number of copies, and then this number came 10. So if a child is having MDD positivity at the time of diagnosis, and the normalized copy number ratio is more than 10, so the cumulative incidence of relapse would be nearly 70%. So this has a really prognostic implication. If we could identify these children early, then we can add something to our initial induction treatment regimens. However, contrarily, the children with less than number of these copy numbers have a very less incidence of relapse, nearly 20%. The children who are MDD positive as well as MRD positive after first cycle of induction therapy, the CIR rate is 80%. And the children who became MRD negative of the first cycle of chemotherapy have a reduced CIR rate of nearly 30%. So this is very important. If we could implement this thing in a routine practice at our setup, so it would be really helpful. But unfortunately, we have a resource limitations, and the laboratory are not standardized till date to monitor for this and to do quantitative analysis for this MDD and MRD at present for ALCL. And as I've told earlier, there is a good correlation between the blood and bone marrow MDD and MRD values. So recently, it has been implicated as a prognostic factor in ALCL 99, and they have concluded that the MDD at the baseline correlated with the presence of B symptoms, mediastinal disease, visceral involvement, high-end disease, and with small cell and lymphocytic histopathology. All of these, I have told, these were the broad prognostic markers which have been identified in the past studies. So till date, if I have to look for one thing, if I can say could be a prognostic marker and that can be used for the stratification of these patients, would be MDD more than 10 NCN. It's the best predictor as it correlates with clinically also, with pathologically also, biologically. The children who were found to have MDD positivity reported low anti-ALK antibody levels. And also they later have a progressive disease, and majority of them were CD3 positive at the baseline. However, in ALCL 19, CD3 positivity was not tested. So based on all these findings, a latest risk stratification was suggested, in which the children with ASCL are divided into 3 limbs: high risk, intermediate risk, and low risk. The low risk group included the children who are MBD negative and are high antibody titer. As we all know that the ASCL children mount immune response also. So in these cases, the 5-year PFS was 93% as against the high risk category who were MBD positive with the low antibody titers. And in these cases, the 5-year PFS was 28%. So where the future lies? Likely the future risk stratification will be based on MDD, ALK antibody titers, and MIB status post-first cycle, if we could attempt it. Now coming to the management from past to present, previously there was 2 main cohorts, European and the American cohort, which were conducting the parallel trials, and they were basically aiming. There was a stark difference between the patterns which both the cohorts were following. The Europeans were mainly focusing on the multi-agent short interval block therapy, whereas the American COG group was mainly treating this ALCL like a leukemia based on the leukemia-like regimen. Prior to that, in the early 80s and 90s, this entity was not treated separately, and they were using these structured protocols for leukemias and lymphoma for these ALCL patients only. So the first was the French group. They gave 2 courses of carpedum and a maintenance treatment for 5 to 7 months, and the event-free survival was ranging between somewhere between 60 to 65. Then came these 2 main groups which identified this category as a separate category, though it was rare at that time. And this was the basic difference between these 2 arms. So European were concentrating on short intensive BHNL analogous therapy with a high dose of alkylators and high dose methotrexate. They were not using anthracycline, whereas the COG, they were following leukemia-based therapy with high cumulative doses of anthracycline, no high dose methotrexate, and very low dose of alkylators. But the EFS in both the groups was similar, between 65 to 70%. The overall survival ranges between 80 to 90%. Later, the NHL BFM19 was the first trial which segregated these patients and started treating these patients separately. It was when they did a retrospective analysis for the children who were CD30 negative, likely to be categorized as ALCL positive patients, CD30 positive ALCL patients, the 9-year EFS was 83%, the 9-year OS was 81%. So this was the trial BFM90. We all know about this trial. K1, K2, K3 arms, high-dose chemotherapy regimens were given, and those were the event-free survival. Then came BFM95 trial. They have tried different reducing the duration of therapy, duration of infusion, and also the dose of high-dose methotrexate, and what they found that in the R1 and R2 early groups, the 4-hour infusion and the 1 gram dose were not inferior but were less toxic than the 24-hour infusion and the 5 gram per meter square injection of high-dose methotrexate. This forms the basis for ALCL 99 trial, which was the first dedicated trial for the ALCL children. So in these all children received 6 cycles, and there were 2 arms. One arm received 1 gram per meter square with TIT, and the second arm received high dose of methotrexate over a short duration without any TIT. What they have found that the 3 gram arm with short duration without IT can safely replace 1 gram per meter square over 24 hours with IT in the children with ALCL without any difference in the EFS and OS. This was the extension of this trial in which they added vinblastine. Later on, there were studies which were assessing the role of vinblastine in ALCL. So what they found that when they added vinblastine, there was a prolongation of EFS and OS in the first year, but later on, there was no significant difference between the two. So the difference holds only till 1 year, and after that there was no improvement in that. So what they concluded, if we add a vinblastine upfront, so there would be delay of the relapses which we are seeing in ALCL, because despite of giving high dose chemotherapy or anything, nearly 25 to 25% of children of ALCL will relapse subsequently. So the main concern was, if we add the main thing advantage what we got after adding vinblastine, we were delaying these relapses without any concrete evidence of achieving any improved overall survival or EFS, event-free survival. So this was an American study. They were using leukemia backbone, the APO backbone. But they also tried with vinblastine. There was no significant difference in the between in the 3-year OS or EFS, and they concluded vinblastine now was more toxic. So vinblastine was somehow was de-escalated as a induction agent initially. This was another study by the COGU group in which they altered maintenance and added intermediate dose methotrexate and high dose cytarabine in the maintenance arm. There was no difference in the event-free survival and overall survival. However, the toxicity was more. The main aim was to reduce the dose of alkylators. So with this, there was like no concrete standardized structured treatment protocol were available. Only the ALCL 99 trial was there, which suggested multi-agent block therapy for short duration, which we can give with a high toxicity sometimes, and the overall survival and the EFS ranging between 65 to 75%. So what could more be done? The first step was taken by the COG. By that time, there was era of monoclonal antibodies as the ALCL is CD30 positive and ALK positive. So people were exploring these agents with ALCL children also. So brentuximab vedotin came into the picture this time. It's a anti-CD30 monoclonal antibody bound with the conjugated with a microtubule disrupting agent. Initially, it was used as a bridge to transplant in relapsed patients, in adults. But when they were able to find good results in the adult study, they switched using brentuximab vedotin in the children subgroup also. So this was the first pilot study done by COG. In this, they gave 6 cycles of chemotherapy to ALCL children, and they added brentuximab upfront in the induction regimen, 1 dose per cycle for 6 cycles. And what they found that there was an improvement in the 2-year event-free survival from 65 to 75 to 79.1 a marginal, and the best overall survival was achieved till date, that is 97% in the newly diagnosed patient of ALCL. So that's where they suggest, if possible, we should add brentuximab vedotin if available. This goes without mentioning this adult trial. This is also a landmark trial. It's a phase 3 adult study in which initially they were using CHOP regimens for managing ALCL in the adult patients. On this, they replaced vincristine with brentuximab vedotin in a newly diagnosed ALCL patient, and there was an improvement in progression-free survival and overall survival. The main aim of adding the BV to the targeted therapy to this multi-agent chemotherapy backbone was to reduce the anthracycline dose, which was not achieved in this trial. The anthracycline dose was 300 to 400 mg per meter square, as against the pilot study in which I showed previously in the last slide. There they were able to reduce the anthra dose to 150 mg per meter square. So that was the ray in hope in which we can reduce the cardiotoxicity in these children. There is another trial. Predominantly, it's not a separate trial for ALCL children. They form a part of a large cohort of peripheral T-cell lymphoma in which they are adding this BV CHOP with etoposide and consolidating with BV monotherapy without doing any transplant or anything. The preliminary result showed it is safe and efficacious. The most common side effect encountered with BV is peripheral neuropathy, which is manageable, and it is more commonly seen in adult patients as compared to the children. So the next thing which they explored was ALK inhibitors, and of these, the first one was crizotinib. Again, it was an American group. They conducted similar based on the same backbone, ALCL 99 backbone. They added crizotinib in the upfront newly diagnosed ALCL patients, and they gave 6 cycles of chemotherapy, and they also found a marginal improvement in the overall survival and the event-free survival. However, there was high incident of thromboembolic events in this cohort. So that's where and secondly, the crizotinib is not that potent. It has a very less CNS penetration. So it was like, if we have to choose between crizotinib and BV and everything is available, then BV should be chosen first. Another ALK inhibitor, these are the next generation inhibitors like ceritinib and alectinib, brigatinib, lorlatinib have been developed, and the trials are underway. None of the studies till date have used these ALK inhibitors apart from that pilot study upfront in the newly diagnosed patient of ALCL. These mainly are involved in the management of relapsed and refractory patients. the next generation are being more propagated because they're more potent with a better CNS penetration, and the ALCL with CNS involvement at the onset or even at the relapse holds a poor prognosis as compared to the children who are CNS negative. So this is about the newly diagnosed ALCL. Now a word about relapse and refractory ALCL. These are the different consortiums which independently and parallelly were studying these patients, and what they concurred on that nearly 50% of the patients of ALCL treated upfront will relapse within 12 months from the diagnosis, and the mean time of relapse was 8 to 12 months. The CNS involvement, which was 1 to 2% at the time of diagnosis, hikes up to 5%, and the bone marrow involvement is roughly 15% at the time of the diagnosis. So what can we do for these children? The re-induction strategy remains same. We have to start with the chemotherapy, and if available, we should add a targeted therapy. So what options we have? We can choose amongst the BFM chemotherapy and consolidate later on with the autogenic or allogenic transplant. And there were studies also about the single agent vinblastine. So overall, the event-free survival and the overall survival for this cohort remains between 40 to 50%, and the OS was between 60 to 65%. These are the studies which highlighted the role of single-agent vinblastine in relapsed and refractory patients. As noticed earlier, the main advantage of adding, we can use vinblastine only if it's a low-risk relapse. If it's a CD3 negative relapse and it's a late relapse occurring more than after 12 months of stopping the therapy. And importantly, the duration for which vinblastine should be given is not known. That is also limiting factor. This is another study by the BFM group. They have also studied this cohort and concluded the overall survival is less if there is a bone marrow involvement as compared to CNS involvement. The important crucial factor is trying to relapse, the worst being the progressive disease followed by early relapse. And another important prognostic factor is CD3 positivity. The children who were CD3 positive at the time of relapse fared very poorly in these studies, and they have to resort to allogenic transplant later on, and on allogenic transplant also many of these relapsed. Okay, so these are the outcomes which I have told you. The overall, if we are proceeding ahead with the autologous, the 5-year EFS was 59, OS was 77, and the progressive disease, it was 0. And the late relapses, 64%, CD3 positivity 18, CD3 negativity 72. So what we conclude, autologous transplant is not a treatment or salvage option for consolidation in the children having a high relapse, of high risk relapse of ALCL and CD3 positivity. So this is the only available randomized trial till date of ALCL relapse, which has classified these ALCL patients into the 4 groups based on all the prognostic factors which were highlighted in previous studies. It classified it into very high risk, intermediate risk, and low risk, depending on the CD3 positivity and the time period of relapse. And the children who are under very high risk mainly will undergo allogenic stem cell transplantation because of the poor result which we have seen with the observation period or the autologous transplant. And the children who are having intermediate relapse, in the intermediate category, we have 2 options. Either we can consolidate them initially with the autologous transplantation, subsequently wait. If they relapse, we can reconsolidate them with allogenic. And the last are the very low risk, the low risk, very low risk group. In this, we can follow them with the 2-year monotherapy with vinblastine. That has proven, that has shown a good results in this cohort with an overall survival rate of roughly 80% in this cohort. So these are the modalities of treatment which we can decide upon depending upon the patient profile and the CD3 positivity and the timeline. So to summarize, in the relapse patient, this I have in the progressive disease, CD3 positive, we can consider upfront palliation also. If negative, we can consider allogenic transplant. In early relapse, CD3 positivity, definitely we should go ahead with the allogenic transplant. Negative, we can give it a trial of a weekly vinblastine for around 2 months. In the late relapse, surely we'll proceed ahead with the vinblastine weekly. So a word on the role of targeted therapy in relapsed and refractory cases. We have ALK inhibitors. There are few studies which have explored the role of crizotinib. The overall response rate was 88% if you are using crizotinib as a single agent. These are all phase 1 and phase 2 studies. The recent one is this CRISP trial, which has included vinblastine along with crizotinib, and the CR was attained in more than 80% of the patient. However, there was severe toxicity, which was noted in the form of prolonged neutropenia and neurological toxicity. So they have concluded that ideally we should not combine crizotinib with vinblastine. Then role of BV in relapsed and refractory ASL. These are the two studies only available till date. Many trials are underway. So these are also phase 1, phase 2 trials with the overall response rate of roughly 50 to 60%. And the dose is variable. Some are using 1.8, some are using 2.6 per kg. So this table summarizes the recent clinical trials which are exploring these targeted therapy for relapsed refractory ALCL. The most awaited one would be this brigapit, which is using brigatinib, exploring this, and the results are promising. Like they are showing 100% of overall response rate, but the long-term results are yet to follow. The new thing into the armamentarium is like immune checkpoint inhibitors, nivolumab. The ALCS cells express PD-L1, and we all know that there is a host cell immune response. However, we only have case reports suggesting the use of these agents in relapsed refractory ALCL. The trial is like Nivo ALCL, which is underway, and some people are also exploring the use of monotherapy using nivolumab in relapsed and refractory cases. The last is the CAR therapy, the anti-CD30 CAR. So these are also in under preliminary phases only. We have two trials in which the one in they have given this anti-CD30 CAR to two patients, and one achieved complete remission that persisted for 9 months, and in the another trial they have done lymphodepletion before giving this anti-CD30 CAR, and only the PR, they were prolonging the PR only, and of these one patient will have progressive disease. So these are the treatment options which we have for ALCL, but still it's a long way to go to decide upon a structured protocol which should include a targeted therapy, what should be the dose, for how long, and where we can incorporate that targeted therapy in the chemotherapy backbone which we are having. It's still debatable. We don't know for how long we should continue these targeted therapy. In the past studies, they have noticed the moment they have stopped this targeted therapy like crizotinib because of the adverse reaction or the financial constraint, that the patient relapsed. So these are certain questions we still need. We need to explore the answer for these, and we are yet to define a structure. It's a targeted based chemotherapy protocol regimen for this ALCL. So the last word would be, ALCL often presents with prolonged misleading symptoms. It's a great masquerader. We should always keep a high index of suspicion. Till date, ALCL 99 in India and other LMICs remains the standard. If possible, biologically based risk stratification should be used if available. High risk disease still faces suboptimal outcomes despite VV and other targeted therapy. And the relapse timing is the single most important prognostic marker along with CD3 positivity. Vinblastine works well for late relapse. This is the only good thing which we have for late relapses. We can try vinblastine, just a single injection weekly. We can give for 2 years. Allogenic transplant is reserved for early and progressive relapse. Autologous transplant has no role except in a small bracket of intermediate relapse patients. And as we all can extrapolate, targeted and immune-based therapies are rapidly evolving and definitely will reshape the relapse management even in the LMICs in the coming future. So with this, I would like to end my talk. Thank you.
Hello. Thank you so much, Dr. Himani Bhasin, for giving us such an insight. We have Dr. Tulika Seth with us.
Ma'am has another session in the next room. So a fantastic talk, Himani. And if I have to ask the house, Faisal, Anuj, have you used these targeted therapies in an upfront setting? If you have used, and what is your experience? Brentuximab, Crizo. So all of us are familiar with the use of these medicines in a relapse refractory settings, but have you tried this in the upfront setting, and what is your experience like?
No, sir. Upfront, we have not yet tested. We have used only in relapse refractory. I just want to highlight also the ALCL is very intriguing disease. The outcomes are just stuck at 70% since last 30 years.
Yeah.
Chemotherapy has been reduced, high dose MTX, 1 gram, even intrathecal removed, the outcomes are same. The remaining 30% patient, which account for reduced TFS, can be divided into two groups. One group has relapsing and remitting course. They will have rate relapse. You will treat with vinblastine, again relapse, again vinblastine. The other group is progressively increasing disease. They will have refractory disease even at the first time point assessment. I think that is the subgroup in which, if they are not responding to induction therapy, we should go for maybe BV or Crizo, because COG has tested BV in upfront, but I am very sure in our country it's very tough to introduce BV upfront. Crizo possibly we can.
Faisal comes from Srinagar. So what is your experience with ALCL patients, Faisal?
Like Anuj said, right, there is a subset of patients, approximately around 20 to 30%, which actually do not respond that well. Other than that, the subset of around 60 to 70% of the patients, we tend to use the BFM protocol basically for it, and they tend to respond pretty okay. In terms of using the new immune checkpoint inhibitors upfront, we really haven't used them. We've used a little bit of BV upfront in terms of adolescents or something like that. One patient, that's it, not more than that. No experience more than that.
So Anjali, Ritu, do you have experience with brentuximab, Crizo, and is it available in your country? So Dr. Anjali and Dr. Ritu are from Kathmandu. So whether you have availability of these fancy new
These medicines are not available in our country, but we used to export from India, and we have used medicine, this kind of medicine.
Okay.
But often it is not possible in our context. But when it comes into the context of relapse cases, we used to bring the medicine from India only, and we have used in so many patients.
Ritu, have you tried these medicines?
I have a very small subset of ALCL patients, and then I'm using ALCL 99. So far, it has been working, and they are doing good with that. However, if need be, then we would definitely go for brentuximab and all these things.
Yeah, I think in majority of people in this country are also using ALCL 99, and some centers like you are using BFM, and we are okay with the outcomes. Any other questions?
So I just want to highlight, there was a study from Tata, I think Mumbai only. They have used MCP 842 protocol without methotrexate.
Anuj is
And the
straight from
results
Tata.
are comparable up to 60. I was reading.
I just wanted to say that only. So in ALCL, even further reduction. So that MCP protocol is like reduced dose BFM. So it has blocks of A and B, about 30% intensity reduction, completely outpatient therapy. And the cumulative anthracycline is also only about less than 200 milligrams.
So very benign protocol as compared to ALCL 99.
Yeah.
So what the results without high dose methotrexate?
Exactly. So it's actually the ALCL, the milieu is very different. If they have an inflammatory milieu, disease progressing, then they will not respond to even ALCL 99. Right. If they are having a less inflammatory picture, then they usually respond.
I think rightly said, if we can trace those high risk patients early, and we can intervene, we can put these patients on targeted therapies, then we may be able to achieve good outcomes even in those patients. Arun.
Dr. Himani, any role of maintenance post-transplant to prevent relapse, ALK inhibitor, or
is there any data? Is there in adult trial
any study?
I have to check. So there was, adding to the previous talk, there was a study, I think in adult they are doing, that is would be a good thing. The children who are not responding after 2 cycles or 1 cycle of chemotherapy, they have added those, they have, after 1 cycle only majority, they have added that any targeted therapy, they have escalated the chemotherapy, they have changed the line of chemotherapy. I think the result is awaited. And there is one more trial which is assessing the role of TKI, that is along with PTL1 inhibitors. That is underway, the results are awaited for that trial.
Right, thank you. Thank you very much, Himani. Thank you. A big round of applause for her.
Thank you so much, Dr. Himani Bhasin, and thank you, Dr. Anjali, Dr. Ritu, Dr. Faisal, and Dr. Anuj for this discussion. Next, we have the TKI toolkit, and we have Dr. Faisal Rashid Guru with us, who is an Associate Professor Medical Oncology, SKIMS SORA, and he's an in-charge pediatric oncology unit at Sher-e-Kashmir Institute at Medical Sciences. So he's already here. Can you have a round of applause for him, please? A little noise is not bad. Thank you.
It's what I meant. Thank you. First of all, a very warm good afternoon to all of you. I'm highly thankful to the Fortis team and the HEMENEXT 2025 1.0 for giving me this opportunity to present in front of you the TKI toolkit, optimizing pediatric CML treatment in 2025. Coming on to the chronic myeloid leukemia is a myeloproliferative disorder driven by the BCR-ABL fusion oncoprotein. The fusion oncoprotein arises from the Philadelphia chromosome, which includes a reciprocal translocation between chromosome 9 and chromosome 22. CML in children is rare and has a low overall incidence. It accounts for approximately around 2 to 3% of all childhood leukemias younger than 15 years of age and represents 9% of leukemias in adolescents. The management in CML is varied. Importantly to note, the guidelines have been extrapolated from adults. Pediatric CML is different from adult CML. It tends to be more aggressive. There tend to be long-term treatment and its complications. And compliance is a very important issue in case of adolescents, and there is higher resistance to TKIs. Various prognostic scores have been basically used for CML. These include the SOCAL score, the Euro score, the UTOS score. These scores have been designated to evaluate the differences in survival and response. Since most of the patients from CML die from causes other than leukemia, a fourth score has been developed to predict the probability of dying from CML, that is leukemia-related deaths. This is the UTOS long-term survival score. The ELTS score is basically based on the TKI-treated patients and uses the same hematological parameters, spleen size, and age as the SOCAL score. The main difference, however, lies in the negative predictive value of age, since it has less impact in case of TKI-treated patients than patients who received conventional chemotherapy. The SOCAL score apportions more patients to the intermediate and the high risk than the ELTS score, particularly in the older patients. So as you can clearly see, various publications have been published which show the UTOS long-term survival score is superior to the SOCAL score in predicting survival in chronic myeloid leukemia patients. There is a study by David et al. Which basically shows that various prognostic factors, various prognostic scoring systems can be used and established in adults, can actually be used in pediatrics. Coming on to the pediatric prognostic discrimination based on the UTOS score, showed the long-term survival score with the international registry in CML in adolescents. They actually showed that the effectiveness of three prognostic scoring systems and the responses and outcome in children using first-line imatinib was established in children. This score basically utilized almost 300 patients who were using imatinib, and they classified into low risk, intermediate risk, and high risk, which eventually showed that the ELTS score had better differentiation in terms of PFS in children and should be considered in various therapeutic algorithms of CML in children. Coming on to treatment, various factors need to be considered when you're deciding for treatment. The most important being the aim of therapy and the patient preferences, the cost and affordability, whether the patient can afford it or not, the various possible interactions that various TKIs can have, comorbidities in terms of, in case of children, various hepatic, renal, and pulmonary dysfunction. Important to note, the CML category, whether it's high risk or intermediate risk or low risk, and the ease of administration of various TKIs that are used in case of CML. So how do we actually treat chronic myeloid leukemia in children? The important is the various TKIs that are available. 3 TKIs have been approved as frontline treatment for pediatric population. The most importantly used is imatinib, which was approved in 2003, dasatinib, which was approved in 2017, and nilotinib, which was approved in 2018. It's very important and challenging to actually decide which TKI is to be used and additional treatment options in case of suboptimal response in children. Like I clearly mentioned, the various factors that need to be considered are, we have more experience with imatinib that's basically been used for a long time, the efficacy of various TKIs, the toxicity profile of each of the TKIs, the various drug interactions, the ease of administration, and financial constraints. Imatinib has been used in the dose of around, various studies are basically used in the doses of around 240 to 340 milligrams per meter square, however maximum dose being 600 milligrams. Dasatinib is used 60 milligrams per meter square once daily with a maximum dose of 100. Nilotinib has been used 460 milligrams per meter square in 2 divided doses. All of these TKIs can be used in the frontline setting, and TKI dose should be adjusted in terms of the body surface area, but maximum doses should not exceed. Important to note that second generation TKIs have been shown to induce a faster and deeper molecular response, but no survival added advantage.
There have been a lot of studies, and most of the data has actually been extrapolated from adults. There's this study which is compared imatinib with interferon and low-dose cytarabine in case of newly diagnosed CML patients. There is the ENEST trial, which has basically shown nilotinib versus imatinib, where they basically use nilotinib upfront. There is the bosatinib study, which is the before study. And the Dasavian study, which is basically compared the role of dasatinib versus imatinib in treatment patients of naive CML upfront, but this is mostly adult data. Coming on to the pediatric data, there is a study which was published by Casey Lakshmi et al. They actually showed that CML in children and adolescents and children initially started with imatinib. They had a total of 43 patients. Imatinib was used in the daily dose of 260 milligrams per meter squared. All the patients actually achieved a hematological response. Cytological response was seen in 58% of the patients. Major molecular response was seen in 41% of the patients, and the EFS was 92%. This study clearly showed that imatinib is effective and very well tolerated in case of children. However, side effects were noted. These include the hematological and the non-hematological side effects. In terms of non-hematological side effects, it's usually nausea, vomiting, diarrhea, a characteristic rash, arthralgias and myalgias, and a little bit of transaminitis was seen. In case of hematological toxicity, anemia, neutropenia, and thrombocytopenia are the ones that are usually seen with imatinib. There's another study which was published in the Leukemia Journal, which actually was a multicentric study which included 150 patients. Various doses of imatinib were used at different phases, and they actually saw that the responses rate of complete recovery was seen in almost 89% of the patients. Major molecular response was seen in 63% of the patients, and hematologic response was seen in 83% of the patients. And the overall survival of this study cohort was approximately around 94%, and imatinib failure was basically seen in 27% of the patients. There's another study which actually showed imatinib is effective in children in previously untreated CML in early chronic phase, which was a French study. It was a multicentric, open-label, single-arm trial, phase 4. They included almost 44 patients, used 260 milligrams per meter squared of imatinib. Complete hematological recovery was seen in 98% of patients. Cytological response at 1 year was 77%, and major molecular response was seen in 57% of the patients. They also escalated the dose to 360 milligrams per meter squared if any of the following criteria were met. Complete hematological response was not achieved at 3 months. Bone marrow contained more than 65% of pH-positive metaphases at 1 year. There was loss of complete cytological response or loss of major molecular response. Dose reductions were needed in children in terms of toxicity. They actually showed that complete hematological recovery was almost seen in 85% of patients at 3 years. Major molecular response was seen in 84% of patients, and almost 25% of the patients actually had imatinib failure. The various doses of TKI that have basically been used across the trials include imatinib being used from the range of 260 milligrams per meter squared to 340 milligrams per meter squared. Nilotinib is being used around 230 milligrams per meter squared. However, it's a BD dose, and dasatinib is used at 60 milligrams per meter squared. There is this trial which has been published in the British Journal of Hematology, which actually showed the long-term results of high-dose imatinib in children and adolescents with chronic myeloid leukemia and AML, which was an Italian experience. Complete cytological response was seen in 91% of patients. Major molecular response was seen in 78% of patients, and imatinib was very well tolerated in this subset of patients. Similarly, there is a trial which is known as the dasatinib trial, which was basically published in the JCO. They basically incorporated dasatinib into the treatment option in upfront, and as well as imatinib resistant and intolerant patients. A total of 113 patients were used. 14 of them were imatinib resistant or imatinib intolerant. 73% were newly diagnosed. At 12 years, in case of the resistant and intolerant group, the complete cytological response was seen in 76% of patients, and major molecular response was seen in 41% of patients. And in case of the newly diagnosed CML, where it was used upfront, the responses were much better. They did not see any side effects related to dasatinib in terms of pleural effusion or pericardial effusion or pulmonary edema. There's a phase 2 trial which basically used nilotinib in patients with CML. They used CML resistant and intolerant to imatinib or dasatinib. 33 patients were used, of them were resistant or intolerant. 25% of the patients were basically newly diagnosed. Again, in the intolerant group, major molecular response at 6 months was seen in 39% of patients, and complete cytological response was seen in 81% of patients. In terms of newly diagnosed, it was approximately around 64%. They did not note any major cardiovascular ischemic events in their subset of patients. So basically, if you're basically treating a patient with imatinib upfront and you're suspecting imatinib failure, there can basically be three causes. Either you're dealing with resistance, or you're dealing with intolerance, or you're dealing with poor adherence. If you're suspecting resistance, then you need to do the mutational profile. If no mutations have been found, then you can basically switch from imatinib to either a nilotinib or a dasatinib according to the various risk factors and the toxicity profile of each drug. In case there is mutation, you basically change to the second line TKI according to the mutation that is present there. In case you're dealing with intolerance, you switch to an alternative TKI based on the side effect of profile of those second line agents that are being used. And in case there is poor adherence, you continue imatinib and ensure compliance. In case you have a suboptimal response to imatinib, you watch and wait for next 3 months, and then you basically change to a second line TKI. However, if there is failure on second line TKI as well, you can take the patient for a transplant. And in case no donors are available, then you can use the experimental therapies, which can include using of a TKI that has not been used in case of a license for children, or a haplo stem cell transplant. The second algorithm is basically if you've used a second generation TKI upfront. Similarly, again, if you're suspecting failure, you need to look into resistance, intolerance, or poor adherence. In case of resistance, if there are no mutations present, you can change to an alternate TKI. In case of mutations, treat according to the mutation that is present. In case of intolerance, switch to the next TKI that is available. And poor adherence, you basically continue the same TKI and ensure compliance. In case of suboptimal responses, again, if you use second generation TKIs upfront, you again wait for 3 months and then reassess for response again. Again, if you have a failure of second line TKIs, you either do a stem cell transplant, and if no donors are available, you can again go for an experimental TKI or a haploidentical stem cell transplant. So these are the three drugs that are available in our toolkit. This is imatinib, which was approved for pediatric in 2003. Dasatinib was approved in 2017, and nilotinib was approved in 2018. The doses have been used 340 milligrams per meter square once a day with food. Important in case of children. Dasatinib 60 milligrams per meter square again with food, and nilotinib 230 milligrams per meter square twice a day. But food needs to be avoided for some time. In terms of cost, we all know imatinib is the cheapest, and then dasatinib and nilotinib are expensive, so can be used in patients where financial constraints are not there. Coming on to side effects, which is actually very important when it comes to TKI. In terms of imatinib, the very important side effects that we're bothered about is hematological side effects, which can be anemia, thrombocytopenia, musculoskeletal pains. There's a characteristic rash. Long term, it has delayed puberty, it has long-term effects on delayed bone growth and endocrine side effects. Dasatinib, we all know, we're more worried about the pleural, pericardial effusions and pulmonary edema. In case of nilotinib, it tends to cause liver dysfunction, and also it is cardiotoxic and tends to cause QT prolongations. So coming on to the criteria that are basically being used in children to define response to TKI therapies, complete hematological response refers to no signs and symptoms of disease with disappearance of a palpable spleen, complete normalization of the blood counts, absence of immature cells in the peripheral blood, and a platelet count that is recovered. The cytological response is basically classified into complete cytological response, where no pH positive metaphases are being found. Partial is between 1 to 35, and minor is where you have more than 35. Coming on to major molecular response, it basically refers to no detectable BCR ABL mRNA by an RT-PCR. Relapse is when any signs of the loss of a response take place, either hematological or cytogenetic, or there is an increase in 1 log increase in BCR ABL. As you can clearly see, it's color-coded, and these are the NCCN guidelines. So green is basically where you have a TKI-sensitive disease. So if you have a BCR-ABL which is less than 0.1% at any point of time, it is basically green, so you do not need to worry. If you're dealing with something which is light green, that is, if you have a BCR-ABL more than 0.1% at 1 year, you basically are dealing with a TKI-sensitive disease. The yellow is where you're basically dealing with a possible TKI resistance, which basically is if you have a BCR-ABL more than 10% at 3 months, or a BCR-ABL more than, BCR-ABL more than 10% at 3 months, or a BCR-ABL greater than 1 to 10% at 1 year.
Again, as you can clearly see, the milestones are 3 months, 6 months, and 1 year. If you're dealing with an optimal response, your BCR-ABL at 3 months should be less than 10%, BCR-ABL at 6 months should be less than 1%, and BCR-ABL less than 0.01% is something that will indicate an optimal response to you. Warning is if you basically have a BCR-ABL at 3 months, which is more than 10%, or a BCR-ABL between 1 to 10% at 6 months, and a BCR-ABL more than 0.1% to 1% at 1 year. So when do we do basically the mutational analysis? Primary resistance to TKI in patients with uncomplicated CML-CP is rare. Hence, routine testing for mutations is not required at diagnosis or those with an optimal response to TKI. Approximately around 24 to 30% of the patients actually are diagnosed with these mutations in the advanced phase of the disease. NCCN recommends that mutation testing should be done in chronic phase only if there's a failure to reach the required milestones, or there is any loss of response, either defined in terms of hematological or cytological response, or there's a 1 log increase in the BCR-ABL transcript, or loss of major molecular response, or if there's a disease progression to an accelerated phase or a blast phase. Again, the ELN guidelines basically say that you do the analysis if patients present with failure or progression to an accelerated phase or a blast phase. And the IBFM-CML committee basically responds to the mutational analysis if you have a treatment failure or a suboptimal response. So these are the various mutations that are basically being seen in terms of CML. So this is another study which basically, which is the dialogue study. It basically studied the effect of nilotinib in pediatric CML patients. They basically subdivided it in 2 groups. One was the resistant to or intolerant to imatinib or dasatinib, and the other was the newly diagnosed patients. They gave nilotinib at a dose of 230 milligrams per meter square twice a day for 66 cycles of 28 days each. As you can clearly see in the previous picture, the intolerant group basically had a major molecular response of 68%. The MR4 log was to the tune of around 30%. So, however, in terms of newly diagnosed patients, the responses were much, much better. So another important thing that when it comes to pediatrics, as seen in adults, is when can we stop TKIs? There are a lot of trials which have basically been done in adults, which is basically the Stop Imatinib trial, the Twister trial, the eNest Freedom trial, the Euroski trial, which have basically actually thought about discontinuing TKIs. The important criteria for discontinuation has been undetectable levels of transcript for more than 2 years, and utilization of imatinib, and in the recent trials of nilotinib and dasatinib for more than 3 years. But these are mostly trials which are basically used in adults, and they've actually shown that treatment-free remission is basically, we've seen in almost 50 to 60 to 70% of the patients that were basically discontinued. We have this discontinuation of imatinib in chronic myeloid leukemia, which was a study which was done by the Frederick et al. Group. They actually had 18 patients, where they basically tried this. The main criteria were they should have been on an imatinib for 3 years, and they should have been in deep molecular response for 2 years. Loss of MMR was basically seen in 7 out of the 18 patients at 4.5 months, and TKI basically needed to be restarted. And once the TKI was restarted, they kind of achieved the deep molecular response in 6 out of the 7 patients. There is this another trial, which is the STKI trial, which is again one of the most important trials for stopping of imatinib in pediatric patients in CML and chronic myeloid leukemias. They actually showed that it was a multicentric trial. Again, the criteria were that you need to be on a TKI for more than 3 years. There needed to be a sustained molecular response to the log of 4 for more than 2 years. They actually had 11 patients who actually were started and experienced basically a molecular relapse and needed to be restarted on TKI almost around 3 months after the discontinuation of TKIs. No progression was later on seen in these patients once they were restarted. It is basically a gray area in case of pediatrics. There's this another trial which actually showed the discontinuation of imatinib in children with chronic myeloid leukemia, which is the Stop Imatinib trial. They enrolled 14 patients. 10 patients among them actually relapsed once the treatment was discontinued. There is a large prospective trial which has been planned by the COG group for supporting imatinib, and I think it's nearly completed, but I think the results are awaited. I could not find the results anywhere. There is another interesting concept, which is basically use of intermittent doses of imatinib. They actually used an intermittent scheduling where imatinib was given at the dose of 340 milligrams per meter square, 3 weeks on and 1 week off in CML patients less than 18 years of age. The aim was to decrease the long-term side effects and improve compliance to treatment. They basically classified them into 3 groups, and what they basically found was that imatinib intermediate scheduling of 3 weeks on and 1 week off was an effective strategy before stopping imatinib in children. It was capable of improving the molecular responses in patients with poor compliance and to reduce the imatinib-related adverse side effects. Various trials have basically been published which have actually showed the various side effects of imatinib and other TKIs. There is this trial of growth deceleration in children with imatinib and for treatment of chronic myeloid leukemia. There is this Jim et al. Trial which actually recognized the various endocrine pathways that were associated with TKIs. Dr. Deepak has actually come up with a study which has shown the adverse effects of imatinib on the growth of children with chronic myeloid leukemia. Interesting to note that they saw that the effect of growth retardation was more pronounced in prepubertal children as compared to the adolescents and the pubertal children. So coming on to the recommendations for the endocrine toxicities in children and adolescents with CML on TKI, the various side effects that actually take place affect the growth. They can cause growth retardation. They can affect the bone mineral densities. Hypo and hypothyroidism is known. Gonadal dysfunction in terms of delayed puberty, gonadal dysfunction, and potentially decrease in fertility has been established. And pregnancy outcomes in terms of having fetal abnormalities has been noted with the nose of TKIs. The chart clearly indicates which tests and at what point of time they need to be done. So coming on to the bone marrow transplant for CML chronic phase may have a bigger role to play in children as compared to that of adults. Before TKIs, allogeneic bone marrow transplant was the only curative option for pediatric CML, and it still remains the only established cure, especially for avoiding the long-term TKI therapy. As previously mentioned, pediatric CML biology differs from that of adults, making the adult criteria inadequate and keeping bone marrow transplant relevant, especially with improving reduced toxicity regimes and decreasing TRM. The indication of bone marrow transplant in children in today's world include a TKI failure, a disease progression on TKI, or a CML blast phase. Better prognostic markers need to be identified for who do not do well on long-term TKIs, as reduced toxicity sibling match may be available, which can have a long-term effect in terms of long-term cure. These are the various trials that have actually shown the role of hematopoietic stem cell transplant in CML. And as you can clearly see, the overall survival has basically ranged from the tune of around 50% to almost around 75%. Coming on to the Indian scenario, the disease monitoring is always a no-go area and is very critical and crucial in predicting outcomes through appropriate modification of therapy. Lack of timely PCR testing is noted in 15 to 20% of the studies in the West, and in our country, the numbers are going to be definitely much higher. There's a lack of standardization for the available lab tests, as well as the testing facilities across the country, and high cost and non-availability of tests is also an important concern. To add to the complexity of consideration of discontinuing imatinib, the cost of monitoring with frequent PCRs may actually exceed the expenses of genetic imatinib in India. As clearly told you, in the pre-TKI era, allogeneic stem cell transplant was and is the curative treatment for CML. And in the post-TKI era, the indications include lifelong TKI treatment, side effects because of TKIs, and post-transplant survival is much better as compared to that of adults. These are the various indications in chronic phase: the failure to respond to 3 TKIs, the presence of the T3151 mutation, and the high-risk cytogenetic factors, or the presence of recurrent severe cytopenias in children who are basically given the treatment for CML. In advanced phases, if there is a suboptimal response to the frontline TKIs or any progression to the blast phase or the accelerated phase. Role of stem cell transplantation is arguable, however, in patients where there is a question of poor compliance, because compliance is also necessary in case of stem cell transplantation in terms of GVA risk prophylaxis that has to be used later on. Also, patient preference for which modality of treatment he actually wants to have also plays a very important role. Take-home messages are: CML in children is challenging, data in case of pediatric population is limited, and most of the studies are extrapolated from adults. The definition and monitoring criteria need to be adhered to. The first choice of TKI should be thoughtful and individualized.
Accelerated phase TKI is still a choice. Blast phase TKI with or without chemotherapy is debatable. And in the blast phase, a transplant with a suitable donor is a very good option. Thank you so much for a patient hearing.
Thank you very much, Faisal. So, any thoughts of the house on using second generation TKIs upfront? Anuj.
Thank you, doctor. And as rightly presented, it's not there cannot be a single treatment modality for every patient. So we need to take into account the availability, access, and adverse effects of the TKI. I will say till now, first generation TKI is sufficient, and if the patient is at the 3 months more than 10% PCR levels, then we can consider switching to second generation by doing a tyrosine kinase.
So the reason I'm saying this is because our adult colleagues they use these fancy medicines upfront. So is there a data to say a second generation TKI works better in pediatric CML?
So second generation will achieve a faster and deeper remission.
Correct.
But that can help in achieving a TFR. So we have to see what is our goal post. I was actually about to ask, is this the time we should change the goal post of CML treatment from survival to TFR? TFR should be our treatment-free remission period should be our main goal. That can be theoretically better achieved with second generation TKI. So there are studies from adults which have compared TFRs and then they look back which TKI the patient was on. If the patient is on second generation TKI, they have better TFRs because they achieve MR4.
Once we have the result of that COG trial, we'll come to know whether we can stop these medicines, whether we can stop imatinib or whatever TKI they were using and see how those patients behave.
And
Definitely.
I think, sorry, please. I think it's also important right now we're in that gray area where we don't know where can we stop it or we can't stop it. But when we come to like adolescents and younger where they're kind of planning pregnancy or you're planning anything, that is probably an area where we can comfortably kind of stop it for some time, see for the response, let them have the pregnancy and then probably see the response and decide what can be done.
Definitely. So one large study I think which was published this year only from TMH was stopping TKI in pediatric patients. They stopped TKI in 45 patients actually. That is one of the largest till now. And the TFRs were almost 60%.
Wow.
And those patients who failed stopping TKI, if we start the same TKI, they usually respond. So they do not develop resistance actually.
And were the subset of patients on imatinib or?
So majority on imatinib. But they were on imatinib for like more than a decade, 8 years, 10 years and like this. But in our country, we have to ensure follow-up. So we do not want the patient to come back with a hyperleukocytosis and splenomegaly.
So has anybody in the house encountered an issue when people are asking a pediatric CML patient's family asking you, should we offer transplant to them? Why don't we do a transplant? Because otherwise they have to take the medicine for the rest of their life. So has anybody from the house encountered a situation like this? Shilpa, Prachi? Not yet.
Not yet.
Yeah. No, sir, not yet.
So we had two patients. I remember a patient who came to us from Medanta. He was started on TKI. A boy, 16-year-old boy, CML in chronic phase, started on imatinib. The family wanted a permanent cure. Family said that we will not take TKI. We wanted to get a transplant done. We have spoken to the doctors in Medanta. The doctors in Medanta says that better you take TKI rather than going for a stuff like transplant in which you can have a 10%, 20% risk of mortality. The family came to us. We also counseled in a similar way. They said that we don't want to take this medicine. The boy stopped. The boy stopped taking the medicine. We took the patient for a transplant. By God's grace, it's been 8 years. He's doing well. A similar sort of situation has come to us recently. A patient who has come to us from Iraq and says that, doc, we cannot, a very well-educated family, doc, we cannot have a standard of care what you people give in India back home in Iraq. We don't have good labs. We cannot get our BCR-ABL checked every 3 months. Why don't you do a transplant for this boy? He's been having pain. He's been having, after imatinib, the boy was having bad pains. We started him on calcium supplements. The pain was not improving. Eventually, we counseled, we shifted him to dasatinib, and by God's grace, 3 months later, his BCR-ABL is 2%. So he's responding, and then this family agreed that we will not go ahead for transplant, and will continue TCAP. But just wanted to understand from the house whether you people have also encountered a situation like this or not.
I think adolescence is a very tricky group where compliance eventually becomes an issue. So I think if the group, and also over a period of time, transplant has become, the outcomes have become so good and the mortalities come down. So maybe probably a few years down the line, maybe this is something that we offer to that subset of patients.
Fantastic. Thank you, Faisal.
Thank you so much.
A big round of applause, please.
Thank you so much, Doctor. And now we have, the next is the flow cytometry for pediatric hematologists in 2025, which is chaired by Dr. Astha Gupta. Can we have Dr. Astha Gupta on stage, please? Thank you. Please, a round of applause for her.
Good afternoon, everyone. So let's change the gears from therapeutics to diagnostics. And for this, I would like to invite my teacher, my mentor, and a friend, Dr. Jasmita, who is Associate Professor at All India Institute of Medical Sciences. And she's a great hematopathologist known for her exemplary work in flow cytometry. Over to you, ma'am.
Good afternoon, everybody. And I see a lot of people here who are interested in malignant hematology. Would you raise hands for benign as well? How many? Okay, great. So the second half of my talk is for all of you interested in benign, and the first half is about malignancies. So you're all familiar with this technique, and all of you are treating patients day in, day out. So essentially, flow cytometry is that we analyze cells while they are flowing. So what we need is essentially an instrument with reagents, analysis software, and we require expertise in analysis, for which you have lab colleagues like me, Astha, Surabhi sitting here, and maybe others as well. But what about solid tissues? Can you really flow solid tissues? How many of you have tried? You have a paraspinal mass, no blasts in the peripheral blood. Can you do a paraspinal mass biopsy and flow it? The answer is yes. So as long as you can agitate, mince the cells, get them to flow in a liquid state, you can. So for that, essentially for flow, you just need a liquid sample. So when we look at the applications that you have in malignant hematology, this is one that we are very familiar with, the lineage assignment of any new acute leukemia patient. And this is what we do day in, day out. However, you also get clues to underlying genetic anomalies. So here on the top are examples of the MLL or the KMT2A rearranged AML, which is 19 and 10, which is 34 positive but 10 negative. And you have some amount of 15 expression. Can anybody tell me if 19 and 371 both are positive, which translocation should we be looking for? That is the DUX4 rearranged ALL. Now this is something, if you're not sending NGS for all your patients at diagnosis, you will miss. But if you talk to your lab colleague and ask them to incorporate 371 and CD2 in their panel, they will pick up this abnormality as well. And on the right, you have the TSLPR, which is one of the clues for CRLF2 rearranged pH like BLL. When we talk about other things, very frequently nowadays we receive a request, we want to know whether our patient is CD22 positive or not. So one is how to identify patients, whether you can use certain targeted therapies in them or not. So for this, flow is something that comes to your rescue. And how often have you experienced culture failure rates in BLL? Cytogenetics? Frequently, right? So ploidy is another thing that you can analyze on flow cytometry. So this is an example where you have green being the lymphocyte value and the red is the blast. So you have a DNA index of 1.4. That clearly tells you that your patient is hyperdiploid. Now this is something which has come of age in the last 15 years or so. So measurable residual disease analysis is again something that helps you guide your therapy post giving a patient intensive induction and consolidation therapy. In addition, we are extensively using flow to monitor our leukemia patients for CNS disease. So this was a part of a thesis at our center, but we've sort of continued it post the thesis also. Your detection rates will be at least 2 times that of the cytospin preps. And for those people who don't have cytospin in-house, this becomes a very useful technique. Otherwise, you're going to miss a lot of CNS involvement. And I think I have faced this situation multiple times, that something which looks like single cells in the marrow is not an acute leukemia, but maybe a neuroblastoma spill or an Ewing sarcoma spill. So this flow clearly highlights the 56 positive neuroblastoma. So even with our regular markers, sometimes it gives us clues that we're looking at maybe a solid malignancy. Now the other thing where it helps is when we have reactive lymphocytosis versus an acute leukemia, or hematogone hyperplasia versus blasts. And this is another indication. Usually, pleural fluid is positive in many TALLs, sometimes in BALLs, but here we had a case of Burkitt lymphoma that was involving the pleural fluid, and there are certain clues which we have. Similarly, in adolescent age group, you can have patients with hepatosplenomegaly where HSTCL forms a differential of the TALL cases that you have. So with the kind of immunotherapy that you guys are using now, the lab colleagues' life has become difficult because suddenly, the 19 positive MRD can't be assessed because blinatumomab CAR T cell therapy has been used. And the same thing will happen with inotuzumab as well with loss of CD22. So that makes our life difficult and it sort of forces us to think of better strategies to monitor the disease by flow cytometry. That leads to expansion of panels and also the discovery of new populations. So something like stage 0 hematogones was discovered post the panel expansion and when people tried to incorporate 22 and 24 because otherwise these stage 0 hematogones are CD19 negative. So you guys force us to read every day and we enjoy it. Now the next part of the frontier is your CAR T therapy. So you look at the CAR T cells, and this is from a review, you practically would like to assess the T cell population before you give it for expansion, during the expansion, then you would like to monitor the CAR T constructs. So flow comes to your rescue at many points in the course of CAR T therapy. So if you look at this paper, they tried to detect the CAR T cell expansion and they realized that the maximum expansion was noted between day 7 to day 11 and then it sort of declined till day 20. Now, if you want to do that, then you have to prepare your lab in advance. You have to talk to your lab colleague, ask them to order the reagents. Otherwise, you will want something, but they will not have the capacity to deliver it on time. So I think this is one specialty where a two-way dialogue is very, very helpful. You can also monitor the immune subsets post-CAR T therapy, even post-hematopoietic stem cell transplants. And these are examples of the classical 19 positive CAR T where you see a depletion of the cells and then the slow reconstitution over a period of time. Interestingly, we're going to see it even more with the 7 positive CARs when they come in. So interesting part is that our body knows how to evade things. So our normal T cells, they tend to downregulate their 7 because there is a CAR T which is directed against CD7. So that is what is shown in this comparison. And if you look at what are the different T cell patterns till now, or actually with pediatrics, at least for your immunology patients, you would be doing a lot of T subsets beyond the 4 and the 8. So all of them you realize do reduce except for the T effector memory cells, which stay well in the CAR T therapy. Another thing that you want your lab colleagues to monitor for is B cell aplasia if you've given CAR T cells. And you will have to act on loss of B cell aplasia, especially if it occurs early. So again, this is something which is good if you talk to them and tell them that this is our indication, this is what we have given. You can also use flow cytometry to monitor the T cell exhaustion patterns on the CAR T cells. And if you have exhausted T cells after, I think around 5 months or so, the patients, they tend to do better. And now we'll switch gears to benign hematology. Can anybody tell me the diagnosis here? So you have a history, you have a peripheral smear picture. HS, perfect. So classical HS, do you really need anything here? If I give you the family history that the patient's mother is also was symptomatic, you will tell me I don't need any further workup. But will your patient be satisfied? So here again, we can do flow cytometry. So these are 2 tests that we have done earlier, and you can also refer your patients for them, especially if you find doing an incubated osmotic fragility test very, very challenging or long, or it is not available in your lab. Plus, remember that incubated OFTs will miss 20% of your patients of HS. So if you look at this graph on the left, this is EMA dye binding test, very easy to set up. Your lab can batch the test. The only problem that the lab faces is in finding the controls to run this test. So regardless of whatever mutation is there on the red cells, the band 3 protein is always downregulated. So that is the whole mechanism. EMA binds to the band 3 protein. So if the band 3 protein is low, the expression reduces. On the right, you see a test called as flow cytometric OFT. What does this test need? Just a blood sample, distilled water, and normal saline. That's it. No antibody, nothing. So it is a dirt cheap test. The only challenge is again that it has to be done right on the same day that you collect your samples. So you take a dilution of red cells, load it on your flow cytometer, and then you spike it with distilled water. So the minute you spike it, the cells will start lysing, and the rate of lysis will obviously be far more in a case of hereditary spherocytosis than any other hemolytic anemia that you're dealing with besides AIHA. So these are two interesting tests and they're very rewarding when you do them in your laboratory. Not very difficult to set up either. Now, interestingly, CDA is one more diagnosis which becomes difficult, and it was more difficult before you had NGS available and before you could pick up the mutations easily. So you have one clue on the EMA. So if you look at this plot here, HS, the EMA fluorescence reduces considerably. In CDA, the fluorescence fall is relatively lower, but there are other antigens that can be used, such as an absence of CD44 on the red cells. That gives you a clue that you're looking at CDA. And if you look at CD71, it's an interesting marker because 71 is a marker of reticulocytes. It is not positive in the mature red cells. So if your CD71 positive cells, you can identify. So somebody who's using eculizumab for their patients or any other complement inhibitor, is anybody using it here? Yes? Great. So you're using it, Arun, great. But so if you want to monitor how it is responding, so the WBC clones, so RBC clones you can monitor using 71. What it will tell you is what is the PNH clone in the reticulocytes rather than just the entire red cell population. Now we come to another problem. So this is a 5-year-old male. You have the history here, presentation in the month of November. The smear findings are also here. This is one thing where you want us to usually give you a diagnosis early. So what about these cells here? Bites, blisters. So you have a case of possible G6PD deficiency, and in our country with the naphthalene ball exposure that happens in the winters, G6PD susceptible children may actually hemolyze. So this is a patient of G6PD deficiency. In an acute phase of hemolysis, will you send the quantitative G6PD levels? Acute phase of hemolysis, will you send the levels? No. Or you may send, and if you say that the values are towards the lower limit of normal, then maybe the child still has G6PD deficiency, but you will not know that. So we set up an assay where, and I'm sorry for the slides, I think the version of Office here is cute. So we set up an assay, again a very simple assay, because you essentially treat the cells with sodium nitrite. So your cells, hemoglobin converts to methemoglobin. Now in the presence of G6PD, it will be converted back to hemoglobin. If you use potassium cyanide, the hemoglobin molecule becomes a feral compound and that emits fluorescence. So again, no antibody, nothing, but just fast processing. So a normal individual will show you a nice positive peak because the methemoglobin was converted back to hemoglobin. However, when your patients are deficient, you will either have a complete absence or you will have some positive populations here. So this is an example of a borderline deficient case, and this is an example of females. So detecting carrier females has always proved to be a challenge in G6PD vis-a-vis any test that you use. So this test can come to your rescue because it can identify carrier females with G6PD deficient populations as well. And now comes the inborn errors of immunity, and I'm sure all of you would be getting these patients, and this is still an iceberg because we are recognizing very few cases in comparison to what the burden may be. In fact, many of your lymphoma patients may actually have an IAI sitting there. Many of our acute leukemia patients will have an IAI or will have an underlying germline predisposition disorder as well. So I don't need to remind you of the warning signs. And SCID was the prototype which was used for detection on flow. And the pattern, whether T cells, B cells, both are absent, NK are present, or otherwise can give you clues to distinct genetic disorders in the different IEIs. So instead of just, so this is something which will be available on a TB, NK, 6-color kind of a panel. However, we have to move and we have to now detect different subpopulations for which there are extended panels and extended tubes. So I think we should move away from doing a basic TB, NK, cytotoxic helper T cell panel to advanced panels where we enumerate the subpopulations of T cells, be it the memory T cells or the TEMRA cells or the T regulatory cells. Now, these are two examples of phagocytic defects which can be very easily picked up on flow. So you have on the left a patient of leukocyte adhesion defect. You assess for CD11, B11C, AT, neither one of the antigens. If that is reduced on the neutrophils, you clearly have an answer. On the right, you have a classical history of chronic granulomatous disease. And in this case, the oxidative burst in the neutrophils is absent. So upon PMA stimulation also, the DHR is not converted to rhodamine, so there is no fluorescence in the panel. And this is a very easy test again to set up. And it also tells you whether your CGD is X-linked or not. Assess the mother will show 2 peaks. And many of your IAIs, some of them are X-linked and you can use this, such as even an X-linked Bruton's A gamma globulinemia. Another situation where flow helps is this kind of a situation where your patient has intractable generalized lymphadenopathy, hepatosplenomegaly. To us in hematology, it comes mostly as patients have certain kind of an autoimmune cytopenia, be it thrombocytopenia or a DCT positive AIHA. You assess for the TCR alpha beta positive 4-8 negative T cells, the DNTs as they are called. Now, most of the DNTs in our body are actually gamma delta T cells. However, in this, it is the alpha beta T cell expansion. So this compartment is what we look at. And this patient had a mutation in the FAS, and that was essentially a case of ALPS. Now, what about the same situation, but this time the patient has this finding on the barrow and the patient is quite toxic looking, is sick, is admitted in the ward. Tell me, what is it that you ask us to look for? Perforin, yes. So what you're looking at is hemophagocytosis, right? So next question is the lab tests. Yes, they are compatible with hemophagocytosis. Perforin is the right answer. You can assess for perforin in this patient using flow cytometry, and perforin you have to permeabilize the cells. So the assay is a little tricky to standardize, but it can be done. You have to assess the NK cells, and normal CD4 positive cells do not have perforin, so they act as an internal negative control. Now, how many of you have faced this dilemma, sepsis versus HLH? Is my patient just having a bad infection or is there full-blown hemophagocytosis? Have you struggled with it? Two of us, right? So, Chaturvedi et al. Came up with this paper, a nice paper where they demonstrated that if you have the CD8 positive T cells, which are showing this activation phenotype, 38 positivity and HLA-DR positivity, at more than 7%, that tells you that your patient has HLH. So this is something again that is possible, easily possible, as long as you want to talk to your lab colleagues. Now the same expansion is also seen in the 4 positive subset, but the 8 positive one worked better. So they talked about that. Now this will be, I think, the last case that I'm going to show you. Now this 2-year-old child had this history of bleeding. Essentially, the complaint that she came to my department was primarily bleeding and they wanted a platelet aggregometry done. So we did an aggregometry and we realized that all the agonists show an absent aggregation. Ristocetin, the aggregation starts and then it sort of dissipates. So everything else looks abnormal. So classical pattern that this aggregometry shows us is that of Glanzmann's thrombasthenia. So we ran the flow for platelet antigens, and this is again something that is easily doable. So on the platelet antigen flow, you realize that the antigens for Bernard-Soulier, that is 41A, 41B, are normal. 42A, 42B are normal, while CD61 and 41, the GT2B3A antigens, they are absent. So should I sign this case out as a GT? Not type 3, but type 1. But then the patient has neutrophilic leukocytosis and has delayed cord suppression, separation. So this patient was a LAD type 3 and was FERM3T3 mutated. So this is the other thing that I want to set up maybe in my lab in the next year. That is to assess platelet function by flow cytometry. How many of us have faced a situation where we refer a sample or we refer a patient for aggregometry, the platelet count is 9,000, 10,000, they are unable to run it, right? So this is another assay that can be set up. And this is on the left, a patient of GT. The 2B3A molecule, it undergoes a conformational change when their platelets are activated. So if this conformational change can be detected by an antibody, then you know whether the conformational change happened or it did not. So this is a patient of GT in which when you stimulate with convulsin, which is similar to collagen, you see no PAC expression. And the dense granule defect where Again, one more very difficult defect to pick up, because aggregation patterns are inconsistent. You will not have access to transmission electron microscopy. And for all the lovers of NGS sitting here, if you refer your bleeding patient without any phenotypic positivity for NGS, you are rarely going to recover anything out of it. So be wary of that count. So in this case, once the dense granules, they express their antigens out, the platelet starts expressing CD63 on its surface. So the missing 63 tells you that there is a dense granule defects. Now what the future holds for flow is that the number of colors is increasing. When I started, it used to be 6 color, 8 color. Now we are at 12, 18 in the clinical use, and much more in the research use. The data analysis is going to become increasingly complex. And as we increase colors, we have to worry about compensation. That is not your worry, but you have to understand that indirectly it is. Because sometimes a badly compensated experiment may show up populations that don't exist and are not physiological or even pathological. So we'll see a shift from conventional to spectral flow cytometry soonish. So spectral is essentially you use diffraction gating array and you resolve many, many more colors. What practically it means is that instead of the 12 or 14 detectors that you're going to have, you can have up to 80 or even 180 detectors. And jitna gud utna meetha hai, so when this comes in, the cost of the assay is going to go up. So keep that in mind when you want to push your lab colleagues to get an equipment like this. You will see more and more figures, and I'm sure that you would have started seeing them in the published literature, where you have these supervised and unsupervised gating algorithms and these kind of plots, be it the SPADE or FlowSOM. And you will also have possibility of AI or automated analysis. Keep in mind that most of these analyses will be correct only 80 to 85% of the time at the best possible performance. So key takeaways are that we are actually underutilizing flow. The applications are vast. For acute leukemias, any point that you want to look at will be done by flow. CAR-T, you really needed to monitor both the immune reconstitution and the CAR-T persistence. For IEI diagnosis, as I said, we need to move away from just a 6-color TB-NK subset. It is an important tool for hemolytic anemias as long as we want to exploit it. For bleeding disorders, both antigens and platelet function. And we will see spectral flow, AI/ML-based analytic modules, and high dimensionality data analytics in the future. With that, I would like to thank you and thank my team. I'm open for questions if you have some for me.
Thank you very much, Jasmita. I think the fantastic time is going to come on the lab side as well. So Astha, your thoughts?
Thank you, ma'am, for such a wonderful and juicy talk. I have one question, that for those flow OFT and G6PD based test, how soon a sample should be processed? I mean, is there any number of hours within which we should process the sample? Is there any?
So for flow OFT, it will be good if you process the sample within 4 hours. The challenge with any of these tests, be it EMA or flow, is finding out the controls, because in a normal lab, you don't get samples which are coming to you, and you cannot ask the patients ki aapka attendant sample dega, or you bring somebody, which is possible in my setup, but it is not in yours. So that becomes a slight challenge. But other than that, if you, as long as flow OFT, you process the sample within 4 hours, you're good to go.
Thank you.
Any other questions? Anyone?
Yeah, sure.
Yeah, sorry, in terms of processing the sample within 4 hours, that is basically possible in places and centers where basically labs are close by.
Yeah,
so we basically have to send our sample from Kashmir to Delhi, which technically takes around.
Faisal, I'll give you the alternate for that.
Yeah.
So if you're sending the sample out from Kashmir to any lab and you want a diagnosis of HS, so that's your consideration, don't send out the flow OFT. You send it for EMA instead. So EMA samples, the sample is stable for 7 days. It has to be refrigerated and it is stable. It is good if you send at least one shipping control along with your sample, so that at least one other sample should be there to assess it. That cannot obviously be the parents or the sibling. So anybody unrelated can give a sample. So at least that gives you a check that nothing happened badly on the transport side.
So one more question. Any role of apoptotic studies? Can we do that on flow cytometry? Because that's a one domain of targeted therapy which is coming up.
So again, the assays are available. They can be set up. But having assays on apoptosis, if you want certain controls for that, sometimes you need cell lines. So maintaining those cell lines becomes tricky in a diagnostic lab. It can be done in a research-based setting, absolutely. In a classic laboratory-based setting, simple assays such as just the annexin expression or the propedium iodide, that can be done. Beyond that, it becomes difficult for a flow cytometry lab handling 20 samples a day to do other assays like apoptosis, because they have to do the entire setup of compensation on the same day for the apoptotic studies.
Thank you.
Thank you so much, Dr. Jasmita Das. And can we have a round of applause for her, please? Okay, ladies and gentlemen, so this is lunchtime, and this is your time to recharge scientifically and socially both. I would request everyone to be back as soon as possible. Thank you so much and enjoy the feast. We will join in half an hour, yes, for sure. So it is 1:30, so everyone please be back by 2. Thank you.
वो बच्चा है यार.
Welcome back, everyone. I would request everyone to please settle down. Your friends, your colleagues, your doctors, whosoever is outside, you may call them in. Okay, we resume with Locking in the Cure, presented by Dr. S.P. Yadav. He is Director Pediatric Hematology at Medanta Hospital, Gurugram. Because if Cure had padlocks, he would definitely have the key. So he's going to talk about post-HSCT maintenance. So can we have Dr. S.P. Yadav on stage, please? Can we have a round of applause? Now I guess everyone had a good feast. Thank you. Welcome, sir.
Thank you, Vikas, and thank you, Rahul, and all the team members. It's not just two people's effort. I can see a lot of youngsters who are with them. All have made a great conference, highly successful one. I can see a lot of people, houses are full, and all are excited to learn, which is the most important thing. And it's a pleasure to be here today. And the talk, I think they're just loading it. Yeah, so that's the topic, locking in cure, post bone marrow transplant maintenance strategy. So Vikas always chooses very difficult topics as he's very connected to the real issues of transplant and hematology. So always find the best topics which are like burning topics and people are interested. So that's what he has asked me to speak on. So before we take in locking in cure, we'll go back a little bit in history. So acute lymphatic leukemia, as we all know, like in the beginning in 1950s and 60s, the survival rates were about 20% with oral methotrexate and 6-MP, those sort of medications. Almost everyone relapsed. So relapse was the main problem. So locking in cure is, from that era, people are trying that cure should be fixed, that okay, patient don't relapse. That's the goal in leukemia. Then came Sir Don Thomas. He got Nobel Prize in Medicine when he transplanted leukemia patients, ALL patients, and he could save 18% of them, cure them with bone marrow transplant. If today I tell someone that my survival rate is 18%, they will say, oh, this is rubbish, this is useless. But he got Nobel Prize. Why? Because there are a lot of hidden messages in that work. One, he showed that ALL, we all thought is cancer, just give chemotherapy and kill the cancer and we can cure the cancer. He showed that when chemotherapy is not working,
immunotherapy works, that the donor cells bring a new immune system and that can finish the leukemia and cure. But relapse was still a problem in that era. That was 1970s. So quite a number of them relapsed, but he could cure some. So he showed the proof of the principle that the donor immune system can clear the cancer and cure. Then came Leo Luznik in early 2004, 2005, John Hopkins. He got multiply relapsed leukemia cases who had even had one bone marrow transplant before, and there were nothing more to offer. They were mostly palliative. So he offered them a bone marrow transplant, haploidentical, with hardly any conditioning. Fludarabine, cyclophosphamide, very low dose, and 2 gray TBI. And with that, he put in a graft, and he could cure nearly 40 to 50% of the patients were cured. They were like those in CR2, CR3 or beyond. So such patients, previously, historically, outcomes were almost like less than 10%. But it was a magical thing to attribute to haplotransplant with PTCY platform, that graft versus leukemia effect was there, and that cured those patients who were multiple relapse. So it proves two things. Chemotherapy helps reduce the disease burden, but eventually to clear the leukemia, you need a functional immune system, either your own or someone else's, who clears the last bit of leukemia. So if we can perfect this concept, we will lock in the cure and no one will relapse. That's the crux of the understanding we all are here for. So how to prevent the relapse after transplant? The first thing is, if it's an ALL, AML, CML, JMML, you always try to do an NGS sequencing to see if any target is available, and you can give a targeted drug. So TKIs are there, FLT3 inhibitors are there, IDH1, 2 inhibitors are there, and if on flow there is CD20, then rituximab is there, CD30, then brentuximab is there. So there are various CD19, you have Blincyto, there are a lot of monoclonal antibodies which can be given. So all these things are available. CD33, you have an antibody against CD33 also. So all these things are available. Now, how to use them, where to use them, when to use them, before transplant, after transplant, as a bridge to transplant, those are the questions or algorithms which haven't been worked out very nicely at this point of time. But you should always look for these targets so that you are ready when you are taking a patient for treatment, and then you decide how you want to go about it, and do you want to use that target as a part of your treatment algorithm or not. And combining your targeted therapy with the chemotherapy, is it safe or not? That's the second thing which comes to your mind. So in terms of TKIs, so TKIs in CML in the adult world or pH positive ALL, it's very common that after transplant, most patients are put on maintenance. But the data is controversial, whether this 1 year or 2 year maintenance is useful, do they really reduce the relapses or not? The data is not, there is no RCT to prove head to head that those who are given, those who are not given, what is the benefit. So it is still individual practice, what people do. Most people tend to give a maintenance for a year, especially in ALL, pH positive ALL, if there's a TKI which is working after transplant, at least for a year. Then FLT3 inhibitors, the only data is there for sorafenib, where there was an RCT done in an arm where sorafenib was given, in the other arm it was not given after transplant as a maintenance therapy, and there was improved event-free survival with sorafenib as a maintenance therapy in AML with FLT3 positivity. So that is sort of expected that you can use sorafenib. There is a proven data there. And the newer FLT3 inhibitors, the data is coming. It's not that it's not there, but data is being generated. So many centers are putting on the newer FLT3 inhibitors, especially high-risk AML with FLT3 inhibitors after transplant. Then comes CD20. So CD20, you will say, why this as a maintenance strategy? So I'm not saying this is a maintenance strategy. I'll just tell you from my own experience that I had 2 kids of pre-B ALL whom we had transplanted, and they relapsed. And when they relapsed, at that time there was no CAR T cell therapy available, no BLINA available, nothing much. So I put them as a palliative therapy on rituximab alone. So CD20 was positive, and after just one dose, they became MRD negative. 2 such children, and they are doing okay. One kid 5 years out, no relapse, and the other 2 years out, no relapse. Just rituximab alone. So it shows that it can be a bridge to further therapy. If CAR T was available at that time, maybe we could have given a CAR T or a second allo transplant. So this could be a good strategy. Similarly, anti-CD30 in Hodgkin's lymphoma, those who have high-risk Hodgkin's lymphoma or relapsed refractory ones, after you have done the transplant, autologous, then you can put them on brentuximab maintenance, and that can help at least for a year. So these are some of the targeted therapies which you may use in your practice. Then comes age-old donor lymphocyte infusions. This has been there for so many years. So many people have tried, but there is no hard data to say that donor lymphocytes, when to use, how many doses, in which platform, post TCR alpha beta, post haplo, things haven't been worked out. And what is the efficacy? That is also not there. So all the case reports or case series are there, 10 cases, 12 cases. From that, the data is difficult to generate. But some of them have dramatic cure. Some of the patients who had relapsed after even transplant or had mixed chimerism, where they saw that MRD was positive after transplant, they gave DLI and the disease disappeared, and some of them were cured. So it definitely remains an option. If you have nothing else to offer, no other targeted therapy, then DLI is an option. Now, in terms of efficacy, if you see myeloid malignancies in general respond better to donor lymphocyte infusion as compared to lymphoid malignancy. So CML is the best one. So CML, when you transplant, even if you have not given a myeloablative conditioning, you just done a RIC transplant in CML, and you have mixed chimerism after that, you can give them DLI from the same donor, and it has very beautiful response. Usually you are able to achieve full chimerism and the disease disappears and you do well. So CML DLI works. It should always be tried if CML is relapsing or has mixed chimerism post-transplant. Then comes AML. AML also, the data is better than ALL. So AML patients also, those who are high risk, where you have complex cytogenetics or P53 positive, where you know that after transplant also there is a high risk of relapse. So you may offer them DLI. So now the question comes, when and whom? So whom we know, those who are high risk of relapse, you may offer, but when? So usually we start tapering of immunosuppression from day 60 onwards after transplant, and by day 120, we remove all the immunosuppression in AML. And if there is no GVHD, then they are candidates for DLI. Those who are high risk for relapse, you may give them DLI. And if it's a matched sibling donor transplant, 1 into 10 to the power 6 per kg can be the starting dose. And if it's a haplo, it can be 1 into 10 to the power 5 per kg if it's a PTCY haplo. And if it's a TCR alpha beta haplo, then start even with a lower dose, 1 into 10 to the power 4 per kg of lymphocytes, donor lymphocytes. Because GVHD rates are high after TCR alpha beta if you give a donor lymphocyte infusion. Okay. So that's about DLI. The good thing is there is one trial which has opened in Europe where there is a head-to-head comparison between an arm where there is no DLI and the other they are giving prophylactic DLI, and they're going to look at this data, and that may give us an answer. If the DLI arm has a better survival, then it may become a standard of care in AML. Now, the other strategy which Charlie Craddock, he's an AML guy from UK, he has done a lot of work on cyclosporin levels after transplant. What he has shown, he looked at the retrospective data, that if your cyclosporin levels are about 100 or 150, low levels, as compared to those who had high levels, 200, 250, the survival rates were 20% better. So in AML patients, when you're transplanting, keep the cyclosporin levels low. Just around 100 is enough. Don't target very high levels because that is counterproductive. That is suppressing the new immune cells, and you may be losing your graft versus leukemia effect. So this is something doable, easy, which we can all do in our practice. Then DNA hypomethylation. So we can hypomethylate some genes and silence those genes. That is epigenetic changes. So azacitidine is one such drug, and JMML, it's a good target. Azacitidine works beautifully even before transplant. We use azacitidine to reduce, make the spleen smaller and control the disease, and then do a transplant in JMML. But those who have high risk JMML, like PTPN mutation positive, early age, other things, or the disease not under very good control, big spleen and all. So I would say that such cases, the relapse rates are very high. Nearly 50 to 60% JMML patients relapse after allo transplant. So here some sort of maintenance is a good idea. So azacitidine can be given and it may help, but the data is not there on which I can say that it's a recommendation. It's just a suggestion which people have used. There are case reports people have used as a palliative or as a maintenance strategy post JMML transplant. Now, CNS disease. When you do a transplant, somehow CNS tend to relapse again after transplant. So CNS relapses are in general bad. So they don't do very well after transplant or radiation and other things. Quite a number of them do relapse. So people feel that some sort of maintenance would be a good idea after transplant. So some people use intrathecals every 3 monthly for a year or so and monitor the disease closely. If there is any mixed chimerism or MRD positivity, then intervene with targeted therapies, whatever is possible. So again, it's controversial. There is no hard data, but some people use it that post-transplant CNS intrathecals are given 3 monthly for at least a year. CAR T cell therapy for mixed chimerism after transplant. So you have done the transplant and you are seeing mixed chimerism and you are seeing some MRD positivity. So what next? You can offer CD19 or CD22 targeting CAR T cell as a treatment option which can control the disease and maybe cure the patient. So I had a patient who had pre-B ALL and we treated him first with chemo. He relapsed. Then we did the first transplant. He relapsed after 2 years. Then we did a second transplant. He relapsed after 1 year. And then every time he was responsive to inotuzumab. CD22 was positive. So we gave him inotuzumab. He became MRD negative. Then I referred him to ImmunoAct clinical trial in Mumbai. Gaurav Narula gave him CAR T cells. And now he's 3 years post CAR T cell therapy. He's still alive, disease-free. So after 2 bone marrow transplants, CAR T cells cured him. So never give up on your patients. If they are clinically stable, they are fit, then explore all the options which are available. And CAR T is a good option after relapse or an impending relapse after your transplant. Then deeper remission before transplant is something, the data is there in NEJM. There is a paper in which they have shown that those patients who were given just chemo as a bridging for transplant versus those who got chemo plus blina as a bridge to transplant, there was nearly 15% better event-free survival for those patients. So blina is a targeted therapy, leads to deeper remission, MRD negativity, and that may be helping in the cure. So it may be used. I think Manas is here. I think he might be having a talk later on blina, or he may comment on this, that blina plus chemo as a bridge to transplant is better than chemo alone. Then myeloablative conditioning, wherever possible, when you're doing transplant, use myeloablative conditioning because it gives you better disease control. If you use RIC or non-myeloablative conditioning, especially in ALL, relapse is just around the corner. Patient will relapse soon. NK cell infusions in AML, this was an exciting field which initially Ruggeri et al. Had shown that if there is an NK cell mismatch in graft versus leukemia direction, graft versus host direction, then the leukemia cells after T-depleted haplotransplant had 70% survival, and those who did not have this NK cell mismatch had 50% survival. So, but this work was never replicated again. Only one paper came in way back in 1998 or 2000, nothing after that. But people have tried NK cell infusions post-transplant. Even Dharamshila Hospital has published, Sarita Jaiswal's paper is there, that it leads to slightly better outcomes, say 5 to 10% advantage if you give NK cell infusions. They are very safe, no major side effects. Only thing is the cost of preparing the NK cells, and it can be done in India. You can prepare NK cells. Then comes inotuzumab if you're using it as a bridging therapy. So inotuzumab leads to VOD. And because it can lead to VOD, your conditioning, you cannot give certain drugs. You cannot do double alkylating agents or very intensive myeloablative conditioning because VOD risk will go up, or TBI cannot be given. So for such cases, it's a good idea that after inotuzumab, use some bridging therapy for washout, so that the effect of give chemotherapy or blina or something for 2-3 months, so that the effect of inotuzumab has gone from the liver, and then do a myeloablative conditioning transplant, and patient would tolerate transplant better and would have better outcomes. So these are some of the strategies. I will finish here and will thank you all. So I hope it was good enough. Thank you. I can take a couple of questions. Yeah.
Any questions? Anyone?
Yeah, Manas.
Sir, just a question about DLI. So in your practice for high risk ALL, you know, some very high risk patient or second relapse patient and things like that, where, you know, again, the chance of relapse is very high. In your practice, are you using prophylactic DLI? Are you monitoring MRDs post bone marrow transplant?
Yeah, ALL, the data on DLI is very meager and it's not really effective. So I'm not using prophylactic DLI in ALL. But in AML, there is data, and high risk AML, I'm using it around day 120. Once all the immunosuppression stopped, then we are using it in few cases, not all cases. Yeah.
So, sir, if we are not going to give DLIs, is there really a role of doing repeated MRDs post bone marrow transplant?
I don't do it. I just do the chimerism, and that's, if there is a mixed chimerism, then we do an MRD or a bone marrow. Thank you. Okay. Anything else? Okay. Thank you.
Thank you so much, Dr. S.P. Yadav, for such an insight. Okay, next we have a powerhouse panel discussion on rewriting the all-risk rulebook using NGS. May I call the moderated by Dr. Manas Kalra, joined by an all-star line of panelists. Dr. Manas Kalra is a senior consultant pediatric hematology oncology in BMT at Sri Gangaram Hospital, New Delhi. So can we have a round of applause, please?
So very good afternoon. Thanks to Vikas and his team who have given us this opportunity to come and interact with you in this HEMENEXT conference. For our panel discussion, I would like to just invite the panelists, Dr. Swati Bhayana, who works at Fortis Hospital, Dr. Minakshi, who works at Apollo Hospital, Dr. Shilpa Khanna from RML Hospital, Dr. Kanika Singh, geneticist at Artemis, and Dr. Vandana Arya from Gangaram Hospital, and Dr. Srinidhi, is she here? Vikas said Dr. Srinidhi may also join. Okay. So today we are going to talk about this burning issue of next generation sequencing. So, you know, this is where we are, is that we got this fancy test available in India, and it really helped us in many ways for many diseases, you know. So many illnesses we didn't know the diagnosis, and NGS gave us an answer. But what about NGS and leukemias? I think we are still not very smart in interpreting these NGS reports. We are still not very clear as to how we have to utilize the abnormalities that we see in this NGS report. And often I'm seeing that, you know, all of us, not all of us, many of us are doing NGS. We are collecting the data, but really not altering the management of our patients based on that. unless you're using a very low risk therapy to begin with. So if you're very, very low risk kind of an arm for your ALL patients is there, and you find some abnormality and you escalate it, then yes, maybe you're utilizing this NGS to kind of modify your therapy. But if you already use a therapy like BFM, where you give anthracyclines to everyone in induction, where you give cyclophosphamide post-anthracycline, you give 5 gram per meter square of methotrexate, you give reinduction, reconsolidation, 2 years of maintenance, then where is the scope of escalating based on these minor or major abnormalities, which sometimes we are not very sure what they are? How do we modify? So that's really the problem. And I think, once we keep collecting these reports, we will get clever with time. We will make mistakes. We learn from the mistakes made by others. Hopefully, we'll collate our data together and maybe able to give the best treatment for our patients. So ALL, which contains a lot of, it's not getting projected. So ALL, which has many somatic genetic alterations. Can the screen be displayed, please? It's not coming on the screen. So we know there are chromosomal translocations like BCR-ABL, TEL-AML, translocation 119, MLL gene rearrangements. There are aneuploidies like hyperdiploidy, hypodiploidy. And then there are secondary genetic events which are deletions like IKZF, PAX5 deletion, CDKN deletion. And you have sequence mutations. Swati can come on the stage, please. TP53 mutation and NNK RAS mutations. So these are the kind of primary and the secondary genetic events which happen in children with ALL. And now ALL, which was considered to be one disease, is actually, an amalgamation of 25 or 26 different types of genetic alterations. Sometimes it's very hard to even remember that, there is something like a ERG deletion which is there with ALL. There is a LIL1 mutation, and many such. So, the disease which you manage day in and day out, at times you are kind of flabbergasted with all the mutations that you are seeing, and you have to go back and refer. And the genetic classification is actually becoming complex by the day. So you see that there is BCR-ABL, ETV6, RUNX1, and all the other common genetic chromosomal abnormalities that you can see. Then you have genomic abnormalities like DUX4, ZNF, PAX5, and many other. And then you have these genetic signatures like BCR-ABL-like, ETV6, RUNX1-like, PH-like, and all these abnormalities which have the genetic kind of a signature of a classical abnormality that we are seeing. And out of these, some are good, some are bad. So what are the good ones? We all know what are the good ones. High hyperdiploidy is good, ETV6 RUNX1 is good, DUX4 is good, NUT-M1 may be good. And what are the bad ones? KMT2A is bad, near haploidy is bad, low hypodiploidy is bad, IM21 is bad, MEF2D gene fusion is bad. All these are, the bad players and the good players. And then there are many unknown players in the field of ALL, and we don't know how to modify the therapy based on that. So I have just put some cases today where, we did a genetic testing. We had an NGS report, and I asked the panelists to kind of respond as to how they would manage that patient. And, inputs from audience will also be welcome. So we have a 15-year-old boy, pre-B ALL, CSF negative, molecular negative, karyotyping standard, not very high TLC, prednisolone good responder, B-cell ALL. And now you do a genetic testing and you identify a DUX4 mutation in it, which you otherwise did not identify, based on your routine testing that you would have been doing for the last 20 years while managing patients with ALL. So Dr. Swati, would you like to comment on, once you see this mutation, what does this mean to you?
Thank you for the question, sir. So DUX4 is like I would say it's like a false alarm. It's a mutation. You might get initially very bad results with it. There might be a prednisolone poor response. There might be a MRD positivity at the end of induction. But overall, in the long term, they'll do good. So it does not warrant for a therapy escalation, but it warrants for a close observation.
So I think, we can watch these patients. Most likely they will do well. And this is one entity that you can pick by NGS. but our smart flow cytometrist will tell us that they can do a CD371, and that will also help pick DUX4. Jasmita, is that right? Do you do 371 for your patients? No, not yet. So that's the same problem. We also don't do 371, but we do NGS, so we are able to pick DUX4, and we know that probably these patients will do well. And as Swati said, the TP1 MRD was positive in this patient, TP2 was negative. We didn't get too much worried because DUX4 was there, and these patients generally do well. And even if they are prednisolone poor responder, even if their MRD is higher, they generally, the curves merge with the low risk ALL, and these patients do well. Now, there is a alarm here that is the true alarm and not the false alarm, and that mainly pertains to other coexisting mutations. So if you have DUX4 with IKZF+, if you have DUX4 with TP53, or if you have a lineage switch. So you did the MRD testing, and in the MRD testing you find a monocytic clone. That is the time you will think, oh, maybe there is some problem happening. So if you see a switch happening in their MRD patterns, or you see these associated two mutations, these patients might do poorly as compared to the please come. Please come. I invited you. I could not see you at that time, so please join the gang. So unless you have these three abnormalities, the odds that your patient is going to do well is very, very high. So we are probably going to have a cure for this patient. Dr. Vandana, would you like to comment on what is IKZF1+? I just said if it is there with DUX4, it is bad.
Good afternoon, everyone. Yes, IKZF plus is the new entity where it's not that new as well, but a relatively newer one, where not only the IKZF plus, IKZF mutations or IKZF deletions will be detected, but along with this deletion, one more other gene alterations in the CDKNA2A, 2B or PAX gene deletions should be there, plus ERG deletion. So in case this combination is there in any patient, that particular entity is known as a IKZF+, which is definitely associated with a bad prognosis.
So your ERG deletion will be absent, and you may have one of these mutations along with the IKZF mutation. This is called IKZF+, and these are associated with poor outcomes. So moving on to the second case, this is a 2-year-old girl with pre-B ALL, highest TLC was 14,000, CSF was negative, molecular negative, prednisolone good responder. So when you see such a patient with a karyotype like this, what's your feel? Your feel is that this patient is most likely to get cured, and you'll give them very good hopes, and you'll say 80% cure rate, and that is what we would want to have. And then you do a NGS testing. Dr. Meenakshi, do you want to comment on that? Often we'll get these reports and it will be written associated with relapse, associated with leukemogenesis, associated with poor outcome. And then the parents are crying. What is your interpretation when you see such a report?
So usually when we see such type of reports like KRAS and PTPN11 mutation, so these are involved with the RAS pathway mutation, which we all know that plays a crucial role in the oncogenic pathway, and any mutation leading to the RAS kinase thing, there is a high chances that these patients will not do well, and there will be probably a high risk of relapse. But at present, these mutations do not qualify for the escalation of therapy. So that will be based on our end of induction assessment. But yes, we have to keep
if you see these mutations, you don't change your therapy, you just wait for the MRD analysis. Is that what you're saying?
Yes.
So I agree with that, because is there a role of these percentages which is given, like this 17.7, 7.9, and does that have any role in kind of decision making for you?
Yes, sir. Like there are clonal and subclonal variations, but some take target of 25%. Like if it is more than 25, that will be taken and clonal mutation and more significance as compared to the subclonal
mutation. So, in this patient, we observed this, but we really were not very moved with this because this does not mean much. The percentages are not very high. It's KRAS, PTPN, not much significance as to definite therapy changes required. We didn't act on this. This child did have a TP1 and a TP2 MRD which was positive, received BLINA, is negative post BLINA. We reviewed the literature for RAS pathway mutations, and these reports come with an attached literature which kind of says that these are bad mutations, but there is a concept of clonal and subclonal mutation. So as Dr. Meenakshi said that, if your percentages of VAF are not very high, and you have kind of less than 25%, they are most likely subclonal. And if you look at the subclonal mutations, really, most of these subclonal mutations are not represented at the time of relapse. So that means they were not really the driver mutations of the disease. They came up as the leukemia was progressing. Whereas some of these mutations, like the ones on the top, where the blue part is prominent, like the IKZF1 or a large NRAS KRAS, in those cases, even at relapse, this mutation actually persisted, kind of indicating that they may have been the driver mutations. So, definitely VAF or clonal versus subclonal may play a role. So, Dr. Srinidhi, if you want to comment on this about, how you interpret these reports.
So I think this is a very well-known thing, that what is clonal, subclonals. Clonal is the driver on the wheel, that is which started. In that we also take consideration of what is truncal. We call that as truncal. So a very normal common thumb rule which we apply while reporting an NGS, that whatever is your driver is 50% of your blast percentage typically. Okay, so if your blast percentage is 80, you typically expect the driver to be 40% if it's an oncogene, the VAF. And if it's a tumor suppressor, it can go high. If it is germline, it can go high. Okay, but this is just a thumb rule. When we report, we are taught like that in molecular also, that the driver mutation, if it is in an oncogene, the VAF is typically 50% of the blast percentage. And if it is less than 25% of the blast percentage, then we say it is a subclonal alteration. So anything subclonal, we also don't really give it too much of.
So that's great. And now we have started to understand this, and we have now started to look at the percentage and everything. But just tell me, why do these reports come with all these big red boxes if they are not very significant? The way they are highlighted, it kind of, the visual impact is such that something is majorly wrong with the patient.
So that's a guideline which we have to follow. American College of Medical Genetics and Genomics and Association of Molecular Pathology have told us guidelines that when there is a pathogenic alteration detected, something which is clinically significant, we have to put a big red box to it. And if it is less likely, it's likely, then we put a yellow, orange box. So it's just a guideline which we have to follow in terms of color code.
So I think we need to tell these people that you give us tachycardia so many times in a day. Whenever we open a report and there is a red box and we say, okay, there is a big problem with this patient, and often it is not really very significant. So it's very important to kind of keep talking to your molecular geneticist, molecular hematologist, to kind of get an idea that whatever this abnormality is there, is it really significant or not. So we'll move on. Yeah.
Or a new shade card.
Or a new shade card, yeah. So let's move on to the third case, which is an 8-year-old boy, pre-B-ALL, highest TLC is 3,300, CSF negative, molecular negative, prednisolone good responder, hyperdiploid. So is the house happy with this patient? Most likely good outcome. All NCI, everything fits into a perfect condition. And then you get an NGS report, which shows NRAS positive, CREB BP positive. Dr. Kritika, would you like to comment on this? Kanika, sorry, Dr. Kanika, would you like to comment?
So I can see that both these variants are variants of uncertain significance, and before we kind of interpret that this, so the CREB BP variant, they have written that it is associated with relapse, but we have to see that if we can upgrade this variant by following the guidelines if it could be pathogenic or not.
Dr. Shilpa, you get such a report, patient is in front of you, how do you counsel them?
Again, there is NRAS also in this. So, as we talked about RAS mutations and all, these are associated with high risk. And even CREB-BP, although it is a rare in primary disease, it's known to occur in secondary cases or relapse cases. But still, as of now, we can't intervene on the basis of these investigations, but maybe later on we can think about targeted therapy based on that. Like, for example, for NRAS RASopathies, we can try MEK inhibitors like trametinib can be tried. And then for CREB-BP, we can try like venetoclax, BCL2 inhibitors can be tried.
So again, I think all these are in the trial phases, and really when you see these mutations, again, this would give you tachycardia, but you really don't know whether this will actually lead to a poor outcome or not. But when I was reviewing the literature for CREB-BP, it kind of shows that it's a bad disease. It is associated with relapse, and very high chances that these patients would not do very well. But if you're already using a BFM like regimen and you have TP1 and TP2 which is negative, I really don't know whether we have to modify therapy for these patients or not. And once they relapse, you feel terrible that maybe you should have done more for these conditions. So they come in the single nucleotide variants, and the VAF here was somewhere around 40-45%. So I think they are significant. We need to closely watch these patients for clinical relapse. And again, CREB-BP also with a high VAF, you can see that it is a kind of a clonal mutation and can be associated with high representation even at the time of relapse. So we'll move on to the next case, which is a 3-year-old boy, pre-B ALL. Now here you have the NCI criteria showing high risk because the white cell count is very high. So this is a high-risk patient, CSF negative, molecular negative, prednisolone good responder, and you see a hyperdiploidy kind of a pattern in your karyotype. So, Dr. Swati, what do you think? You would treat it as a high-risk patient? Anything you'll be very worried, or you think this patient may do well?
TSC is a bit alarming for me in the starting.
White cell count is the only thing, otherwise hyperdiploid generally do well. And then you do a NGS which shows this. Does that change your management? Does that change your viewpoint for this patient?
So NRAS and FLT3 are known to be bad, bottom line. But having said that, the NRAS VAF is not very alarming in this. And FLT3 ALL are a very rare entity upfront. So I would continue therapy and go as per MRD, but keep a close watch because I have few alarming signs already.
Okay. So Dr. Vandana, if this case you are reporting, would you even report this?
Certainly, NRAS going with the frequency, it's 1.79% reported. So before reporting such kind of frequency, you have to be 200% sure before reporting somatic mutation at that frequency level. So ideally, in case they are 100% sure, there's a reason they are reporting. Otherwise, you shouldn't report up to that level in case if the QC metrics and everything is not matching up to the mark. Secondly, FLT3 mutation certainly not having that clear role in terms of ALL as per, but in AML definitely have a very important role. But recent literature says that ALL is coming in a very big way in a B and T ALL both.
So a lot of patients with B and T ALL can actually have FLT3 mutations, more so in I think ETP ALL where FLT3 can be associated, but therapeutically I think most of these patients are just managed like a leukemia therapy and you don't add FLT3 inhibitors to them. We'll move on to the next one, which is a 16-year-old boy, pre-B ALL. Dr. Meenakshi, the white cell count is 43,000, CSF negative, molecular negative, prednisolone good responder, and you have a little complex kind of a karyotype, but not really much, which kind of tells you that this is good or bad. So with this, we did a NGS which shows this. So what do you think? How do you interpret this?
So this, based on the initial parameters, this child would fall into the intermediate risk category, like whether he will be treated as per COG or NCI risk criteria or BFM. And NGS shows that IKZF deletion is there and JAK2 fusion is there, which are pH-like entities. And as the literature is less, and we have targetable mutation here, JAK2, we can add ruxolitinib, but upfront, so I will not add upfront JAK2 ruxolitinib to this patient, as anyhow he will be getting intermediate risk. But yes, we can keep a watch later on, and if needed, add ruxolitinib along with the chemotherapy to his
Dr.
protocol.
Vanna, you wanted to say something?
Yeah, I want to say this thing that IKZF deletion is there and coexisting CDKN2A, 2B deletions are also there. It's so homozygous deletion in CDKN2A, 2B. Altogether, this is giving the picture of IKZF plus sort of phenotype. Also
So this
having
is-
one more
yeah.
coexisting fusion, which is PAX5 alteration along with JAK. So keeping both the things in mind, it's giving a poor prognosis of the
Yeah,
patient.
so this looks like a high risk patient, a very high risk patient. It has got IKZF plus signature, the one which we discussed earlier. And I'll not go into the theory for that, but just, kind of tell you that there are drugs that you can use for these IK, for these JAK-STAT pathway mutations. Although the doses that have been given for ruxolitinib are like way higher than what we use for GVHD. So I don't know how many of our patients will be able to afford that kind of a treatment. There is no access program for using Jakavi for these patients, and I don't know about the toxicity because you're giving such high dose of Jakavi along with your conventional chemotherapy because we are not really able to de-escalate. So I'll tell you frankly, for this patient, we did give low dose Jakavi throughout. They were not affordable for a transplant. His MRD was negative. And he's been like now almost 9-10 months on Jakavi plus conventional chemotherapy. I'm not sure if we are doing right or wrong, but because there was this mutation and it is IKZF plus signature, along with the BFM protocol, we continued this patient on Jakavi. So the next case is for Dr. Shilpa, which is a 12-year-old boy, pre-B ALL, highest TLC is not much high, CNS negative, good responder, molecular 119 translocation. So a kind of intermediate risk. There were some other additional abnormalities that we could see on the karyotype. And then we did a NGS which shows this. So what is your interpretation? Do you modify therapy or just continue the way you treat your patients?
See, TP50.
So do you use icicle?
Yes, we use
Okay.
icicle.
But even in icicle, he's 12 years, so he would get a higher risk.
Icicle translocation 119 is high risk.
High risk, okay.
So that
Yeah.
would be treated as high risk.
So you would give anthracycline, cyclo, everything.
4 doses,
Yeah.
definitely. So, but apart from that, this patient has TP53 mutation, which although very rare again in primary disease, more often it is seen in relapse cases. I would not further intensify therapy, but yes, definitely I would like to investigate the patient for germline TP53 for not only this primary disease prognosis, but even later on development of other malignancies in view of possibility of Lee-Fraumeni syndrome.
That's right. So we asked a good family history. If there is history of cancers in the family, there was none. The VAF was high for TP53. We were worried about, germline. We managed him the standard way. He got some complications. His MRD was negative. We looked at TP53 literature. We discussed in the National Tumor Board. They just said, continue therapy the way you give for all your BFM patients. There is a recent paper, very recent paper, which actually says that if you have TP53 mutation and newly diagnosed, your outcome is poor. And the graph is actually, the survival is 49% versus 89%. So this is a very recent paper. At that time, few months back, we just thought that it is probably just the way we manage our BFM patients. We did evaluate for Lee-Fraumeni. It came to be negative. We reassured the family. MRD was negative. Unfortunately, the patient relapsed on treatment. So during maintenance, just start of maintenance, he presented with a relapse. And, we are feeling really terrible that we could not do much. I don't know if such TP53 upfront should be managed. Sandeep wanted to comment if whether they should upfront receive a transplant. Is very poor.
continue intensive chemotherapy, the outcome is 50%, and even if you take them for transplant, still the outcome is 50%. So transplant has not made any dent in the outcome.
Yeah.
I think here lies the importance of chemotherapy. These are the ideal patient whom we can add blina.
Yeah.
So as to achieve deeper remission, and probably because transplant related mortality is very high in patients with TP53, and it is not the risk of relapse but the secondary leukemias and the mortality associated with the toxicity that is concerned.
Yeah.
So I think
and he was not hypodiploid, because generally hypodiploid and TP53 go together, but here even hypodiploidy was not there. So really we kind of ignored that TP53 because he was not germline, but that fear was always there in the mind. You know, we had that fear, the parents had that fear, but because MRD was negative, we just progressed with the usual therapy, and unfortunately he has a relapse.
in the current UK protocol for all these TP53 mutations, they are upfront giving blina for these patients.
Blina therapy. Yeah, that's right. So the next one is 6-year-old girl, pre-B ALL, CSF negative, molecular negative. Dr. Srinidhi, this is for you. Karyotype normal, white cell count is normal, prednisolone good response. So are you in a happy zone with this patient? Everything looks good. Everything is good. Okay, we did a molecular PCR, BCR, ABL, all those things were negative. So again, you know, it's kind of B other. It's B other phenotype where, you know, everything else is okay. And then we did a NGS which revealed a RUNX1 mutation, 54% allele burden. Does that have any significance for B cell ALL?
So we do see a lot of RUNX1 mutations in BALL, and the fact that the VAF is so high, I would again think of a lymphoid neoplasm with germline predisposition. I would evaluate for a germline and would be interested in knowing that, and probably that may change things for you in treatment. I'm not sure.
Okay, so the TP1, TP2 MRD was negative. Again, you know, sometimes these reports are teaching us a lot, and we are going back and referring to the literature, and we did the same thing. We were reading about the RUNX1 and BALL. So association is not very strong. It's very rare. It's more common in AML and myeloid neoplasms and not lymphoid neoplasms. It can be associated with a familial platelet disorder. We looked at the platelet count of patients' parents, and both had normal platelet count. And we did a Sanger which confirmed the presence of a heterozygous mutation. Do you want to comment on that?
So this confirms, so did you do this on buccal swab?
This is on buccal swab.
Yeah, so this confirms a germline predisposition. So probably you can, it is associated with thrombocytopenia, but it can also have platelet function defects also. So
Yeah.
maybe,
So I discussed this with the lab that used to do more samples for us in the past. Now we are doing many in-house. So they actually felt that, you know, this is a missense variant. This missense variant has a Reville score which is low. The clinical significance of this variant is uncertain. So I was totally confused because there was RUNX1 in the marrow, then there was RUNX1 in the buccal swab, but it is not significant because it is VUS. And the patient's parents' platelet count is normal. So I really don't know how to counsel them whether your child has a predisposition for developing cancer or not. And is there a way we can find that out?
So typically, actually the guideline says don't chase a VUS. Okay, you should not chase a VUS in any family also, ideally. Okay, but in case if there is one other affected family member and that person has RUNX1 and an unaffected does not have a germline mutation, then that actually tells you that yes, it is co-segregating and it is going to cause cancer.
Okay.
So in this patient, if the parents are negative, it's not co-segregating.
So I have not tested the parents, but their platelet count is normal.
So, I mean, one of them, if it's germline, one of them may still have it, right? Because otherwise, how did the child get it?
So should we test the parents for the mutation?
I think you should, because in case if it is co-segregating and if there is any other affected family member.
Okay. So it is, yeah, Sandeep wanted to comment and Swati wants to comment, yeah.
I just want to say, suppose this patient now you are taking for transplant and he has 2 siblings. Would you check RUNX1 for the sibling and would like to take a donor who is rungs 1?
No, I think we have to check the donor if we give importance to this. But the lab told me don't give importance to this. So I don't know what to do about it. So that
I think so. Ideally, yes, I think we should check the donor for the transplant. But for the VOS, I just have one comment that we are always told in a conventional teaching that don't chase the VOS. But the moment something goes wrong, we go back and it becomes a novel variant. So then we are stuck. Like you were the one who discovered
A lot
it.
of cancer genes, the thing is they usually have an incomplete penetrance. So testing the parents, I don't know if they have it. I don't, it's not necessary they would have developed cancer.
Yeah, so they don't have cancer. Parents are totally healthy, but I just wanted to look at their
They could have a
platelet
germline
count.
thing and never developed cancer. That is possible.
So at the moment, what I have told the family is that the lab tells me that it is not significant. So I'm just going to wait and watch, and I'm going to monitor you for development of any other malignancies. And that is the maximum thing that you can do. MRD is negative and the child is otherwise okay. So we move on to the next case, because sometimes, you have to just put a full stop to these investigations which just go on and then you don't really find an end solution for them. So this is a 13-year-old girl, B cell ALL, CSF negative molecule.
To wind off in 5 minutes.
Yeah. We'll finish in 5 minutes. It says 13 minutes, but I'll wind up in 5 minutes. No problem. So molecular negative, karyotyping normal, highest TLC 2190, prednisolone good responder, steroid pre-treated, BFM 2000 protocol. So any significant thing, only the age. Otherwise, everything looks okay. So, Dr. Kanika, would you like to comment on the reports that we have? There is ETV6, 32%, and there is PTPN, 11. I think PTPN is not very important. We can probably ignore it. But is there any importance of this ETV6 mutation?
I'm not sure.
So again, probably again going back and reviewing the literature, there was this literature on ETV6 related malignancies, so again it is like a RUNX1 malignancy. This can also be significant. In this patient, the TP2 MRD was positive, the TP1 was negative, but TP2 was positive. The lab felt that the quality of specimen for TP1 was not very good, so maybe they missed the MRD, but the TP2 was positive. We reviewed the literature on ETV6 related neoplasms, and again there is some history of thrombocytopenia, solid tumors, blah blah. The VAF was a little high, but then we evaluated by doing a Sanger and the patient was negative, so we kind of counseled them that most likely it's not a cancer predisposition syndrome which led to cancer in this patient. The next one is a 13-year-old girl, pre-B ALL, with a white cell count of 60,000, CSF negative, other things are okay. Karyotyping shows this. Dr. Vanna, would you like to comment?
Karyotyping shows monosomy 7, right, and translocation 7-9. So would like to see what is the, PAX ELN fusion is there, which is reported on the karyotype.
That's right. So our cytogeneticist mentioned that this mutation is PAX ELN fusion. So the PAX altered is also now a big entity in ALL, which are generally associated with poor prognosis. So this is the comment from the cytogenetics part, and we were looking at PAX and its association with IKZF and other things. The girl had a complicated course during her induction, somehow came through it. This was the entire report from the cytogenetics, and we identified this. But when we did the NGS, we identified CDKN2A, 2B deletion. So when I looked at the karyotype, and I just sent it to a friend as to, aapko kya lag raha hai, kuch significant hai ya nahi, a cytogenetics expert somewhere else, he said that this is IKZF plus.
Right, rightly said, as monosomy 7 is there, so entire one chromosome of 7 is deleted. So IKZF plus chromosomal position is 7 chromosome. So in case the whole chromosome is deleted, certainly IKZF is deleted altogether.
So if you have an absence of chromosome 7, you have IKZF deletion. And if you identify CDKN here, then it also comes into the IKZF plus profile. And you have to really check the ERG and see if there is an absence of ERG deletion. And if there is absence of ERG deletion, this becomes IKZF, and these are very high risk patients. Again, Although the TP1, TP2 was negative for this patient, she relapsed 8 months or 9 months into treatment with liver lesions, lung lesions, and we biopsied the liver lesion and it had leukemia. The marrow was normal. So again, this is, one of the things that you can pick with the help of NGS karyotype, and if you bring them together and you have experts sitting with you, you can probably predict relapse. I don't know whether we are able to treat them, manage them better, or have better therapies for this patient, but you can definitely probably say whether these patients are good or bad. So I'll skip my next 3-4 cases because there is lack of time. I'll just say that NGS has opened a Pandora's box for a disease that we thought we kind of understand most of it, but actually we don't. It is vital to do this test. We need to collect data. I'm sure we are going to make mistakes, but hopefully with time we'll get better. We need to keep learning from our Western colleagues the ways to optimize therapy for these high-risk patients, whether to add some molecular targets, whether to use immunotherapy, whether to do a transplant. And I'm sure when, we have more and more data for these smaller subsets and we collate them, we'll be wiser as to how we can do best for our patients, and then probably we'll be able to adopt our policies, especially in a low and middle income scenario where there are anyways many challenges managing these patients. So thanks to all the panelists for giving your valuable inputs. Thank you.
Thank you so much, Dr. Manas Kalra, and thank you all the panelists for such an insight. Next, we have a debate on flag versus Veneza, the remission showdown before HSCT, which is by Dr. Safal Muhammad and Dr. Anut Singh, chaired by Dr. Anupam Sachdeva. So Dr. Safal Muhammad is an associate professor at Army Hospital, New Delhi, and Dr. Anut Singh is an assistant professor, pediatric hematology oncology. So can we have Dr. Safal Muhammad, Dr. Anut Singh on stage, please? Is Dr. Anupam Sachdeva here? Okay, so we'll begin with the debate here.
Slide. Yes. Slide.
Good afternoon. So at the outset, I would like to thank the organizers for this opportunity. So the topic for this debate is remission showdown in acute myeloid leukemia. I'll be speaking for the regimen flag. So when I was allotted this topic, I was quite happy that I'll be defending sort of the standard of care, one of the most commonly used regimens in relapse settings. But I was also apprehensive in the fact because I was sure that most of the literature that I'll be getting will be slightly older. Because Azavin is a new thing, so most likely Dr. Anuj will have more updated articles compared to my presentation. So let's start. So we all know that positive MRD and MRD relapse increases the risk of phenotypic relapse and leads to inferior leukemia-free survival. And in this setting, a transplant, hematopoietic stem cell transplantation is essential for meaningful survival in high risk, in case of MRD positivity or in relapsed AML settings. So FLAG is the one of the most commonly used backbone for most of the salvage regimens that we have been using over the last 2-3 decades. So FLAG as such, the data would be, the articles would be less, the evidence would be less. So I'll be discussing most of the FLAG IDA based regimens. So this is the FLAG that the protocol that we have in our setting, in our unit. Fludarabine, we give 30 mg per meter square for 5 days. Cytarabine 2 gram per meter square for 5 days. Starts after about 4 hours from the end of fludarabine infusion. And we give GCSF. But why FLAG? So the scientific basis for this came in 90s from MD Anderson Center. So they did a lab-based test in which cytarabine was administered after fludarabine, a few hours after fludarabine, and then they found that the aryl CTG, which is the active metabolite of cytarabine, is concentrated more than 400 times. 400 times the level is there in the intracellular compartment as compared to those who were not getting fludarabine. So this sort of said that fludarabine about 4 hours prior to cytarabine potentiates the action of cytarabine, which we all know is one of the most potent anti-AML drugs which are available. Now, when you administer GCSF along with that, most leukemia cells are pushed into G1 phase and they become more sensitive to the action of cytarabine. So this is a biological basis for using FLAG regimen, and it's a very versatile regimen. You can use it with FLAG, without GCSF also, with GCSF, with idarubicin, with gemtuzumab also. And there are BFM studies where they have used it with liposomal doxo or daunorubicin. Then FLAG, IDA, venetoclax is also a new regimen which is coming up. So CCLG 2025 protocol for upfront therapy of AML also uses FLAG IDA as a second course in high risk AML before transplanted, they proceed with transplant. Now I checked what the NCCN says. So NCCN for those who are, So for eligible patients, for appropriate patients, they are still advocating intensive chemotherapy before to bring the patient back into remission before proceeding with transplantation. So one of the regimens that they advocate is FLAG, IDA plus minus venetoclax. So what is this appropriate patient? So appropriate patients would be anybody who is eligible for intensive therapy and those with long first remission. So I think we can all agree that most of the pediatric patients would be eligible for a second intensive chemotherapy, as most of them don't have any comorbidities. So some of the early studies came from late 80s to early 90s. Till then, there was most of the relapsed AML patients did not have any meaningful survival. But with the advent of FLAG-based regimens, some sort of long-term survivals started to be achieved. But these were all adult studies. So one of the first pediatric study also, which studied AML in relapse setting, was from UK. So this studied 19 patients, out of whom 13 achieved CR and 13 of them underwent bone marrow transplantation. And seven patients were alive at a median of 1 year, which was a huge achievement in 1990s for relapsed AML. The toxicity grade for hematological toxicity was there in all patients, but febrile neutropenia was there only in 1, and grade 2 GI toxicity in 2 patients only. Then they did a multicentric study, MRC only, for relapsed refractory AML as well as MDS. So the older term, refractory anemia with excess blast. So in this, the first induction was with flag, second was also with flag, but only for 4 days, and the consolidation second cycle was also optional. What you can find is that those with late relapse had long-term survival lead of almost 40%. Those with even RAEB had some sort of long-term survival amounting to about 20%. The ones who were refractory or early relapse had very dismal long-term survival. So the total of 83 patients were there, and after follow-up of 22 months, 25 patients were alive. And deaths due to toxicity was 13, which was just over 10%, approximately 15%. So BFM also tried flag in their study AML 2001. So this was flag 2 courses were given, and the outcomes were that with flag alone as well as flag with liposomal daunorubicin, there was sustainable remission. CR2 was achieved in many patients, and there was a long-term survival of almost 40%. And toxicity was similar between flag as well as flag liposomal daunorubicin group. The only subset where flag liposomal daunorubicin improved outcome was core binding factor AML. So I spoke about refractory situation or relapse situation. AML 15 trial by MRC studied flag IDA in upfront therapy of AML. So here they also found there was significant reduction in relapse risk and improved relapse-free survival compared to the standard ADE that we have been using most commonly. So you can find that from the survival curves. So flag IDA of 2 courses they found was equivalent to 4 courses of standard therapy like ADE 2 times followed by 2 courses of HIDAC. And flag IDA followed by consolidation itself improved the survival to 66% by 8 years. The only significant toxicity was prolonged myelosuppression requiring longer hospital stay as well as more transfusional burden. And the benefit was consistent across all age groups and demographic groups and included patients with FLT3 ITD as well as age more than 50 years. So the BFM analyzed their own relapse AML studies. So they found that as soon as they introduced flag, the outcome started improving significantly from around 20% to up to 40 to 50% after they introduced flag in their AML 2001/1 study. So what is our own experience? I am currently working in RR hospital. Me and my predecessor, Dr. Khera, we have used flag or flag IDA or flag VEN in about 11 patients over the last 3 years. All of them did achieve CR2 except for one who achieved CR2 after a second course. All the others achieved CR2 within 1 course. Though 2 of them died after transplant, after we could transplant them with a relapse. Both of them were KMT2A positive. 2 of them we can't, I mean, it's too early to comment because they are still undergoing pre-BMT workup and one has just undergone transplant. So, and the toxicity has been tolerable. It was not worse than ADE. This is not a published data. I just analyzed our data when I got this topic for today's CME. One more thing that I just want to say is the economics of administering flag and the economics of administering azaven. So we all know that venetoclax, at least right now, it's a bit expensive for most of our patients. 28 tablets come to about 80 to 90,000. So even for a 10 to 20 kg child, the parents will have to bear a cost of between 1.5 to 2.5 lakhs for just getting venetoclax. This will be on top of the admissions and all. Whereas flag only will come to between 30 to 50,000 if depending on the brand that they will be buying, plus whatever is the length of stay in the hospitals. So I believe that if you look at the cost also, something which is tried and tested, which has been found to lead to sustained remission should still be explored. So what is the way forward? The way forward is combining the new with the old. So this is one ash extract in which they combine flag, aza, ven and vorinostat, which is a histone deacetylase inhibitor for 10 patients. 7 of them achieved nil MRD and proceeded to allo HSCT with 1 year OS of 53%. Some of the COG studies which are ongoing still have flag or flag IDA as their backbone, combining it with gemtuzumab, venetoclax, glitatinib, quizartinib, and all these newer agents. So I would like to conclude by saying that flag is still a regimen with a strong biological basis, which potentiates the action, potentiating the action of cytarabine. There is robust evidence available for its efficacy. Toxicity, especially in pediatric age group, is acceptable and probably makes sense to a low middle income country like ours with a reduced cost burden to the family. And it's more importantly a versatile burden. So flag itself being a less toxic regimen, it can be combined with other agents like venetoclax, which we have done also, which is ongoing with other anthracyclines also. So I would like to just leave this quote on the stage that we should not just because we have new agents available, something which is tried and tested should not be discarded very early. Thank you.
Respected faculty members, my dear colleagues, and thank you, Dr. Safal, for setting the stage for the debate. And can we have the presentation loaded? Yeah. So I would like to just begin with some data. So can anyone guess what's the outcome of upfront pediatric AML in our country in a proper prospective trial? So as I can see in the literature, recent multicentric study done by AIMS and RDR group, it is only 30 to 40%. So that is upfront. And the relapse data is very sparse. So the outcomes in pediatric relapse AML from COG and BFM group from last 2 decades has not changed much. It was in the range of 30% and now it's in the range of 39% in BFM. In the COG, it has moved up to 40%, but the p-value is still not significant. So I would like to request everyone to think for just 15 seconds, what are the reasons our outcomes are suboptimal? And I can categorize them into 3. One is failure to achieve second remission. And why it is so? Because of adverse biology and chemoresistance. How do we check chemoresistance? Any guess? So we do check clinically just by giving the drug and testing whether the patient is responding or not. There are no assays for chemoresistance as of now. The second is treatment-related mortality, which is a big pillar in our country, sepsis, malnutrition, and supportive care quality. The third is access to HSCT. Right now, if 100 patients need HSCT, it's only accessible to 5 to 10. And the fourth major chunk is treatment abandonment. Actually, I think everyone will agree that almost 50-60% patients at the relapse AML setting, they opt for palliation. So the need is clear. In last 30 years, I think the flag is there, but it has not been able to move the Kaplan-Meier curves much. So today's talk will be focusing mostly on how to induce the remission. We know that there are other pillars also, but we'll focus on the talk how to induce remission. And this is a simple, we all know, the management of relapse AML is simple. Just induce the remission by whatever magic drug you can use. Do HSCT. Everyone will need HSCT. There are no cures for relapse AML without HSCT. So the real question is how to bring them into remission. And that's the core of our debate today. So what can be the ideal regimen? Say we are living in a utopian world, everything is there. What can be the ideal regimen? A regimen which gives 100% response, 0% TRMs, and it is accessible and available. But ideal world doesn't exist, is it? So at least we can aim for it and we can go towards little bit what is ideal and we can find a trade-off between the 3 so that we can select a regimen. So this is the therapeutic arsenal of AML remission induction regimens. Conventional chemotherapy, just now discussed, intensive regimens. Targeted therapy will be my talk, and others are also there, immuno, NK, CAR, and the armamentarium is continuously increasing. So I will set the case for Veneza and I will discuss it under biological rationale, efficacy, toxicity, and cost effectiveness. So what's the biological rationale? So I would just request you to go to your Robbins first chapter, apoptosis, and how does venetoclax act? It's a BCL2 inhibitor. So if you cannot remember anything about BCL2, just remember BCL2 is like Amrit for cancer cells. They need BCL2 to become immortal. And if you can inhibit BCL2, they will die. That's very simple. So venetoclax inhibits BCL2 and it leads to caspase activation and cell death. But normal cells are spared, and you can see on the right. So this is a normal cell. Normal cells have a lot of MCL1, which inhibits, doesn't let venetoclax to act much. So there is a differential action of BCL2 inhibition on a cancer cell as compared to normal cell. The second is when you combine it with HMAs, that is histone methylating agents, hypomethylating agents, my bad, yeah, then it also disrupts leukemic stem cell metabolism. Okay, so, but we do all see these nature papers, big diagrams. Rationale doesn't translate to clinical outcomes. So rationale inconclusive, but let us see what does the data says. So I will be discussing data on efficacy and toxicity, and the data will be a mix of adult and pediatric studies. So first of all, there is no head-to-head study between FLAG and Veneza. So the first retrospective single center study from MD Anderson, 43 patients, median 2 cycles of venetoclax and hypomethylating agents were given. So if you see the patient profile, 80% of the patients had received already 2 lines of salvage. And 50% of them have had adverse molecular features. When HMA was given, overall response rates, I will be discussing about this composite response rate throughout, which is complete remission with incomplete count recovery, and morphological leukemia-free state, that means less than 5% blast, was achieved in 21% of the patients. The number is less, but please focus on the subset of patients which they were. They failed already 2 lines of therapy, a biologically unfavorable group which got selected. And 47% of the patients already had infection at beginning, and which we do see in our country also. Lot of patients, if they have infection at upfront, at presentation, it's very tough to induce remission by giving an intensive regimen like FLAG. And during Veneza course, 70% of them got infections. The pneumonia was most common, invasive fungal infections almost 30%. So it's not that there are no neutropenia, cytopenia, hematological toxicity is common in Ven HMA regimen also. So moving on to the larger study again from USA, California, 33 patients, all received Ven and HMA. Prior failed lines were 2. Median number of 2 cycles were given, 1 to 10. There was no intention to take these patients for transplant. It was chosen mostly as a palliative. And the overall response rates were 60%, and MRD negative is 53%. So, which is quite significant. So although it's a small molecule, but you are achieving a deeper remissions also. We can see the upfront curve is for survival. The lower curve is for leukemia-free survival. It just shows that after 10 months, if you do not take for transplant, your remission is not going to stay for long. And that's true for any intensive regimen also. When the same study was extended for 3 more years, total 90 patients, response rates were 64%, and MRD negatives almost 2/3, 60%. Cytogenetic group again influence whether we can achieve CR or not. And the TET2 and ASXL mutations, these are the patients who had better response with Ven HMA. So the data from Italy, again single center retrospective study, Ven durations were different. So it's a 3-day ramp-up course which is given initially, then the total duration is 28 days. The cytopenia usually lasts for 5, sometimes even 6 weeks. When the cycle 1 has prolonged cytopenia, in subsequent cycle the duration is reduced. So the median venetoclax duration was 14 to 28 days. Cytogenetic intermediate risk in 66%, and there were 23% patients who had relapse after HSCT, and they received median 2 cycles. Composite response is 50%, and MRD negative again 60%. And when the patients were taken for transplant, we can see the outcomes are pretty good. So with these three studies, we can see 2/3 responses and 2/3 MRD negativity rates. The toxicities again, grade for hematological toxicity in almost everyone, and we know that aplasia is needed to induce remission, and that's what was noticed. Febrile neutropenia 40%, infections almost 30%, and in 70% patient the dose was reduced in subsequent cycles. MSKCC data, 86 patients, overall responses 40%, MRD negativities is not reported in this study. NPM1 subset, more common in adult, had higher responses as compared to P53, because when the cell BCL2 you inhibit, you need P53 to kill the cell. If it's mutated, the cell is not gonna act very well. So P53 mutations doesn't respond very well. Again, we can see these are the three subsets which respond not so well with Ven-HMA. Then the pediatric data from Texas Center, 43 patients, median age 17 years, 40% of the patient had failed 3 lines of therapy. I think if a patient comes to you who failed 3 lines, I think it's very tough to give an intensive regimen, and 40% had post-HSCT relapses. The median duration of Ven treatment was 14, from 7 to 28. Composite response is 40% and overall response is again 45%. So you can roughly remember half of them will go into CR and the half of them will be MRD negative from those who respond. Again, similar data from Philadelphia Center, 2 cycles of venetoclax MRD negative response almost 40%, and the GLIS2, which is seen usually with M7, 3/4 of the patient responded in that tough subset also. Similar data, multicentric retrospective study, 134 patients received Ven as a response rate, again 50%. Cincinnati Children's Hospital, again 60% responses, 70% MRD negativity rates. So now some comparative groups. So there is no prospective comparative study, but this center from Germany, they did propensity score matching and they compared 2 groups, one with Ven-HMA, other with TPC, that is treating physician choice of regimen, which was a myeloablative regimen, usually mito-Ara-C and etoposide. There were 30 patients in Ven-HMA and 90 patients in the intensive regimen. What we can see here is the responses, overall response 59% in Ven cohort and 30% in the intensive chemo arm. So stronger the regimen doesn't mean we will get a good responses. And when these patients were taken up for transplant, the survival was maintained with a longer follow-up. So Ven cohort did superior as compared to intensive regimen. Again, a study from Korea in which they compared mito-Ara-C flag. There were 2 different intensive regimens for these 2, and with Ven, Aza or decitabine. As you can see in the baseline characteristic itself, the Ven group, which is here, had 38% patients which were post-transplant as compared to 13% in the intensive chemo. So when the post-transplant relapses are coming to a physician, they are unlikely to start them on intensive regimen. So that is why there is always adverse biology patients which are concentrated in the Ven group. That makes response assessment bit difficult, but still with that 50% of the responses were seen in the Ven-HMA as compared to 43% in the intensive chemo arm. So definitely the responses are within up to 50% in adverse biology groups also. So when you want to see, because it's a new molecule, everyone want to see whether when we take these patients for transplant, do we encounter issues with that? Do they do very well with transplant or they have graft rejections? So this study from the Korea, there were 40 patients which received Ven-HMA as salvage, median follow-up of 13 months. Those patients who got more than 3 cycles, they did better before transplant. And you can see the survival was pretty good, 50%. What else we need in a patient who has relapsed post-transplant? And these are the studies which have compared the outcomes of allo-HSCT after Ven-HMA. Median number of cycles of Ven 3. The CR rates pre-transplant, it will be high because these are taken, those patients who are taken for transplant. Myeloablative conditioning in almost 30%, sometimes 80% also. Relapse-free survival at 1 year is 40 to 50%. So definitely it's a ray of hope. New is not always better, but it seems to be the scenario till now in this. And when the systemic review and meta-analysis is done, we can see the effect size of each study and the composite effect size, which the effect here is the response, is almost 43%. But the heterogeneity index is very high. When the heterogeneity index is more than 75%, we cannot rely much on these forest plot. It is like a forest only. But yeah, there is some data here that 40-50% patients have response, but there is no prospective study. So the lesson learned is it's a safe, feasible regimen. Response rate between 30 to 60%, MRD negativity 50% among responders. It's an effective bridge. Hematological toxicity is high. FN rates are almost 40 to 50%. Now coming to the cost effectiveness, I think after GST rate cuts, we had made some changes in the cost effectiveness. So when as a medicine is, I agree, 80,000. Supportive care is 50 because the mucositis is not there, gut translocation is not there, there is cytopenia, but there is less bacteremia rates. FN rates are 40% as compared to flag. Flag inpatient 100%. Here, maybe in the second cycle, there may be outpatient care also, so that will reduce the cost on supportive care. Hospital stay 20-30K depends on which setup. So, which I could see there is around 1 lakh Indian rupees difference towards Veneza as compared to flag. Fludarabine 1 vial 10,000 for a BSA of 1, 4 vial 40,000, 50,000 medicine. Supportive care SDP 3 SDPs, and then it will be almost a lakh hospital admission, and it's pretty costly. About 2 lakh will be needed for a one cycle of fludarabine Araci with increased toxicity. So which is close to ideal. I will leave up to you to decide that. So there is a trade-off of efficacy and toxicity. Efficacy, I agree, till now is 30 to 60%. It's not 60 to 70 as with flag, but the toxicity is less. Other than hematological, the febrile neutropenia rates are less. And in our country, we know that every episode of infection, if it's MDR, the outcomes can drastically reduce and we may not salvage the child. TRMs are less as compared to flag. Bridging to HSCT is same. It depends on multiple factors, whether there's a nexus, there's a donor. Cost effectiveness is there. Yeah, so it's evidence and real world patient mix, heterogeneous cohort, because till now good risk patients are taken for flag, poor risk are for Veneza. Still Veneza is doing good. It's like comparing two runners, one running with the hurdles and another with not, and both are reaching at the same time. It's up to you to decide who is running fast. So yeah, thank you.
Thank you so much, Dr. Safal and Dr. Anuj, for such an intense insight and knowledge. Do we have something more? Any questions you want to ask Dr. Safal or Dr. Anuj? Anyone? Yeah.
No, that are there any studies done, as you had showed, that where the fludarabine and cytarabine has been combined with venetoclax? Because if you give only flag, the remission rates are not that great. But when you combine the anthracyclines, then the remission rates improve. But these patients have already received very high dose of anthracycline before, and they have exhausted the dosage. So if we are giving 60 mg per meter square in every cycle for 3 days, so they have received 360 mg per meter square, and for Indian patients, they are nutritionally not that great. So when they relapse, there is a very less window to give them anthracyclines. So after this debate, is there some middle ground where you can use fludarabine and cytarabine and you combine it with venetoclax just to get the best remission rates, and then we can take them up for transplants?
So I think after the debate, probably my take home message would be that up till first relapse, we should intensify the therapy and try to bring him to transplant after the first relapse. So how you do that after the first course of therapy is, after he has already undergone one set of therapy is the question. So in our setting, what we are now doing is that, since being an army background, most of our patients can eventually undergo transplant. So we are trying to not give anthracyclines from the second course onwards, so that we have that 180 mg per meter square only they get in the course 1. After that, we try to avoid giving anthracyclines, because in case of relapse, we still have that. And in any case, unless the child is having standard risk features like inversion core binding factors, in which we are giving standard MRC 15 protocol. Second, so in the second course, we have extra donorubicin or idarubicin, whatever is available, and we are actually combining it with venetoclax. So we have, our experience has been good with that. One of the studies that I showed is just 10 patients, and that they just presented it as an abstract. There is no larger studies that I can find combining flag when published studies. But as I've shown, COG is trying to combine flag with many other molecular targets. So maybe azaven will be utilized after the second relapse, probably, if they relapse after transplant, to prolong the remission. That is my take on this.
Yeah, thank you, Dr. Sufalia. Right. Yeah.
So I have seen my adult colleagues using azacitidine as maintenance. I don't have any experience, neither data to show that it can be used in pediatrics.
Right. So regarding your first question, definitely. So there is data from MD Anderson which I've added when to fludarabine and Ara-C. I will say in our country, if you have received 300 to 350 mg per meter square of anthracycline, not to go beyond that. See, if you have to do haplotransplant, you need post-transplant Psi, again cardiotoxic. So don't go beyond 350. Flu, Ara-C and GCSF is a good regimen. You can consider adding when, but be very careful. The cytopenias are very profound and prolonged. So 7 versus 14 days, 28 days is unimaginable. It's tough. People have tried 7 to 14 days. I think sometimes 10 days also. That has increased the response rate, but it's tough to see the long-term effects. And yeah, right. So I will say when are definitely for patients who are having comorbidities, relapse after transplant, you can consider them, and or maybe with those who have failed after 2 lines of therapy. Right. And maintenance post-transplant, when will work when there is BCL2 increase those cells which are requiring BCL2. If the patient is in MRD negative state, when is unlikely to enhance GVL as with ESA. So ESA data is there. When is, I don't think it's much there.
So just a comment, it's not a question, coming from a different setup, a private setup. The cost analysis that you did for the 2 regimens is actually vastly different in a private hospital. The cost of drugs might be lower with flag, but the amount of supportive care, hospitalization, neutropenic fever, and high-end antibiotics and antifungals. So there's a huge difference in cost over a regimen where ESA can be given subcut, when is an oral drug, mucositis is very low. So I think some of the treatment decisions are also influenced by the fact, and when the patient relapses, the finances are already drained. And the emotional burden of hospitalization, and also all these factors I think also come into play in the decision making. As you both rightly said, there's no head-to-head comparison even in adults, so let alone pediatrics. So I think this fact also comes into the decision making. Thank you.
I completely agree. In fact, that's what he was alluding to. I was actually mentioning the cost of flag as less than 50,000 when I had originally made the slide. Then I realized that because I always worked in a government setting, I never understood the cost of transfusions and all these things. That's when I changed that thing. That's what he was just mentioning.
Blood product irradiation is 1,200 rupees extra.
Yes, exactly. Yeah, right.
Okay, thank you so much, Dr. Safal and Dr. Anuj. Next, we have a panel discussion on conquering post-induction MRD positivity. Moderator is Dr. Prachi Jain. She's a pediatric oncology, hematology, and BMT with Max Hospital, Vaishali and Patparganj, Delhi. So, can we have Dr. Prachi? Good evening.
Good afternoon, everyone. Thank you, Dr. Vikas and the organizers of HEMENEXT for having us here today. So actually, our job is made easy by the debate we just had. And as we all know that overall survival of AML is actually pretty below when it is compared to ALL. So what is an alarm? If we pick it up early, if we do something early, are we really there to conquer? So this is what our topic is. And I would like to invite my esteemed panelists, Dr. Rachna Seth. Can we have the slides on stage? Yeah. Dr. Rachna Seth, ma'am is a professor in pediatric oncology at AIMS. Dr. Ritu, pediatric hemato-oncology at Kathmandu, Nepal. Dr. Payal, I'm sorry she could not make it up today.
because of some sick patient. Dr. Alka Yadav, Professor in Pediatrics and Pediatric Oncology at PGIMS Rohtak. Dr. Arushi Agarwal, Consultant Hematology and Pediatric Oncology and BMT at Asian Institute Medical Sciences, Faridabad. And can I also request Dr. Anuj to please join us for the panel. He is Assistant Professor at PGICH Noida. I welcome all my panelists. So we'll start with a case, a 2-year, 4-month-old boy presented to us with fever for about 15 days. He had some pain in the right shoulder and legs. There were no other complaints. On examination, he had mild pallor, no icterus, no lymphadenopathy, no hepatosplenomegaly, some diffuse swelling of the right shoulder joint, otherwise no bony tenderness as such. This was the CBC, his hemoglobin was low, platelets on the lower side, and PS had about 21% blast. So we did a bone marrow, which confirmed the diagnosis of acute leukemia. On flow cytometry, it was acute myeloid leukemia with aberrant CD7 positive. It was a normal karyotype, and NGS also did not pick up any significant mutation. So this 2.5-year-old boy, AML with aberrant CD7, non-M3, intermediate risk, CNS1. We started treatment as per the UK MRCALL 17 protocol with 3+7 donomycin and cytarabine continuous infusion. At the end of induction, his bone marrow was in morphological remission. MRD was 0.08, which is a flow cytometry based MRD. So we all know that our conventional chemotherapy is actually not going to kill all the myeloid leukemic cells that we have. And here comes the role of detecting minimal residual disease early, because relapse remains the main risk of treatment failure and cause of death. And the first chance is the best chance when it comes to us, especially in the developing world. So ma'am, Rachna ma'am, I would like to ask you, how would you interpret this report of bone marrow MRD 0.08%? Will you call it positive or negative?
Yeah, so I think I'll take it this way, that 0.08, if you take as your detectable thresholds, conventionally what is 0 positive. Conventionally follow many for 0.1 for AML. So, but at the same also technique, because you said this is for flow cytometry, the cutoffs would be much lower if you're using PCR, etc. But nevertheless, if you have to take a decision, I would still say that this is detectable at the once you've given a cycle, and translates into some disease that is still residual with the patient, and should translate, it should help you take a decision for the patient whether you want to escalate or not. So I would still say that conventionally if it is 0.01, you do have a detectable level of MRD.
Right. So in AML, usually, as you rightly said, 0.1% cutoff we take if we're measuring by flow cytometry versus the ALL where 0.1 is the standard cutoff we are using, and even lower cutoffs are coming now. So Dr. Arushi, like ma'am said, minimal residual disease, measurable disease. So what is MRD? Whether it is minimal or actually measurable, or both mean the same?
So actually, previously this abbreviation MRD stood for minimal residual disease, but recently this has been replaced, minimal has been replaced with the word measurable. Although there is very slight difference. With minimal, they used to mean that very small subset of malignant cell population is detectable after the therapy. And now when they use the term measurable, they mean to say that it is the amount of malignant clones that are detectable, which are measurable above a threshold, which has been set for that specific method or assay which is being used. So that is a slightly more precise term, technically more precise, but they can be used interchangeably. They more or less, they mean the same.
Yes, so they are actually used interchangeably. So what if the time point 1 MRD was 0.14%? Dr. Anuj, will it change the interpretation, or will it change something? What will you do?
Yes, so MRD cutoffs in AML are very, not as simple as like in ALL. So if you see the COG data, the MRD cutoffs uses 0.1%. That was the initial AAML 03P1 study, which showed patients at the end of induction 1, when the MRD is more than 0.1%, the outcomes were inferior. Then they subsequently divided patients into 0.1 to 1 and more than 1. More than 1% is definitely bad. 0.1 to 1 bit intermediate but inferior outcomes, and less than 0.1 outcomes do not differ much. The second is where if you see the just cutoff, second was by the NOFO-AML and they have took cutoffs of 0.5%. Then when you see the St. Jude data, they have taken cutoff of 1%. Initially they said 1, but when they realized it's 0.1. So majority of the studies come around 0.1% MRD as positive at end of induction 1. Second is how you interpret MRD in context of cytogenetics. This is not in ALL. ALL, any MRD doesn't matter, it's positive. But in AML, the significance of MRD is there in intermediate risk group only. It splits the intermediate risk group again into two. Either they will follow the low risk, that means chemo track, or HSCT track. If somebody is high risk, even if MRD is negative, you have to transplant. Intermediate risk, MRD positive, you will go into transplant track, MRD negative, chemo track. Standard risk, that means core binding factor AMLs, MRD positive, at the end point of induction 1 is not the actionable point. Check again at end of induction 2. So these are the
like you rightly pointed out, you have to stick to the protocol. Various studies, whether it is the Nordic study or the AIOP group or the Dutch group, AML, MRC, BFM group, all have shown that if you are at the end of induction 1 positive MRD, there is a very high risk of relapse later and overall survival definitely is low. But the cutoff you have to definitely take as per the protocol that is being used, because different protocols have defined the cutoffs slightly different. But 0.1% is taken as the standard. Dr. Ritu, I would like to ask you, so this child now has a MRD of 0.14% at the end of induction 1, and we proceed and give this child course 2 induction, again 3+7, and there are two situations. Suppose the time point to MRD is negative, less than 0.1, and other situation is if it is 0.12%. How will you proceed differently, or will your approach be same in this case?
So after induction 1, with our AML patient, most of the time it is expected that it would clear, even if MRD positivity is there post induction 1, it would clear after induction 2. So after induction 2 here, we have two situations. In first, the MRD has come out to be negative. So in such situation, if we have a favorable risk AML, then we would continue with our conventional consolidation like high dose RSC. And again, if it is not favorable, if it is intermediate or high risk, then we would think of, irrespective of the MRD positivity, considering the genetics, we would consider it to have an early allo HSCT and proceed in the same way. So in situation number 2, where there is only minimal reduction in MRD, in such situation, we would again reclassify it as MRD positive high risk AML, since MRD positivity after induction 2 has high chances of having relapse, and also it corroborates with adverse outcome. And so here it diversifies significantly the treatment strategy to transplant first strategy, and we would consider additional intensifying treatment in between before getting the patient
The second
into the,
MRD is positive. Yeah, so persistence of MRD positivity has more importance and more significance rather than just the MRD at time point 1. But definitely children who have MRD positivity at time point 1 do adverse compared to those who are MRD negative at end of induction 1. But the persistence is more important, and studies have shown that if you are MRD positive more than 1% at end of induction, or persistence of MRD positive more than 0.1% at end of induction 2, you should upgrade the child to a high risk protocol, and they warrant for a transplant, most of these. So Dr. Arushi, would you please elaborate the techniques of MRD detection in AML? So what we were discussing currently was a flow cytometry based approach. What other techniques do we have?
So first of all, as you mentioned, flow cytometry is the most commonly used method of MRD detection in AML, and it is applicable, it has wider applicability in around almost 90% of the children. And it has, although it has low sensitivity compared to other methods, 10 to power minus 3 to minus 4, but still it has a high predictive value of persistence of disease. If MRD is positive after therapy, if MRD has been done by flow cytometry, then it is highly predictive that the therapy has not been very successful. And apart from that, it has a low turnaround time and low cost, easy accessibility. Then other method is quantitative PCR, which is a better method compared to flow cytometry in terms of better sensitivity in the range of 10 to power minus 4 to minus 5. But the major drawback is that it is not applicable to all the kids because it requires a specific genetic mutation or fusion which can be targeted like NPM1 or PML-RARA in version 16, translocation 821. So apart from that, if we test bone marrow after therapy for MRD through PCR, then it can low positive persistent MRD can occur, and although the child might be in CR. So it can be a little confusing in that terms. Then other method is NGS, which has the best sensitivity, 10 to power minus 4 to minus 6, but it is obviously the cost and more turnaround time and lesser availability are the major limitations. Apart from that, it needs more expertise.
So right, molecular MRD is actually not available to all the children because only about 40% of them will have some molecular targets which we can measure in the MRD process. So flow cytometry actually is, can be done for all patients being treated for AML. So is there, yeah.
How to interpret MRD if the events are very less? Sometimes the bone marrow is done, say, on day 25, 26, platelets and ANC has not recovered much. And, you know, when neutrophils in the range of 700, platelets 60,000, events comes out to be very less in the MRD, and MRD is, say, 0.1. And the events are just 50,000. Can it be that with the good events, how much is the variability? Can it be 1 log difference with the less events, or?
I think we should repeat a marrow after a week and let the count recover because this MRD, prognosticating based on MRD is very important. So marrow should have adequately recovered if you are doing a flow cytometry based MRD test for assessment. So is there a concordance between the flow cytometry based MRD assessment versus the molecular ones, Dr. Alka Yadav?
So yes, MRD detection by flow cytometry we can detect at a bit higher level only. Like we can detect 1 in 10,000 events only. But by using more recent techniques like NGS and PCR based techniques, we can go up to a more significant level like 10 raised to power minus 5. Up to that level we can detect the events. So definitely if we are going to detect the patients who are more prone for a early relapse, so we have to go for more intensive techniques like NGS if available. But in the context of our country or like in our developing countries, since flow cytometry is much more easily available to our patients, so we can go and rely on that. And if the patient has come up positive, definitely the patient is a candidate for transplant in the first remission itself.
Right. So for most of us, maybe PCR based and NGS based MRD assessment is not available currently, but it may be available in near future. And studies have shown that PCR based assessment and flow cytometry based assessment are actually up to 90% concordant. And if both the assessments are positive, there is a high risk of relapse and it confers an overall poor prognosis. Similarly for NGS based, the difference for the residents here in the group, difference in a flow based MRD is that we are identifying based on the isotopes that are present over the cell, on the cell surface in a flow based MRD, while we are doing molecular methods and analyzing within the cell when we are using a PCR or NGS based targets. Though flow cytometry is definitely sense to be better in NPN1 mutated AMLs, but in other targeted lesions, if they are there, both have shown to be concordant. And very important, if there is persistence of MRD positivity by either molecular or flow-based methods, it definitely increases the rates of relapse and decreases the overall survival. Also, if both both MRD by 2 methods are positive, there is a high risk of relapse compared to if it is positive by 1 method, and definitely very low if it is negative by both the methods. So now coming to AML with recurrent genetic abnormalities, we know there is a whole list of these genetic abnormalities which, even if they do not meet the blast percentage, they still qualify for AML. AML translocation 821 is one of the most common ones here, and which usually confers a favorable prognosis. So Dr. Rachna, if this child was translocation 821 positive, would you have done something differently? Or would you have monitored this child in a different way?
So generally, if you go by I think we've been talking of, I think Anuj, you also mentioned that how important the cytogenetic classification would be. So I think in the earlier case also, I think that would be coupled with cytogenetics at every step.
Right.
So also this case, I think if you go by 821, definitely you will see it has a very favorable outcome. But it's not so simple as that. I think we all have experienced that 821
also relapse.
These patients relapse very, a lot of relapses occur. So I think the reasons are that one is that initially, yes, they would be chemosensitive, they would respond, but then there are a lot of other things. How do they clear? What is their MRD status? How well they are clearing? Then are there any associated, genetic abnormalities? I think known ones are, if it's only 821, then of course you will go by the MRD values and how well they are clearing. It's not that only one point, as you just said. It matters. It also depends at how well he's clearing, and does that translate into a negative MRD. The other would be other abnormalities like maybe KIT mutations, JAK mutations. So all that I think matters. And here I think, if I remember correctly, again then the fusion transcript, again then how do you in a quantitative way measure the response? There again it could
Will
be
you
a
also
PCR
add
based.
molecular-based testing here
Yeah,
for translocation?
So that is again a PCR, the role of PCR comes here in this particular, but I think we are all not doing it, but yes, there is a role. But I think what we can at least do clinically is see how well they clear and how sensitive they are and what is the MRD trends and the rest of the cytogenetic abnormalities. So I think that is how we would want. Otherwise, we do see a lot of relapses with 821.
So in translocation 821, we have clearly seen that even if MRD by flow cytometry is negative, it has cleared, but there can be persistence of translocation 821, which can remain even months or years after treatment completion. And there are studies to show that you can do peripheral blood testing every 3 months, and any positivity more than 50 in a peripheral blood sample, or if it is more than 150 in a bone marrow sample and persistent positive or rising trend, actually clearly indicates that there is a risk of relapse and the disease is going to come back. So we can pick up these children early on before frank relapse occur and maybe step ahead and initiate therapy for these children. So, Dr. Anuj, would c-KIT mutations, like ma'am said, affect a child who already has a translocation 821?
Yes, definitely. So KIT mutations confer them inferior prognosis to CBF AMLs, and I think recent COG 1831 study has for those patients with 821 and KIT are given total 5 cycles of chemotherapy. Otherwise, the core binding factors are given 4 cycles of chemotherapy. Till now, only presence of KIT doesn't warrant transplant. MRD based assessment will be done, and if they are MRD positive post 2 inductions, then only they are candidate of transplant. Otherwise, there has to be 2 induction and 3 consolidations. So that's total 5 cycles. Adult data has shown some survival benefit by adding tyrosine kinase inhibitors, but the data from pediatric is very limited. And regarding the following of PCRs for 821 transcripts, the St. Jude has a study, I think they have also said the same thing as you said. It's a trend which is more important and rather than absolute value. If a patient at the end of treatment is having PCR positivity but MRD negative, you can continue and do watchful monitoring as of now.
So what about AML with NPM1 mutations? Dr. Ritu.
So NPM1 alone is, as we know, is a favorable risk factor for AML.
Yeah.
However, if there is concurrent mutations alongside, just like FLT3-ITD or DNTM3, or even if it has a adverse karyotypes associated with it, then it upgrades the risk stratification and also makes it a disease with poor prognosis.
Right. And also this has to be taken along with the molecular MRD if available. So flow cytometry based MRD and molecular, because again, NPM1 mutations can persist, but if they are rising or any rising trend is seen, then definitely we need to upgrade therapy in these patients. So MRD directed treatment warrants intensification, and definitely it may be associated with survival benefit. And the GMA AML 1310 study actually showed that when the therapy was intensified, it led to better survival in these children. So, Dr. Ritu, what are the current treatment options available to us? If we detect a child early on with the alarm on MRD being positive, how would you proceed differently?
So, as we've discussed earlier as well, there is plenty of room to intensify the treatment, and also we have, I think, various options as well. Um, so, first we have, as we've discussed earlier as well, we have the fludarabine-based regimen, cladribine-based regimen also, and then anti CD33 also, and other targeted therapies like FLT3 ITD and all. But all these things also, as the earlier study showed, and then there are other studies also, if we go by risk stratifications, and also depending on what is locally adaptable to us as well. So that way probably we can get an optimal regimen for the intensification.
So yeah, so if it is a low risk MRD negative, we definitely continue with the conventional therapy. If as per the risk stratification it is high risk, we try to achieve MRD negative status, take them up for transplant. And the main role here comes in the intermediate risk, as we have been discussing. If they respond poorly, then we definitely intensify therapy regimens. We are going for a transplant, and we want the patients to be MRD negative as much as possible prior to transplant, because we know if MRD positive patient is taken up for a transplant, the risk of relapse is again very high. And various options that we have are the targeted therapies like gemtuzumab or FLT3 inhibitors, where the case is positive here. Venetoclax, as has been discussed in the previous discussion, also is quite promising. But whether it should be included in the upfront setting or not, that still needs more data. Hypomethylating agents, again, azacitidine is definitely being used. So these are the various trials which have included these targeted therapy, either in the upfront or in the relapse setting. So this question has been partly answered in the debate actually. I would still like to ask Dr. Alka, what would be your preference? So here we are not talking of a relapse setting, here we are talking upfront. You have a child who is MRD positive at the end of induction 2, and you know that this child is going to do poorly if we continue the conventional therapy. What modifications would you like to do? Will you add flag IDA or cladribine or venetoclax with azacitidine?
Okay, I think so. This thing has been already discussed in detail in the previous talk also. So, opting one over the other may be dependent on the availability as well as the preferences by the patients as well as the clinician who is treating. Because most of these drugs till now, what I feel is out of the reach of our patients, because I am coming up from a government setup, and most of our children, once they have relapsed after the induction, they don't opt for the therapy. They are the patients who opt for the therapy if they feel that there is a favorable chance of survival. So whatever we have seen, that most of these patients and most of these agents, even if we give 50 to 60% is the overall survival even after the maximal efforts. So definitely we need to look over the all the aspects, and I don't have any clinical experience on this. I can just tell based on the whatever the research or whatever the literature is there. So preferably, I think we should go for the less intensive therapy in our setups. So maybe flag, not preferably go for flag. We should go for venetoclax if it is affordable to the patient, and if there is some financial support from certain agencies like army, RN hospital, if the support is from the government is there, or if there is some other like insurance or anything. So
Dr.
preferably-
Anuj, what would you like to do in
Yes,
upfront
doctor.
setting? Not a relapsed patient has not relapsed yet. We don't want the child to relapse. So what can we do to?
So in upfront, if the patient is end of 2 induction MRD positive, I will offer first fluaracil, right till now. Fluaracil first time. If the patient is still having MRD positivity, then I will consider a cycle of venetoclax as a cytidine for the two reasons. One, it will give us some window of infection-free interval before HSCT. We can build up the nutrition, and these all things will help in HSCT. Also, if the MRD is declining and now it is hovering around 0.1, there is less role of further keep on giving cycles of intensive therapy. I think 0.1 level after one intensive block of like fluaracil, go for HSCT rather than keep on giving few further blocks, till the patient is getting invasive aspergillosis and, cardiac dysfunction sets in. GVL can take care. You can consider all the strategies which Dr. Satya sir also discussed, like, early tapering of immunosuppression. This will not work when the MRD is very high, say more than 1%. But around 0.1, it is hovering at the same level, you can go for HSCT. So till now in this setting, I will consider actually till now fluaracil. It still persists, then Ven-Aza after that.
Rachna ma'am, your thoughts?
So, Pranchi, maybe my views are a little different. So, this is you're talking of MRD positivity at end of second induction.
Yes.
So, this is not a relapse setting.
This is not a relapse setting upfront, because we want to pick up that alarm by which we can actually prevent
taken the
relapse.
decision that you need to transplant the patient. So, I agree with you that we all get patients like this from a low socioeconomic strata, and we can't use very expensive. Those are reserved drugs, but these are the protocols that I would keep for my relapse setting. But when I know the patient is fairly stable, has a high MRD, I need to transplant, I'll go ahead with high dose Araci.
Okay. Dr. Ritu?
So I would go maybe
your
at
thoughts?
a lower dose of 1.5 grams twice a day, and then you have to transplant the patient, and then just take the patient as soon for a transplant.
You won't consider adding maybe cladribine or
No, because
flag
it's
to
just
this?
on a lower, it's just a measurable MRD, and the child is fairly well, and
Yeah.
we often use these protocols, and we take the patient for a transplant as soon.
Dr. Ritu, your thoughts, please.
So what actually where I work is like it's below even less than the minimal resources are there. So in my practice, what I do, yes, I've started measuring MRDs. So, but even if the MRD is positive after second induction also, so I am continuing with the high dose Araci only because it's very limited. So there have been 2 patients so far. After first high dose cytarabine, there was a remission. So now they are continuing. They have completed the treatment and they are just in follow up. So I'll have to see how they will, fare out, or they will come with the relapse. Then I'll have to think
Dr.
of something
Arushi,
else.
you are from a private setting, slightly different from. I will not say actually different in India. I think it is everywhere. It's the same. Even if a patient is taking treatment in a private sector, still resource limitations are always there. But still, would you want to do something different?
Actually, I agree with Dr. Anuj. We would go for some intensification, like venetoclax Azaven. But with Azaven, I don't expect that MRD would come down drastically. So we may need to add some other agent like fludarabine or cladribine. But obviously, MRD is not totally, it does not give you a clear-cut picture. Even MRD negative, 1/4 patients who are MRD negative after induction, they relapse, and those who are MRD positive, some of them can survive even if you don't transplant them.
But what the data says, we have studies published recently also which say that adding flag or flag ida to the current intensive regimens do help these children and they have shown to have superior event-free survival. Again, venetoclax, as I cited in, usually what even I could make out, they have not been added in the upfront setting, usually in the relapsed refractory setting. But yes, they are well tolerated in children. And again, as was mentioned in the previous study, a recent paper published in Blood this month only, where they have combined FLAG-IDA along with venetoclax. But this again is a relapsed refractory setting. It's not. It is also for newly diagnosed AML, but this it had only 12 patients, a very small cohort. But yes, definitely it has been used in relapsed refractory setting. So I would like to conclude here and say that fighting AML, treating AML is like a battle. And we have to definitely be cautious of the alarms, especially the MRD, the alarm that MRD gives us. Have a risk adapted strategy for these patients, and only then we can conquer them. Thank you so much. Thank you all the panelists, and thank you House for the patient listening.
Thank you so much. Thank you so much, Dr. Prachi, an excellent panelist. Next, we have a session by Dr. Bernice O on status of CAR in acute leukemia Singapore experience. And joining virtually with us would be chaired by Dr. Sunil Bhatt. Is he going to join us virtually? Oh, no. I'm not sure. Okay, that's fine. So we have Dr. Bernice with us, and she's going to talk on acute leukemia. Can we have a round of applause for Dr. Bernice, please?
Good afternoon, everyone. My name is Bernice. I'm a consultant in the division of Peds Hem Onc in NUH in Singapore, and I also direct the immune cell processing unit in NUS. So, big thank you to Dr. Vikas as well as organizers for inviting me today, and also for the very warm welcome. So the CAR T-cell program in NUS is primarily centered in the fact that we can perform in-house manufacturing of CAR T-cells and viral vectors. So I lead this effort in the team. I lead a small team of cell engineers where we perform really personalized cell manufacturing in a GMP-certified facility in NUS. So this allows us to do rapid clinical translation of novel CAR T-cell constructs. So our facility is a certified GMP grade D clean room. And within this clean room, we operate within an isolator that gives us a smaller Class E environment where we manufacture CAR T cells. So we are strategically positioned it within an academic lab, which is really close to the hospital wards. And this allows us to really bring the start products from patients directly to our lab, which is just a small road across, where we do cell processing for these patients. So we primarily work with retroviruses, and the manufacturing method is mostly manual, and products are actually frozen after manufacturing for us to clear QC testing as per the GMP requirements. So just to start on BALL. So on screening patients with BALL, we observed two patterns of target antigen expression on flow cytometry. The first, as you can see above here, are patients who have a homogeneous high CD19 expression BALL. The second are patients who have high CD19 expression, but yet we can detect a CD19 negative clone. And in quite a lot of instances, these patients, these CD19 negative clones also express CD22. So if we were to only give CD19 CAR T cells to these patients, this would usually lead to a later on CD19 negative relapse. So in order to tackle this issue, we use the immunophenotype guided CAR T cell therapy approach, where patients with uniform expression of CD19, more than 99.9% on flow cytometry, we will give them 1 million per kg anti-CD19 CAR T cells. For patients with incomplete CD19 expression, but have complete CD22 expression, we would give them a combination of CD19 as well as CD22 CAR T cells. And all the CAR T cells that we use have a 4-1BB co-stimulatory domain. So in the study that that is still ongoing, we did an analysis of 41 patients. So 32 patients were treated with only CD19 CAR T cells, and 9 patients received both CD19 as well as CD22 CAR T cells. Of these patients, 9 in total received stem cell transplant consolidation. For the baseline characteristics of this analysis, the median age was 9 years old. We included patients as young as 1 year old up to age of 20. And in a further subgroup analysis between the patients who received CD19 as well as CD19 and CD22 CAR T cells, we observed that patients who needed 2 CAR T cells were actually more heavily pretreated. A lot of them had, a few of them had relapsed refractory disease post-transplant, and many of them actually had more lines of therapies prior. And in addition, we also found that a higher proportion of patients had a higher disease burden entering CAR T cell therapy. So of the 32 patients who received CD19 CAR T cells, 24 remained alive in CR at the point of analysis. There were 7 relapses and 1 death in CR. Of the 9 patients who received both CD19 and CD22 CAR T cells, 5 remained alive in CR and 4 relapsed. So overall, we observed really durable CRs. The longest CR that we have is almost 7 years, with a fairly low incidence of CD19 negative relapse, which is what we set out to achieve. With a median duration of follow-up of 32 months, we report a 2-year overall survival of 86% and a 2-year event-free survival of 78.5%. When we analyze based on the subgroups, we observed that patients who received both CD19 and CD22 CAR T cells actually did a little bit poorer. Although this was not statistically significant, but I think this is attributed to the fact that these were a lot more heavily pretreated patients with a much higher disease burden at presentation, and that's probably the reason why the outcomes are not as good. In terms of toxicities, we observed manageable toxicities for the entire cohort. ICANS, although the incidence was slightly higher, they were all fully reversible. And we also observed that the addition of CD22 CAR T cells did not lead to any increased toxicity. So in summary, we observed excellent clinical outcomes with our immunophenotype guided approach that is comparable to other published CD19 and CD22 B-ALL CAR T trials. Our results suggest a trend toward a lower incidence of CD19 negative relapse, and the addition of anti-CD22 CAR T cells does not increase the incidence of CAR-related toxicity. So moving on away from B-ALL to T-ALL. As you all know, T-ALL is a lot more difficult to treat, especially in the relapse refractory setting. And we identified CD7 as an ideal target for T-ALL because it is highly expressed in more than 95% of T-ALL cases across various T-ALL subtypes, including the very high-risk ETP-ALL. Expression of CD7 is maintained during chemotherapy and at relapse. However, CD7 is also expressed on normal T lymphocytes, including the very T cells that we would use to express the CAR. So what is fratricide? So as you can see in this diagram here, this is a normal T cell that expresses CD7. And these T cells would then be used to make CAR T cells. And these CAR T cells would end up also expressing CD7. And when combined, these CD7-directed CAR T cells will all start killing each other. And this is what we call CD7-directed fratricide or self-killing. And this would lead to a very low number of CAR T cells with a very low efficacy. And so our group worked to circumvent this issue by developing the CD7 Pebble CAR T cells. So Pebble stands for Protein Expression Blocker Ligand. So this is actually linked to the actual CAR construct using a P2A cleavable linker. And this is added on to the actual CAR as compared to the CD19 CAR that you can see here. So what does the pebble do? The pebble actually helps to retain CD7 protein within the Golgi apparatus of the cell, and therefore the CD7 antigen will not be able to move to the surface and therefore will not be expressed. And therefore these cells would be CD7 negative. So we published our results recently on the use of these CAR T cells in patients with TLL. So this was an international collaboration with the Bambino Gesù Hospital in Rome with our collaborators, Prof. Franco Locatelli, as well as Dr. Francesca Del Bufalo. The cells from Rome were shipped to Singapore for manufacturing in NUS. We then shipped the manufactured CAR T cells back to Italy for infusion in Rome. So within this study, we treated a total of 17 patients because TLL is much rarer than B-ALL. 12 patients were treated at NUH in Singapore, and 5 patients were treated in Rome. We included both children and adults in this study with a wide age range, the youngest being 2 years old and the oldest being an elderly gentleman, 71 years old. We treated a total of 13 children and 4 adults. 10 patients had TLL relapse after transplant, and 4 had persistent MRD after relapse. 3 had primary refractory TLL, and all these patients had received more than 3 lines of prior therapy, so all really heavily pretreated patients. 16 of these 17 patients actually achieved MRD negative remission within 1 month. The single non-responder that we reported had a CD7 negative TAL cells before infusion, and therefore we observed that once we gave the CD7 CAR T cells, what was left was really a rapid expansion of the CD7 negative clones. As you can see in the diagram here, patients, when we compared the CD7 patients to the patients with B-ALL who received CD19 CAR, patients with TLL had a much higher disease burden, and similarly we saw really rapid clearance of MRD after CAR T cell therapy. And to us this was a real game changer because, as you know, relapsed refractory TLL, if disease remains refractory, it's really a historically fatal disease. So at the time of analysis, with a median follow-up of 15 months, 11 patients remain alive and leukemia-free. 9 patients received stem cell transplant. 2 patients remain in continuous remission without a transplant for 7 and 55 months. Following CAR T cell infusion, we also observed that the anti-CD7 pebble CAR T cells demonstrated robust in vivo expansion despite a lower infusion dose. So for CD19 CAR T cells, we usually infuse 1 million per kg, but for CD7 CAR, we started out with a very low dose of 500,000 per kg, and that really started from us doing first-in-human studies with a CD7 CAR, and we didn't quite move on from there. So we thought that 500,000 per kg would be enough. And true enough, we saw higher peak levels in anti-CD19 CAR T cells beyond day 7, and long-term persistence in 1 patient for up to 2 years without HSCT. We also observed that these patients had a better side effect profile than the patients who received CD19 CAR. There was no CRS that was more than grade 3, and we specifically, we saw that there was significantly lower ICANS as compared to CD19 because considering the high disease burden of these patients, only 2 patients had grade 1 ICANS after CD7 CAR infusion. A key concern that we had when we first started giving patients CD7 CAR was that there was going to be a high potential for prolonged T-cell aplasia, creating like a bubble boy, severe immunodeficiency kind of features. But in this study, we saw that immune reconstitution occurred despite the persistence of CAR T cells. CD7 negative T and NK cells emerged during CAR T cell persistence, and regenerating T cells were polyclonal with diverse TCR repertoire. So somehow the body is able to produce normal T cells just without CD7. And for long-term reconstitution, the first patient that we treated, that we follow up for more than 4.5 years without a transplant, actually showed a normal naive and memory T cell distribution at 4 years, and also had a normal response to COVID vaccination at 25 months, which we found really interesting. So in terms of treatment failures in this cohort, 3 patients experienced TALL relapse. 2 patients actually relapsed with CD7 negative TALL, and 1 patient had CD7 negative cells before infusion. Another one developed CD7 negative relapse 3 months post-therapy. And 1 patient actually relapsed with CD7 positive disease at 12 months, first in the CNS, then systemically. 3 other patients died while MRD negative. Really, this is a reflection of how heavily pretreated this population was. One from disseminated fungal infection shortly after CAR T-cell therapy, and another from neurological complications with a strong history of recurrent CNS disease. So we report that higher pretreatment leukemia burden of more than 50% in the bone marrow was associated with an increased risk of relapse that is similar to observations in CD19 CAR T-cell therapy. So what are some of the advantages of this Pebble CAR T-cell approach? Number 1, it is clinically very efficient. We saw a very high MRD negative clearance rate in this very heavily pretreated population. The safety profile, we observed that there was really low rates of severe CRS and ICANS as compared to patients who received CD19 CAR T cells. And in terms of manufacturing simplicity, because you can see that this is a bicistronic construct that not only contains the CAR but also the Pebble, we are still able to manufacture this using our established CAR T cell manufacturing protocol. In addition, an autologous approach which we used actually avoids graft versus host disease and rejection issues associated with allogenic products. So for future directions for our group, we are working on developing novel CAR T-cell constructs to improve efficacy and persistence, because as you can see from our BALL results, the bulk of our relapses were related to CD19 positive relapse and loss of CAR T-cell persistence. So really that's the issue. And we are also hoping to expand the indications for CAR T-cell therapy beyond leukemia to lymphoma, breast cancer, and hopefully neuroblastoma as well. And we also hope to look beyond cancer therapy to patients with autoimmune diseases like SLE or even IBD. And last and not least, we are also trying very hard to try and lower the cost of cell manufacturing to increase accessibility of CAR T-cell therapy for our patients. Thank you.
Thank you so much, Dr. Barnes, for such an insight. And next we have Dr. Sandeep Jain with us, who is going to talk about why is anything not enough, when nothing is ever simple, and he's going to make it simple for all of us. So can you have Dr. Sandeep Jain is here? Can you have a round of applause for him, please?
Okay. Very good evening, everyone. At the outset, I'm really thankful to organizing team for giving me this opportunity, and I have been assigned to speak on T acute lymphoblastic leukemia, why anything is not enough. Actually, when I thought about this topic, I was wondering, is it really so? Because in today's time, around 80 to 90% of the children may be expected to have good long-term outcome with intensive chemotherapy. It is only 10 to 15% of the patients, those who have high-risk disease or refractory disease, whatever we do may sometime be not enough. So in next 15 to 20 minutes, I will be trying to show how we have achieved an outcome of 80 to 90% in most of the patient, and what are the options that we have for the rest of the patient. So we all know that TALL accounts for around 15 to 20% of all ALL. Historically, the outcome of TALL is somewhat inferior to other counterparts, that is BALL. However, with the contemporary intensive protocol, the outcome of TALL is almost equivalent to BALL. So I shall be discussing some clinically relevant issues in the management of TALL, like what progress we have made so far in terms of genetics, how do we give induction, how do we interpret end of induction and end of consolidation MRD, what are the indication of stem cell transplant and granularity, and how can we incorporate newer agent to improve outcome of high risk and refractory disease. So, if we start with the genetics, till 2008 there was no subtype of TALL. In 2016, for the first time, ETP was added as provisional entity, and it was modified in 2022 as BCL11B activated and not otherwise specified. At the same time, in 2022 classification, 8 new genetic alterations were also added, which are now included as provisional entity. So if we have to summarize the WHO 22 classification for TLL, it has comprehensively integrated morphology, immunophenotype, genetic and molecular information to classify TLL. However, it should be noted that none of these clinical variables or genetic alteration that we have been able to identify on NGS or genomic profile have been consistently proven to be of prognostic significance. They are not used for decision making, they are not there in the treatment algorithm. So it is just for the theory right now. So now let's start with the induction chemotherapy. Like in BLL, we know standard risk BLL, many protocol use 3-drug induction, and it has been tested and tried in the TLL as well. It was first tested in the UKLL 2003 trial, and the patient, those who received 3-drug induction, had inferior outcome, 80% compared to 86% who received 4-drug induction. And this was again tested in the CCG trial also, and similar results were found. So all contemporary protocol now use 4-drug induction for TLL. However, type, dose and schedule of these anthracycline that we use in induction vary, and they have not been tested head-to-head in clinical trials. Another contentious issue in the induction is the type of steroid that we have to use. So we all know that dexamethasone is definitely more potent compared to prednisolone, has better CNS penetration, but at the same time it is more immunosuppressive, and therefore leading to more chances and predisposing our patient to infectious complication, and thus leading to induction mortality. So it is imperative to test dexamethasone versus prednisolone, and it was tested in the 2003 UK ALL protocol, and the patient, those who received dexamethasone, has better event-free survival, that is 90% compared to 78% those who received prednisolone. Then it was again tested in the BFM backbone also, and where 10 milligram per meter square of dexamethasone was tested against prednisolone of 60 milligram per meter square for 21 days. The patient who received dexamethasone had 2% more induction mortality, but at the same time were associated with 6% improved relapse-free survival. So if we look at this UK and BFM data, it is very clear that dexamethasone is somewhat better in improving event-free survival. So, but is also associated with more mortality in the induction. So can we reduce this mortality by truncating the dexamethasone dose? And it was tested in the UK ALL 2011 protocol. Here, patients were randomized to receive 10 milligram per meter square of dexamethasone versus 6 milligram per meter square of dexamethasone. Surprisingly, the results were not favorable. In fact, there was more toxicity with the truncated dose of steroid, which could not be explained, but it did not help. So post-induction now, we have to assess the disease, and we know that end of induction MRD has proven to be a very powerful tool in assessing long-term outcome in patients with BALL. However, the kinetics of MRD in TLL is somewhat different from BALL. Like in TLL, end of consolidation MRD is far more important than end of induction MRD. It has been shown in BFM 2000 trial also, where patients with TLL who had negative MRD at day 78, that is less than 0.01, had almost similar outcome irrespective of MRD at day 33. So does that mean that end of induction MRD doesn't have any significance? No, it is not so. So how can we incorporate end of induction MRD in our treatment algorithm? So it can be helpful to identify low risk patient. So patient, those who have negative MRD at the end of induction, can actually be treated with the standard treatment and don't need intensification. So if I have to summarize the induction, the lessons that we have learned in the TLL, 4-drug induction is a standard of care. Dexamethasone is preferred over prednisolone. End of consolidation MRD is far more important than end of induction MRD. And negative end of induction MRD can be used for disstratification and treating the patient in the standard manner. Now coming to the consolidation. So it has always been a matter of debate to use high-dose methotrexate and Capezi. And in the old POG study, it was shown that high-dose methotrexate is better than no methotrexate. But it was not proven whether it is better than Capezi or not. And there are some small center studies which have compared high-dose methotrexate with Capezi. But because these are retrospective studies, sample size is small, no meaningful conclusion can be deduced out of it. The first largest evidence that we have got, which have compared high-dose methotrexate with Capezi, came from the CCG study, where these 1895 patients were randomized to receive either Capezi methotrexate and high-dose methotrexate. And in this trial, the patient, those who received Capezi, had better outcome, around 91%, compared to 85% those who received high-dose methotrexate. But we have to interpret all this data with very caution, because these results are obtained in a very specific protocol with a augmented BFM backbone and a very precise timing of radiation. And these may not be extrapolatable to all setting and all regimes. And moreover, we don't have any pooled randomized control trial or meta-analysis to show efficacy of one over the other. And in our setting in the low middle income country, we again have to be very careful, because we have to intensify treatment depending upon the supportive care infrastructure that we have, because we know high dose methotrexate requires methotrexate level monitoring and also management of toxicity. So decision to eliminate high dose methotrexate or include Capezi should be based on the supportive care infrastructure that we have at our hand. Then next issue is the indication of cranial radiation. We know that TLL is associated with more risk of CNS relapse. Conventionally, all the patients with TLL were subjected to cranial RT, but with intensification of the treatment, many protocols have been able to eliminate it. The first one was EORTC, and then St. Jude protocol, Dutch and UK ALL have been able to eliminate cranial RT for most of the patient. Again, when we have to decide about eliminating cranial RT from our protocol, we have to do it in the context of systemic chemotherapy. Because the protocols that have been able to eliminate cranial RT have intensified the systemic therapy in terms of intensification of asparaginase, inclusion of dexamethasone, additional intrathecal chemotherapy, and systemic dose high-dose methotrexate. He is not in Singapore. He is in Bangalore. He is here. Okay, I will. Do you want me to acknowledge him? So can you show him here? Yeah. I think Dr. Sunil Bhatt is online, and he is chairing this session virtually, and they want to show him once. So basically, the decision of eliminating cranial RT should not be ad hoc. It should be based on the intensity of chemotherapy that we are providing. And most of the protocols that have been able to eliminate cranial RT from their protocol has been because of the intensification of their frontline treatment. So if we look at the indication of cranial RT in TALL, in COG, it is only given to patients with CNS 3 disease. However, in the BFM backbone, in addition to CNS 3 digits, it is also given to patients who have more than one leg count at the time of diagnosis. So now coming to the indication of transplant in TALL, conventionally all the patients, those who were induction failure or those who had M2, M3 marrow at the end of induction were subjected to transplant. But with the MRD based risk stratification, the indication of transplant in TALL have clearly evolved. If we look at the North American protocol, the patient who have M2 or M3 marrow at the end of induction and 0.1% at the end of consolidation, the transplant is recommended for this patient. So again, it is highlighting that the end of induction MRD is not that crucial. It is the end of consolidation MRD in TLL which helps in decision making. And if we look at the UK ALL protocol, it is the cutoff is at the end of induction, and if end of induction MRD is more than 5%, they subject this patient to transplant. And of these also, for patients those who are more than 16 years, less than 16 years and have MRD at the end of consolidation less than 0.01, they are not subjected to transplant. So if we look at the cutoff of transplant, indication for transplant, it is 0.1 after consolidation in North American protocol and 0.01 in UK protocol. Things are much simpler for the relapse ALL, and transplant is indicated for most of the patient. Just one slide about ETP-ALL. We know it accounts for around 10% of all T-ALL. It expresses a unique immunophenotype composed of early progenitor cells and myeloid marker. These patients generally don't have Notch pathway mutation, which is associated with the good outcome. With today's conventional treatment, the outcome of patient with ETP-ALL is almost similar to non-ETP-ALL. It is very interesting to see that the patient, those who have ETP-ALL, are more likely to have M3 marrow at the induction and also have high MRD. So in this COG 0434 trial, only 18% of ETP-ALL had negative end of induction MRD compared to 70% of non-ETP TALL. But if you look at the outcome was similar irrespective of early response. Unlike in BLL, where we know that early response is so important, in TLL it is not so. Again, emphasizing that end of consolidation MRD in TLL is far more important than end of induction MRD. So we have seen that with all these lessons that we have learned in the management of TLL, outcome of 80 to 90% can be achieved. But for 10 to 15% patients, those who have high risk or refractory disease, what options do we have? Let's talk about the role of nelarabine. This was first time tested in the COG study, where 659 patients with intermediate risk and high risk TLL were subjected to 6 5-day courses of nelarabine in consolidation and maintenance. And if we look at the outcome, the patient, those who received nelarabine, had a better event-free survival, 88%, compared to 82% those who did not receive nelarabine. And if we see the benefit, the main benefit was in prevention of CNS disease. The patient who received nelarabine had just 1.3% chance of relapse in the CNS compared to 6.9% for patients those who did not receive nelarabine. So again, this data is again to be seen with caution, because in this trial, the patients were only intermediate risk and high risk patient. Low risk TLL patients were not tested, and there was no advantage of adding nelarabine to high risk T lymphoblastic leukemia. It was just limited to leukemia only, not lymphoma. And then one major difference in this trial was actually the benefit of capizimethotrexate, and nelarabine was on a prednisolone-based backbone. All other trials were using dexamethasone in the induction, so if that could have made any difference, we don't know about it. Then also Capigi arm received additional vincristine and pegaspargines, and this also might have contributed to better event-free survival in that arm. And for us in the low middle income country, we have to understand that this improvement with nelarabine is small, meaning a large number of patients need to be treated to benefit a single patient, and therefore we need to identify subset of patients who are likely to benefit with addition of nelarabine. This is one again meta-analysis which has shown the efficacy and safety of nelarabine in relapsed refractory patient, and it has also shown that it is quite effective but needs more research for its optimum application. So if I have to show how the North American and UK protocol are incorporating nelarabine, in North America, all patients that are intermediate risk or high risk are being given nelarabine with BFM consolidation, and the patient, those who have more than 0.1% MRD at the end of consolidation, are subjected to transplant. In UKLL, the indication of adding nelarabine is more than 5% MRD at the end of induction, and if the end of consolidation MRD is more than 0.01, they are candidates for transplant. So in UK, there are lesser number of the patients, those who are getting nelarabine compared to North American protocols. So if I have to summarize the nelarabine issue, it's effective in high risk and refractory TLL. It offers a survival benefit of around 6 to 8%. But in our setting, we have to identify more specific subset where nelarabine could be really useful to justify the cost effectiveness in our setting. And in relapse setting, definitely it has much more role compared to frontline therapy as a bridge to transplant to induce remission and take them for transplant. So another agent that we have in the refractory TALL is bortezomib. So this was first tested in the BLL in 2 pilot data in the COG study, and had shown a response rate of around 73% with VP-LD chemotherapy. Then it was tested in the TALL also. Here again the response was around 64%. Based on these two data, actually this was tested in the COG study in the upfront setting. And if we see The upper graph shows outcome in the ALL and the lower in the lymphoblastic lymphoma. There was hardly any difference between event-free survival and overall survival in patients with T-ALL. However, it was much more effective in the lymphoblastic lymphoma. So bortezomib is also a promising option in the T-ALL and as a salvage option in the T-ALL, but with the encouraging result of nelarabine, role of bortezomib in frontline therapy needs more study. In fact, the study that I showed just before this also was prematurely closed because the results of nelarabine study were out by then, and they have found that nelarabine is more effective, and the patient, those who were in bortezomib, were actually transferred to the nelarabine arm. Other options that we have for refractory TLL are like venetoclax, navitoclax, and mini hypercVAD. There are more data for this in the adult population compared to pediatric population, and it has been used as a useful bridge to transplant. Then other option we have daratumumab, which is anti-CD38. Around 40% of TLL express CD38, and daratumumab can be used as a targeted therapy to achieve remission and take them for transplant. Then for patients with ABL, JAK mutation or ETP, dasatinib can also be an option. I found this one interesting study which is going on in China, which has included venetoclax, dasatinib, and homohedronine. This is a translational inhibitor, a tyrosine kinase inhibitor, which is like effective after failure of two previous lines of TKI. And the initial results are very promising, and it may provide useful insight in future as an option for refractory TLL. I think I can skip this because Dr. Bernice has just given a very beautiful talk on CAR-T, how what progress we have made in terms of CAR-T, both in B and ALL. We know that the results are much more promising in the BLL. We have some challenges in the TLL, but in times to come, I think we will overcome this challenge and it will be effective for TLL as well. So if I have to summarize the refractory relapse TLL algorithm, what option do we have? We have Nectar, we have bortezomib with PVDL, daratumumab, venetoclax, navitoclax with hypercVAD, and CAR-T. So whatever salvage we use, the aim is to achieve negative MRD status, subject patient to BMT, and in BMT we have to use TBI-based conditioning. And post-transplant, we should try to withdraw immunosuppression early so as to induce GVL. So to conclude, I think we have made a lot of progress in the management of TLL. Dexamethasone-based induction with 4-drug is standard of care. Patient of ETPLL should be treated with the same as their non-ETP counterpart. End of consolidation MRD is far more crucial than end of induction MRD. Use of nelarabine should be considered for high-risk TLL. Cranial RT to be given only for CNS3 patient, and consider transplant for patient with persistent disease after consolidation chemotherapy. Thank you.
Thank you so much, Dr. Sandeep Jain, for the insight. It's time for a quick short break. We'll take a 10 minutes tea break. Go caffeinate, hydrate, oxygenate yourself, and be back in 10 minutes, please. Thank you. Everyone, please settle down. We are starting with our next session. Everyone is oxygenated and caffeinated after tea and coffee? Yes, no, maybe? No response. Doctors? Okay, we have Dr. Nivedita Dhingra with us. She is Director Hematology and BMT, Yashoda Hospital, Yashoda Medicity, and she's going to talk about early identification and optimizing management. So can we have Dr. Nivedita Dhingra and a big round of applause for her, please? Thank you.
So at the outset, I'd like to thank the organizers and especially Dr. Vikas for always remembering me in his pediatric sessions. And so a disclaimer that these slides that I'm using have been provided by Novartis. So I'm going to talk about chronic GVHD management, optimizing the outcomes with ruxolitinib. So chronic GVHD is a condition with which we have struggled a lot. And even after doing a successful transplant, the patient does not get an optimum quality of life because of the debilitating complications of chronic GVHD. And I think this was a great unmet need, especially in cases where there was steroid refractory disease. So we're all pretty familiar with the classification of GVHD. When it happens in the first 100 days, it's classic acute GVHD. After that, it could be classic chronic, but now with the increased use of reduced intensity conditioning transplants, we could have de novo late acute, we could have recurrent late acute, persistent late acute when it persists beyond the designated time frame, and then there could be an overlap scenario between acute and chronic GVHD. One of the strongest risk factors for development of chronic GVHD being the development of acute GVHD. So GVHD is basically an immune reaction following allogenic transplant. The donor-derived immune cells which are present in the graft, they recognize the recipient's body as foreign and attack the normal cells. And it is basically a play of the various pro-inflammatory cytokines which drives the clinical manifestations of chronic GVHD. So the risk factors, again, acute GVHD being one of the strong risk factors. Older children tend to have lesser acute and chronic GVHD as compared to their adult counterparts. We are doing more and more unrelated donor haploidentical transplants, we are likely to see more GVHD. Most of us have now, from the time when I was training where we used to go to the OT and do the bone marrow collections, now most of us have moved towards peripheral blood stem cell transplants due to the ease which they offer and the good dose that we get. So that is a risk factor for chronic GVHD. And now we have better supportive care. So patients are surviving more to actually develop the manifestations of chronic GVHD. And female versus male donors are associated with a greater risk of GVHD. So where are we currently? So in chronic GVHD, along with management, sometimes the challenges that I think we face are how to be objective while grading it. And that objectivity is very important because that will also determine how we are able to assess the response to treatment. So basically, we use the NIH consensus guidelines to make a diagnosis, which is very organ specific and very clear to understand. Each organ gets a designated score, and then you have a global score based on which you decide whether it is mild, moderate, or severe chronic GVHD. So you need to have certain diagnostic manifestations which are sufficient by themselves to make a diagnosis. Other than that, they could be distinctive, which are clinically suspicious, and sometimes you need special tests, sometimes you need biopsies, not only to make a diagnosis, but more importantly, sometimes to rule out other etiologies. If you're not finding anything else, you assume it to be chronic GVHD. So a lot of clinical judgment is also required in addition to the diagnostic and distinctive manifestations. So skin, mouth, hair, nails, Eyes is a very common site. Genitalia has to be examined. The GI tract, both upper and lower. Lung is one of the difficult sites to treat. It's one of the dreaded complications of transplant, having lung GVHD, musculoskeletal system, fascia, hepatic chronic GVHD, and then various non-specific abnormalities, immune-mediated, cytopenias, eosinophilias. So they can be nephrotic syndrome, even myasthenia gravis can be clinical manifestations of chronic GVHD. And this is a performer that is available with which we do an objective scoring of GVHD organ-wise, and then we compile the score to see whether it is mild, moderate, or severe. So up to 2 organs or sites with a score of 1 is mild GVHD. So it's essentially mild oral symptoms, mild dryness of eyes, needing lubricants less than equal to 3 times a day. So you have 3 organs with a score of 1, it becomes moderate. Any organ with a score of 2, it becomes moderate, and lung score 1 is moderate. Severe GVHD is any one site with a score more than 3 or a lung score of 2. Unfortunately, most patients that we see in clinical practice present to us with moderate to severe GVHD. So only approximately 20% of the patients come with mild GVHD, and most of the patients that we see fall in the category of moderate to severe, with mouth, skin, liver, and eyes being the most frequently affected organs. So NIH response assessment should be done on application of therapy. This is important to understand because based on this, we decide whether to escalate treatment or not. So complete responses when there are no manifestations, including fixed defects. Partial responses, you are seeing a meaningful improvement in one side but worsening in the other, and stable diseases rest all of it. So treatment is basically designed, so basically what we say is that chronic GVHD replaces one illness with another chronic illness. So the overall goal of treatment is to give a good quality of life to the patient, and the treatment should not be too toxic because chronic GVHD by itself could lead to non-relapse mortality and hamper your transplant outcomes. So up until very recently, the guidelines what we had available to us, so if you're making a diagnosis of moderate to severe chronic GVHD, you have to, steroids form the first line of treatment with or without your CNIs. And if somebody was already on steroids or CNIs, unfortunately, there was no standard therapy, mycophenolate, ibrutinib, ECP, rituximab, whole basket of options for us to choose from, with none being more effective than the other. So how do we see 50% of the patients become refractory to first-line therapy, and how do we define steroid-resistant GVHD? So anybody who's been on a steroid dose of prednisolone equivalent of 1 or more than 1 milligram per kg per day has progression within the 1 to 2 weeks, or somebody who has stable disease despite receiving more than equal to 0.5 milligram per kg per day of prednisolone for 1 to 2 months, or there is an inability to go down below a certain dose of 0.5 milligram per kg per day on 2 attempts to taper the steroid at least 8 weeks apart. That is another scenario where you say that it is either steroid refractory or steroid dependent. And this warrants a change, or there is unacceptable toxicity happening because steroids, as we know, they are associated with a vast array of some side effects which can be very distressing. So our goal is to take the patient off steroids, prevent the steroid toxicity. A lot of times I see patients, even in routine clinical practice, who have AIHA and who've been taking steroids for ages without realizing that steroids are equally toxic, as probably more toxic than having, a course of rituximab. So a long-term steroid therapy is often something that is not desirable because it's associated with an increase in non-relapse mortality when you have steroid-resistant or dependent GVHD, and it's associated with a poor 10-year-old steroid refractory GVHD is on itself associated, it increases the risk of mortality and reduces the overall survival rates. So we are all well aware of the side effects of steroids. They can be endocrine, musculoskeletal, immunologic, cardiovascular. But now we have, in 2025, we do have some new drugs which are likely to change the landscape of how we manage chronic GVHD. So anybody who fulfills the criteria of steroid refractory chronic GVHD, now we have ruxolitinib available to us, and it is on the basis of the REACH-3 trial, which I'll be discussing shortly. Then another drug based on the Rockstar study, belmosudil, is available to us, and ibrutinib is also one of the options, of which ruxolitinib is the preferred agent. So the REACH-3 study design, this was a study that was done. It did include a few pediatric patients who were 12 to 18 years of age, but it was essentially an adult study where those who were above the age of 12 years who had steroid refractory or dependent GVHD as per the standard guidelines, they were randomized to either receive ruxolitinib in an adult dose of 10 milligram twice a day, along with steroids plus minus a CNI, versus best available therapy, which was between the 10 options that were available depending upon physician's discretion and choice, which often varies on the site of chronic GVHD, experience of the center, comorbidities. So based on availability, a lot of times like ECP is something which is not available to us at least. So based on that, the best available therapy along with steroids or CNI, response assessment was done at week 24, after which the patients could cross over to the ruxolitinib arm. Primary endpoint was the overall response rate at week 24. Key secondary endpoints were failure-free survival. Basically, failure-free survival took into account any new treatment for GVHD that was required, death or disease recurrence, and modified Lee symptom scale, which is specially designed for this group of patients. At least a reduction of 7 points or more was recorded. So what was seen was that at week 24, the primary endpoint was met. The overall response rate was significantly higher with ruxolitinib, which was almost double the best available therapy. So 50% versus 25%, which was significant. And out of the responders, majority had a partial response, few patients having achieved a complete response. So still there is a lot of scope for improvement. And this response was seen across all subgroups, regardless of the age, younger versus older patients, sex, prior acute GVHD. One thing to note is that if you've given other systemic therapy, then the responses are likely to be less. So earlier incorporation of this drug is probably what will give better results. Regardless of the type of conditioning, T-cell depletion, stem cell source, whatever the donor mismatch status, sex mismatch, this drug showed effectiveness. And what was heartening to see was that it was effective across all major sites of chronic GVHD. Although the responses were more marked when we look at sites such as the skin, the mouth, the lower GI, and the esophagus, being less marked in sites such as the liver and the lung, but the number of patients was less. So failure-free survival was better. So ruxolitinib represents an FDA and EMA approved valuable second-line option. But 40%, especially those who will have ruxolitinib refractory disease, they're going to be a challenge. And even when we use this drug in the management of myelofibrosis, which we commonly use, it has its own side effects. So which was the case seen here also, that the patients who had been on the ruxolitinib arm, they had more adverse effects, but yes, they were of course on treatment longer also. The average duration of treatment with ruxolitinib was longer than the best available therapy that was given. More patients were able to reduce their steroid dose over time by week 24. And as expected with the drug, anemia and thrombocytopenia were the most common adverse effects, others being pneumonia and neutropenia. If you look at the profile of infections, viral infections was most common, followed by bacterial and then fungal. But the incidence of CMV reactivation was similar in both the arms. So based on these results, the authors conclude that ruxolitinib, it represents a viable option for patients who have steroid refractory chronic GVHD. The results that have been seen in acute GVHD have been they've also been seen in chronic GVHD. So better overall response rate, better best overall response rate, significant improvement in failure-free survival, more patients being able to taper their steroids, which is one of the important goals. So it does define a new standard of second-line treatment, but we do need biomarkers to predict its response, and clinical decisions should also be based on patients' risk profile, organ manifestations. So I'd just like to show, since I manage both pediatric and adult patients, with regards to adult chronic GVHD, I would like to just show a case briefly. So this was a 42-year-old male who had earlier undergone treatment with me for Burkitt's lymphoma. 2 years down the line, he presented with therapy-associated MDS, and he had a very high VAF for P53. He underwent a matched sibling donor transplant with trioflu conditioning from his sister, who was a multiparous female. And at 2 months, when we did a marrow and we did an NGS MRD for P53, it was positive at 0.2%. So we had to give him a DLI. As is the usual practice in adult high-risk MDS and AML transplants, we put him on ASA maintenance. But down the line, he developed extensive skin GVHD, which was unresponsive to steroids. Even after a month, there was no significant improvement. We started him on ruxolitinib, which he has taken for 5 months. We tapered and stopped. Currently, he is actually more than 15 months post-transplant with 98% donor chimerism. 3 P53 MRDs are negative, and he's doing well. And he was kind enough to, I think I have lost it somewhere, but he was kind enough to share his photographs, which I would have liked to show. So anyway, ruxolitinib reaches for children with GVHD. So we know that REACH-1 was a phase 2 study, which showed in acute GVHD, steroid refractory acute GVHD. REACH-2 was a randomized phase 3 trial for acute GVHD. REACH-3 is again a randomized phase 3 trial for chronic GVHD, where overall response rate of 50% has been seen. REACH-4 results have been published, where ruxolitinib has been used in treatment-naive and steroid-refractory acute GVHD, with 84% responses at day 28, which were sustained in 60%, 65% of patients at day 56. So some durable responses. Although some patients were treatment-naive and majority had grade 2, what was interesting to note was that ruxolitinib was well tolerated in very small children also. Sometimes the dosing of ruxolitinib in children is something that we get a little unsure about, but generally the guidelines recommend that you give 5 milligram twice a day for anybody who's more than 25 kgs, less than that 2.5 milligram per twice a day. Body weight based dosing such as 0.15 milligram per kg per day have also been described. So I think now we are getting more comfortable with ruxolitinib dosing in children. And there was a recent meta-analysis also on children with chronic GVHD, only 109 patients across trials. But what was interesting to see that even in the small number of patients did have good response rates, especially in difficult sites like lung. Some studies have reported encouraging outcomes. So my personal experience in pediatric patients who mostly have used ruxolitinib in the frontline setting in a variety of diagnoses, mostly when I'm unable to give CNI either due to an acute kidney injury or some complication like PRESS, TA-TMA. And what I've seen that even when it was used upfront, the engraftment happened nicely and it didn't interfere with engraftment. My patient for whom I've used for chronic GVHD has had 2 serious hospitalizations with bacterial infections. So yes, in our scenario, infections is something we need to be vigilant about. Tubercular reactivations can happen on ruxolitinib. Herpes reactivations are known to occur. So these are things which we as Indian doctors in an Indian scenario need to be aware. Thank you, and I'll be happy to take any questions.
Thank you so much, Dr. Nivedita. Next, we have a panel discussion on the hurdles and second chances navigating relapsed refractory Hodgkin's lymphoma. And it is moderated by Dr. Swati Bhayana. So can we have Dr. Swati on stage, please? With a list of stellar panelists, and she's going to announce the panelist.
I'm fine. Yeah, thank you so much for that kind introduction. I welcome you all once again to this HEMENEXT conference we are conducting, and we are very, very happy to have you all. So I've been bestowed upon a very easy yet difficult topic of hurdles with the second chances, which is always difficult. But this time, talking about navigating relapse refractory Hodgkin's lymphoma. I am very lucky to have my panelists, and I invite them on stage. Dr. Kavaljeet Kaur, ma'am. Ma'am is a very senior hematologist and has always been a to-go person discussing about experiences. She is currently posted in ESI. A huge round of applause for her. Dr. Jagdish Meena sir is currently posted in AIMS and has been really active in meetings and has been really to-go person for our onco discussions. A huge round of applause for sir. Dr. Anjali Pandit from Nepal. She is hailing from there to be a part of this meeting, so double round of applause for her. Welcome, ma'am. Dr. Prashant Prabhakar, a very good friend and a senior, currently posted in VMMC and Safdarjung Hospital. And Dr. Sunisha Arora, she's a colleague in Fortis Memorial Research Institute and an associate consultant with me in the team. A very warm welcome to all the panelists, and we are here to discuss something. We're here to discuss something about the RS cells which come back. RS cells which are not there previously and have a refractory nature. So I actually call them the RS or the Reed-Steinberg stubborn cells who just come and just stay. So we'll directly go on to the panel discussion due to paucity of time for the case 1. A 6-year-old female who had a right-sided cervical lymphadenopathy for 2 months with no B symptoms and a biopsy suggestive of mixed cellularity Hodgkin's lymphoma. The PET was suggestive of right cervical and right supraclavicular node 2 centimeter with a SUV of 10.2, stage 2A. A urinary protocol was chosen because of the limited disease, 2 OYAPA, and the patient was in CR. The treatment was completed, but unfortunately, what we see very commonly in our practice, 1 year, 2 months later, the child presented with a mediastinal mass. So ma'am, I'll start with you. What is the incidence of relapse refractory disease for Hodgkin's you see in our practice?
Hello, thank you for inviting me here. I thank the organizers. So basically Hodgkin's is a mixed bag. It's not everybody, not all Hodgkin's are at the same risk of relapse. So low risk disease is like this patient, stage 2A is at a lower risk of relapse and higher stage would be at a higher risk. So in our setting, I mean, this is pretty high that you've shown, I mean, even lower risk we see. So around 5 to 10% for the low risk disease and around maybe like 15 to 20% for the high risk disease. Here I would like to add that although international prognostic scale is there for the adults, for children also in the COG study they have used CHIPS, that is Children Hodgkin's International Prognostic Scale. But the criteria that they use, they may not apply to our setting. Like they have used fever, 4 criteria, fever, then male child, then that is like fever, then stage 4 disease, then albumin less than 3 gram per 3.5 and large mediastinal mass. So, I mean, we do see like all these kind of patients frequently like stage 4 disease and any number, 1 point is given to each of the criteria. And stage, if there is like a score of 4, then almost a risk of a relapse refractory disease is around 49% in that. So yes, it depends upon the how the patient is.
So that's pretty high when it comes to Hodgkin's, and all of us in our practice must have treated a case of relapse or refractory because the scents are pretty high when it comes to the disease. So sir, next question directed to you. For our fellows here especially, there are very different definitions when it comes to an early relapse, a late relapse. So for this case particularly, who's relapsing at 1 year, 2 months, how would you like to define this case?
Yeah, this question looks very simple, but it's a very important question. It's very important to know what is the timing of relapse. When we see patient is relapsing, so we feel bad. But we know that relapsing after 1 year, after 2 years, so we feel okay, it's late relapse. But majority of pediatric cancer, so criteria for early relapse almost 12 months, like Hodgkin lymphoma, majority of solid tumors. So we label early relapse if you're relapsing less than 12 months, or late relapse after 12 months. Sometimes we use very late relapse if you have patient relapsing after 5 years, but there's incidence of relapsing after 5 years very less. So cutoff 12 months.
So definitely when the thought process of a usual oncologist is that, okay, the patient is relapsing late and okay, we might be dealing with a disease which is chemosensitive. But in Hodgkin's, the twist and turn are a bit different always. So next question for the fellows here, Dr. Anjali. What outcomes do you grossly project to the family when it comes to a case of a relapse Hodgkin's lymphoma?
Thank you for the question and thank you for the invitation. Actually, as Sir and ma'am have told, like there will be a very less chances of relapse occur in Hodgkin's lymphoma, and
rarely after 5 years, but we have faced some cases after 5 years also. But after 1 year and 2 years, some patient we faces in our daily activities, like we have seen the patient. But for that patient, first of all, we counsel them for the second line treatment after the relapse, second line treatment. Like nowadays, like immunotherapy has done a very good result outcomes in the pediatric as well. So we can add like PD-1 inhibitor like and nivolumab, and then like brentuximab in the patient with nivolumab with ice for the patient, so that we can have the good results even only adding the immunotherapy in the patient.
So
Thank you.
definitely, thank you so much for the answer. Definitely, it's like projecting in relapse outcome also to about 85 to 90%. And that's like almost equal to pediatric ALLs. So that is really assuring with that immunotherapy coming up. So Dr. Prashant, next question for you. Though I think ma'am has highlighted that part, but patient and disease indicators which predict the outcome, how the child will go at the time of relapse.
Hello. Hello. Yeah, so the predictor at the time of relapse. So the bottom line, because multiple trials and multiple bodies have like different prognostic factors, but one thing and two things that are common is the time point of relapse. So the time point, as sir has rightly told, that if the relapse is within 3 months, we take it as a refractory disease, that is the progression of the same disease. And within 1 year, it is an early relapse. So within 1 year, and especially if it's less than 3 months, that we will take it as a refractory disease. So less than 1 year, it is a very high risk relapse. The other criteria is the response of the disease. So with as interim PET is, very important in cases of baseline disease. Similarly, now is the role of PET in relapse disease also. And if you see the Euronet trials, they are using the interim PET after like second line, like two to 4 cycles of chemotherapy as one of the strong indicator of a high risk disease. So if PET responsive disease after 2 to 4 cycles, then it is a good disease. But if it is not responding, that will be treated as a high risk disease. So time of relapse, the response, and the stage of the disease. If the at relapse the disease stage is very like 3, 4, that is the higher the stage of disease, they will do bad. And there are 3 or 4 other parameters which in INPOG study you will find that if the relapse setting is occurring at the place where the RT was given earlier, or there was these symptoms earlier, or if there was a high risk disease at the baseline. So these all parameters constitutes a high risk disease. If any one of them is present, that will qualify it as a high risk disease. So baseline is that it should be a very early relapse or very high risk, and if there is poor response to therapy, they are a high risk group. Thank you.
So definitely the single most important marker is when you relapse. How much is the depth or the longevity of remission that the first shot that you gave actually achieved, and that will predict your future. So based on that, a risk stratification have been proposed, but they are mostly in the adult scenario, but we use them in and out in the pediatric as we have discussed. Second case of a 6-year-old female with a right cervical and axillary lymphadenopathy with these symptoms, mixed cellularity Hodgkin's, and a PET suggestive of multiple nodes here and there with a high SUV. We gave 2 ABVD and child was not NCR. So we still went ahead and gave 3rd ABVD thinking that we'll hit it with radiation. But at the end of 3rd ABVD, unfortunately, we had new cervical nodes and fever. And PET showed new areas of uptake. So Dr. Sunisha, in a case of ongoing refractory status, is rebiopsy essential?
Yeah, so definitely rebiopsy should be done. And if it is a late relapse, that means the relapse is occurring after 12 months of the initial treatment, we should go, we have to, it's mandatory to do a biopsy. First to confirm the diagnosis, second to rule out the other false positive results in PET, like infection can be false positive, which can be present in PET, like it can light up in the PET scan. So to rule out infection, then next to confirm any lineage change, because the lineage shift can occur in lymphomas. So for that, biopsy is definitely mandatory for more than 12 months, if the time has passed for more than 12 months. If it is an early relapse, it is recommended to do a biopsy. Depending on the case-to-case scenario, it can vary. And also, if we see new lesions which are lighting up in a PET scan, then definitely we have to do biopsy and document that whether it is a new disease or it is the same disease which is progressing. So in case of progressive disease, we have to do definitely biopsy.
So definitely, bottom line for fellows sitting here, we should biopsy. Always prove by biopsy that your patient has relapse, because labeling a relapse is a very big unfortune or a fate. So for doing that, a biopsy is mandatory. Just with a caveat or a gray zone, in cases if you have a primary refractory disease who's refractory at the same point, that is the only scenario. For example, you have a mediastinal mass and your mediastinal mass is progressing further after 3 ABVD. So only in that case, you kind of know, okay, you are dealing with a disease which might be refractory because there is no response. And we know that Hodgkin melts. So in that scenario, only it comes with a gray zone that, okay, you may skip. But even if you have a single new area on PET, so that makes the PET very important. If you have new lesions coming up, that makes PET again very important. If you have a new bone marrow involvement, so all these things should always label, always do a biopsy and always label the patient with that disease again.
Can I add one thing?
Yeah, sure.
So if there is a relapse in refractory setting, I want to say one thing, that always remember ALCL is very much similar to Hodgkin's, be it the symptom, be it the morphology, be it the IHC. They are also CD30 positive. So if you are seeing a case which is slightly atypical and that has gone probably in remission or refractory and it is relapsed very early, ask your pathologist, are you in any doubt that it is ALCL? If they are in any doubt, tell them to put a ALK. Because we have seen cases, they have been treated like Hodgkin's lymphoma and they have turned out to be ALCL. So if there is any doubt, you just ask your pathologist and tell them to rule out ALCL in that case, because Hodgkin's like ALCL, we know that there are 3 or 4 morphology, and Hodgkin's like is very similar to Hodgkin's. They have all kind of background inflammatory cells with similarly looking Reed-Sternberg cells, and it is very difficult to differentiate between Hodgkin's lymphoma and ALCL. So you have to keep in mind ALCL as one of the possibility in those cases, and do ask your pathologist about that. That's it.
So that's a very important piece of information. Next question is directed to you, so you can keep the mic with yourself. Will you check for PD-L1 or CD30 when it comes to using a checkpoint inhibitor in a relapsed Hodgkin's?
Okay, so that's a good question. I think CD30, we usually don't take CD30 and PD-L1 because CD30 will be invariably positive in cases of Hodgkin's lymphoma. Only I think lymphocyte-rich type of Hodgkin's lymphoma are CD30 negative, and nodular lymphocyte predominant, NLPHL, which is treated a slightly different way, is CD30 negative. So invariably, if CD30 is negative, we really doubt whether it is really Hodgkin's or not. So we don't do CD30, especially checking for CD30, because invariably it will be positive. And as far as PD1, PD-L1 is concerned, there is no recommendation to go for those checking for PD-L1 and PD1, because mostly they'll have upregulation of PD1 and PD-L1 because of the mutation that is involved in 9p. And so there is no guideline. Only thing is, if the expression of PD1 and PD-L1 is more, you'd like to see a good response in cases of Hodgkin's lymphoma. So that's the only thing. Otherwise, there is no need to check for PD1 and PD-L1 before prescribing nivolumab or pembrolizumab for that matter.
So theoretically, earlier, everyone was finding out which way is best to pick PD-L1, whether we should use a IHC by PD-L1 or use a NGS for PD-L1. But as newer studies are coming up, even PD-L1 negative lymphomas responds beautifully, which is not the case with sarcomas or other adult cancers, I would say. But in pediatric Hodgkin's, they respond beautifully. So it is not mandatory to check, and you can, in fact, overhead advise the family for that. Next case of a 14-year-old male with a cervical and axillary nodes, B symptoms, huge bulk, liver, spleen positive, and biopsy with mixed cellularity. PET was suggestive of uptakes here and there, splenic uptake, bone marrow uptake, a bad disease to start with. We gave a 2 ABVD, and PET was not in CR. We gave a 4 ABVD. End of treatment was done by chemo only, as the family was reluctant for radiation. And at the end of treatment, child had fever for 4 days, and PET was suggestive of new areas of uptake. So in that, we re-biopsied the kid and was suggestive of Hodgkin's lymphoma. At this point, Dr. Jagdish, what is your to-go regimen? You will choose a second-line salvage chemo, you will go for a chemo-immuno, or you will go for an immuno only?
My answer will be in 2 ways. If you ask, what do you do at your center? The answer would be, so we'll go second salvage therapy like DEP, BGV, and ICE. If you ask me what is the correct answer, so best answer would be chemo-immunotherapy. But we work at public hospital, class of patient would differ, affordability would be issue. So we'll try to do first second line salvage. If patient affording no problem with finance, then chemo-immunotherapy would be the first choice.
Definitely, because there is no single answer to it because it comes with so many ifs and buts in our mind. Number one, what will the child actually face? Number two, how heavy will it be on the pocket? It's not like you can just upfront plan a thing and you can go ahead with it. Number three, what is the stage of the disease? Number four, what is the chemo that the child has received previously? So it comes with very ifs and buts, and there is no single RCT which actually says that head on, this is better or that is better. And again, it comes with a lot of questions which are to be solved. So we gave one cycle of Nivo-Benda, and clinically the child was better, but the child was afebrile, the lesions, the neck nodes were resolving, but a PET showed progression. One bottom line, that the senior person was on leave. So we discussed the PET with the senior resident, and as we see in the PET scans, there is a progressive disease. So ma'am, any key point you would like to discuss with that junior person before interpreting this PET scan?
So actually, senior person would not have made any difference in the interpretation. The interpretation is with us, right? How the patient is doing. If the patient is afebrile or the otherwise appetite is good, or the CBC is improving. So we decide clinically how the patient is doing, whether this PET is significant or not. Like in iris for tuberculosis, it is we decide rather than the image. That was my point. Second is a follow-up image will be more important rather than at that point, nobody can say that what is happening. So follow-up at 12 weeks, yes, that is the maximum we go. Usually before that we can tell a repeat imaging. What a radiologist can do is tell the indeterminate stage. So this is the lyric, which is lymphoma response to immunotherapy criteria. So that is like the counterpart of iRECIST in solid tumors. Solid tumors ke liye iRECIST, and for lymphoma we have LYRIC. So in differences in iRECIST, we use I in front of every word, like IPR, IPD, ISD. Whereas in this case, it is not like that. This IR is indeterminate response. Anytime we think that this is a pseudo progression, that I assume that we are all aware of pseudo progression. So pseudo progression is like because of the release of all the cytokines that we are, the immune response was so far suppressed because of the PD-L1 and PD-1 engagement that was broken, and now the T lymphocytes and they are all, NK cells are there, they are releasing their cytokines, and that is causing inflammation, and the lesion is lighted up even more. So IR1, IR2 and IR3 are the criteria that they use in which they see the number of lesions, whether it is increasing, the tumor burden, whether it is more than 50% or less than 50% increase from the previous, or that the tumor burden has unchanged, and it is just that the intensity of the FDG avidity has increased. That is the criteria they can give. That is what we would like to know, and that we can follow up later on.
So definitely, pseudoprogression is a very important term when it comes to using PD-L1 inhibitors, especially, or any other immunotherapy. So what happens is your PET will show increased flare, as ma'am is highlighting. Even the radiologist, and ma'am is very beautifully saying that juniors and seniors are the same, but even a nuclear medicine person will say that it might be a pseudoprogression. They will never label it because they don't want to take that tag on them. They'll say that it might be a pseudoprogression, and the bottom line comes as repeat after 12 weeks. So that will clearly tell that whether it was a pseudoprogression, the areas of uptake was because of cytokine flare, or it is actually the disease which is coming back and putting it on your face that your Nivo-Benda is not working. So over the years, the criteria used in Hodgkin's evaluation by nuclear or PET scan has changed, and LYRIC and RECIST are the new ones which your nuclear medicine team might be using in and out. So after 2 cycles of Nivo-Benda in this patient, the PET was fortunately in CR, and we took the patient for an autologous HSCT with a beam conditioning. Dr. Anjali, next question is for you. Is HSCT always required post-immunotherapy if the patient is in CR?
If it's a high risk case, so if we don't want the relapse again, even after the HSCT, then we have to give the immunotherapy according to the patient condition, whether for the maintenance dose for the 4 cycle or 6 cycle or for the 1 year. We can use PD-1 inhibitor or we can use brentuximab.
So definitely that studies are coming up only for Brent cases in which in adults, in old frail patients, they have skipped HSCT. For us, we should always hit with the HSCT and reach that depth of consolidation whenever possible. So Dr. Sunisha, next question is for you. This patient, we gave 2 cycles of Nivo-Benda and we took the patient for autologous HSCT. So this is a RT naive patient because initially also the family was reluctant. So should we or should we not include RT in this case?
Since the patient has not received RT before, definitely we should include radiotherapy post-transplant for this patient. Why? Because several studies have shown that giving radiation post-transplant to the high-risk areas in high-risk patients can improve the overall outcome. By high-risk patients, I mean patients who have primary refractory disease or those who have B symptoms initially or those had bulky disease initially, but they were like in this patient who had not received radiotherapy before. So definitely should be followed with radiation after the autologous transplant to improve the overall outcome.
So definitely in a refractory case, if we have a weapon, we should use that weapon. And studies have shown that a consolidative RT is better. But that gives us the change of scenario. This is a RT naive patient, Dr. Prashant. Dr. Sunisha has agreed that we want to give radiation. When should I sandwich the radiation? Before HSCT or after HSCT?
So for RT, I mean, if the child has gone into remission after giving like 2 or 3 cycles of salvage, if you are giving, I mean, you give Benda and Nivo-based.
Nivo-Benda, that's
so if the patient has gone in remission, I mean, the role of RT is actually controversial in those settings. So many centers, they do not give RT also if the patient goes into remission. And there are now data upcoming which says that even in transplant setting, if the patient has gone into remission, pre-transplant, if they are in CMR, you can actually go away with RT, although the data is obviously very premature to say. So in those cases, if I am going to give RT, I'll definitely give after. The issue with giving RT prior to that is I might have difficulty in mobilization also because the area that you are going to irradiate. In any case, the patient is heavily pre-treated. So giving RT before transplant will lead to a difficulty in mobilization and ultimately might require multiple sessions of harvest. So I'll give RT after the HSCT and not pre-HCT. And that we do in our setting also.
So that is one way to take it. Yes, we take it with a pinch of salt because there are different opinions that some say you do it pre and your pre problems will be more. Some say you take it after and your post transplant problems will be more. But definitely there have been guidelines about it. In a refractory HL, we should do immediately prior to HSCT or 4 to 12 weeks following HSCT. Even they have given both these scenarios because they let you choose which way you want to go about it. So, ma'am, next question is that the patient was scheduled for a post-HSCT RT. The patient underwent autologous transplant very well. And on day 20, the counts are pretty much normal for autologous HSCT. The child is clinically okay. What is the preferred time you want to start the radiation post-transplant?
Actually, the literature is divided on that. You know, it's very easy to say, like you wrote 4 to 12 weeks, you know, how the patient is post-transplant. And if you are planning post-transplant immunotherapy, that is another thing that you had. So if we, actually there are 4 to 12 weeks is like the minimum earliest you can give depending upon the patient's
general condition
of the bone marrow and the whatever success of the HSCT was done. Autologous ASCT that was done. But the thing is that, when I reviewed the literature, then there were like up to 10 months, up to 6 months. So the literature is divided actually on that. Yeah.
So definitely consolidative RT when your patient can take it. Because it all comes to the patient. We know we want to use that weapon, but the patient will yourself give the answer when that weapon has to be used. Dr. Anjali, next question is for you. Would you consider this patient for a post-HSCT maintenance of Hodgkin's, which is an upcoming topic, which is used nowadays in and out, but the clear evidence, the clear when, if and when to use, everybody has a hazy zone about it. So for this case, will you consider?
Still, it's a controversy, like whether we have to use the maintenance dose or immunotherapy even after if the patient is in remission after the transplant. If it is in a remission, then why to use? Even for the patient also, like to convince also, it was a very hard topic for us to convince the patient. Being a physician, like as we told, like last option is transplant, then again immunotherapy. Why? That is, if it is in a CR, then why immunotherapy after that also?
And heavy on the pocket as well.
Yes. So it is still, it's a controversy. So we have to take the decision depend upon the patient condition, that what was the initial stage at the time of diagnosis, after that how it relapsed, and what terms of condition that patient goes into the CR, what regimen we used. It depends upon all those things, that whether we should do the maintenance or not. So I will not say yes or no, it depends.
So definitely it always depends, and a physician always takes that call based on patient to patient cases. But since I was supposed to moderate the session and I was supposed to take out evidence, so ETHERA trial actually, which was originally for brentuximab, showed that not everybody is eligible for a post-transplant maintenance. If you have one or more high-risk feature, like a primary refractory disease, early relapse, or an extranodal disease at relapse. Originally it was for brentuximab. Only these patients you should consider that you should commit that for 1 year you want to give them that therapy. You should commit that for 1 year they have to be 1 day in the hospital, which nobody wants after the transplant. And again, comes with a heavy on the pocket, always a problem. So ma'am, when do you start post-HSCT maintenance if, let's say, this patient is planned?
Okay, so this one is easy. So I think it's like 1 to 2 months. Within 1 to 2 months, we have to do it. Yeah,
So
it's quick.
whenever the patient
Because
allows?
we don't want the disease to relapse. Yes. That is why it is clear.
Yes, so 1 to 2 months is safe enough a time zone to start that. Dr. Sunisha, let's say this patient is planned for a nivolumab maintenance. How long would you want to give this maintenance therapy?
Should be given at least 1 year post-transplant, at least. That is the minimum if we want to prevent the further relapse to this patient. It has to be given at least for 1 year.
So again, 6 months to 1 year is what studies have planned, but we will come back to that in case 4, because there is a point to be discussed about that. Next case, 80-year-old female, cervical node B symptoms, PET suggestive of nodes here and there, bone marrow uptake, and a stage 4 disease. To start with, we stick to Euronet protocol because thought that it would be less toxic to the patient. 2 OYAPA, 4 COPDAX, end of treatment CR. 4 months later, an early relapse of cervical lymphadenopathy fever and a biopsy proven relapse. Dr. Prashant, let's say this patient is planned for Nivo-Benda immunotherapy. What is the dose of nivolumab, and is there a rationale of using low dose nivolumab?
Yeah, so this salvage regime is, I think, one of the very good tolerable regime, because we in Safdarjung also are using, and Tata has recently published a paper on this. So this is one of the regime which is very easily tolerable, and nivolumab is obviously costly, but it like 38 to 40,000 is kind of affording, rather than giving all kind of ICE, DAP and all kind of protocol which is very toxic. So it is one of the protocol, and this low dose nivolumab is something which is actually built for our setting. Giving a fixed dose of 40 mg per kg or 1 to 2 mg per kg is very justifiable in our setting. And what Tata has shown in their paper, I think it's 20 or 30 patients data, I don't exactly remember. They have shown a very good CR rate, and they have ultimately taken that patients for transplant also. And even in Safdarjung, I think we have used for 6 or 7 patients, and they have really done well on only 40 mg fixed dose with bendamustine. So low dose nivolumab is actually going to be in the coming years standard of care. And I think one of the multicentric trial is also being conducted in India in first line setting with low dose nivolumab. So I think in coming years it is going to be the standard of care, low dose nivolumab for pediatric patients.
So do we have the next publication from you?
No, not me. I am not doing that study.
So definitely, coming back to the question of the previous session, that if you plan a patient for nivolumab maintenance, like Dr. Sunisha pointed, let's say for 6 months and 1 year, you can take it as a low dose nivolumab, and that might be less toxic, less heavy on the pocket. 2 Nivo-Benda, PET, lung was in CR, cervical nodes, Dewey score of 3, abdomen in CR. We gave radiation, we gave autologous HSCT, we did beam. On day 7 of beam, the child had hypoxia. The child was sick, inflammatory markers elevated, serial chest radiograph demonstrated that the lung is gone. We started the patient on methylpred thinking that it is engraftment syndrome, and patient responded well. The patient beautifully responded. So Dr. Anjali, any experience with engraftment syndrome in autologous HSCT, engraftment syndrome post chemotherapy, and in this case post Nivo-Benda?
Yes, as we have used like nivolumab, PD-1 inhibitor before transplant, so that might cause the like neutrophil engraftment. At the time of neutrophil engraftment, there might be a risk of engraftment syndrome.
So it has been seen in various studies, not a textbook line, but seen in various studies that if you use a checkpoint inhibitor, be on alert for engraftment syndrome because it's going to hit bad. I'm going to take 5 more minutes. So post HSCT, child received 9 months of nivolumab maintenance, and after that, unfortunately, 6 months after completing the maintenance, relapsed again. I'll just quickly take us through there. The post HSCT relapse also, we gave an outcome of about 50 to 55%. So that's pretty good when it comes to the fight of Hodgkin's lymphoma. But when we talk about a post-NIVO, post-RT, post-HSCT, our treatment options are limited, but still, a used immunotherapy like nivolumab or a new immunotherapy like pembrolizumab is or can be considered. There is a role of allogenic HSCT when you have a post-autologous stem cell transplant relapse. Quickly to the next case, which is a 9-year-old female with an NLPHL, and initially 2 ABVD and a radiation was given because NLPHL has a different way. Whenever somebody wants to treat it, some say upfront surgical resection and forget about it. Some give a small chemo with radiation, and this child 2 years down the lane relapsed. So anything specific about a relapse, NLPHL, Dr. Prashant?
NLPHL is altogether a different, ballgame. Usually they have a late relapses, and usually you don't need that much of chemotherapy. If suppose a relapse is at single node, then you can also consider, and it is a late relapse. We can consider, following the patient, or rituximab. 4 weekly rituximab is also well enough. ABVD has also been used, so there are different options. But yeah, the prognosis overall is very good, and more than 85 to 90% survival is there even if the child relapses. Yeah.
So definitely, just the bottom line, thank you so much all the panelists for the beautiful discussion. And just the bottom line, in a relapse Hodgkin's, no matter what the time of relapse is, first relapse, second relapse, keep fighting that battle because the second chances are after all not that bad. Thank you so much.
Thank you so much, all the panelists, and thank you, Dr. Swati. Next, we have Intel Ignite quiz, led by all the quiz masters, Dr. Swati Bhayana and Dr. Prashant Prabhakar on stage, please, if he's here.
So we are just waiting to hear back of our results of prelims.
May the fastest neuron win.
टेबल हटा दो बीच में क्या होता है माइक तो सर्कुलेट हो जाएंगे कोई बात नहीं टेबल हटा दो सब चेयर रख दो टेबल हटा दो बीच में ओके ठीक है
Good evening, everyone. I'm back here. So here's announcing the results of the prelim round, which we conducted 1 hour back. And we had an amazing participation from all the teams. So congratulations for all the participants, first of all. The teams which have enrolled in the finals are Dr. Saurabh Pandey and Dr. Abhinav Sengupta. Do we have them around? Dr. Madhukari Sriram and Dr. Labanya. A huge
Can we please can we please clap for them for their participation and for winning?
Dr. Mehek Trehan and Dr. Shubham Goswami. I think they're outside. Can somebody please direct them inside? Dr. Nikita and Dr. Shivani Reddy. Dr. Prashant is on cloud 9 because the AIMS team is walking on stage. So I don't have Dr. Saurabh Pandey and Dr. Abhinav Sengupta. Are they around or should we take the next team? Do we have their contact numbers? नहीं मेरे पास है. Abhinav Sengupta. Dr. Mehek and Dr. Shubham, please come up on the stage. A huge round of applause for them. And we are just calling the fourth team. If they are not available, then we'll take the fifth team in line. You are Shriram. Okay. Hi. Abhinav Sengupta. Please. Do you have your partner? Dr. Saurabh Pandey. All right. They would need paper and pens. Rush, rush, rush. Are we seated? Somebody need water? No? All right. So here we go. Good evening, everyone. We are standing here for the Intel Ignite quiz, and a huge round of applause for all the teams who have made up on the dais. So just a quick introduction. I'm Dr. Swati Bhayana. I'm Associate Consultant in Pediatric Hem-Onc team in Fortis Gurgaon. And with me is Dr. Prashant Prabhakar. We both are the quiz masters for the day. So we have a quick team introduction starting from team A, B, C, and D. I kept the chits, but you yourself chose, like a sorting hat. So you can start. Team A, your introduction, please.
Hello, I'm Dr. Shamni. I'm a DM Pediatric Oncology resident from AIMS Delhi.
I'm Dr. Nikita, and I'm also Senior Resident, DM Pediatric Oncology, AIMS Delhi.
Welcome to Team A. Team B, please, your introduction.
I'm Dr. Abhinav, DM Clinical Hematology Senior Resident.
Dr. Saurabh Pandey, Senior Resident, Clinical Hematology, AIMS.
Welcome to Team B. Team C.
Good evening, everyone. Myself, Dr. Mehek Trehan. I am Senior Resident in Department of Hematology, pursuing my DM in Clinical Hemat at AIMS New Delhi.
Hello, I am Dr. Shubham Goswami, DM Clinical Hemat, AIMS New Delhi.
Welcome to Team C.
I'm Dr. Lavanya, PHO, FNB, Apollo.
I'm Dr. Sriram, FNB, PHO, Apollo Hospital, Delhi.
So huge round of applause once again from them. So starting the quiz for today. The quiz consists of 3 rounds. Since it's a HEMENEXT conference, the quiz is labeled like that. Do you have any problem viewing this screen? No. Okay. So round 1 is labeled as HE, which is hello newbies. Round 2 is labeled as ME, which is meet the saviors. Round 3 is next heartbeat, which is the rapid fire round. So shall we go? We do have chocolates for the audience. So if you want your blood sugars to go a bit up, you can stay back and answer the audience questions. So first round is hello newbies. We start from A and go towards team D. It's a team directed question. The quiz starts with question 1. You have to answer question 1 for the other questions to open. No passing of question to the other team, so other teams can take a breath there. Question 1 is not answered. The question is unfortunately bounced to the audience. And questions go in sequence. So you can answer 1, then answer 2, 3, and 4. You cannot come back to question 2 if you see question 4, because the hints keep on increasing. There is no negative marking, and maximum questions is 4. Time is 40 seconds per sequence, 10 marks per question, and decision of quiz master is the final. Are we good to go? Any doubts? Yes. All right, so round 1 sample question for the audience. What is common between these dates of 10th November 2025, 26th November 2008, 13th December 2001, and 11th September 2001? So yes, you are sad about the attack, sir. Yes, we all are. So definitely these are the dates of terrorist attack. Identify the area of 10th November Delhi blast. I have a low audience. Can we have some caffeine for the audience? So definitely, and mention the chemical compound identified causative of Delhi blast. Ammonium nitrate.
Ma'am? Excuse me, ma'am.
So round 1, team A, are we ready?
Ma'am, one doubt I have.
Yeah, sure.
If I'm unable to answer the first question, second question will open up to me or it will not?
If you answer the first question.
If I don't answer the first
No, then that goes to the audience. For this round, it goes to the audience.
No, we will be given the second question.
No.
So if we cannot answer question 1, so we
Mike,
don't
Mike,
have
you can use the mic.
If we cannot answer question 1, so there is no 2, 3, or 4 for the team.
Yes. Okay. So round 1, team A, you ready? A 10-year-old girl, case of mixed cellularity Hodgkin's lymphoma, stage 2B, non-bulky, ESR 76, received 2 ABVD, was in complete remission on PET scan. We completed 4 ABVD, no radiation was given and the therapy was completed. She relapsed after 2 months of completion of treatment with fever, cervical nodes, weight loss for 10 days, and a PD1, PD-L1 block was proposed. Question 1, identify the drug. 40 seconds each question.
Nivolumab. Nivolumab.
That's right. A huge round of applause for the opening batsman. But that was a simple one for you, right? Yeah. Oh, no. I'm sorry for making simple questions. I make simple questions. So here we go. They get 10 marks for the first question. The next question for you. Mention the location of PD1 and the location of PD-L1 with respect to the mechanism of action of this drug.
PD-L1 would be on the neoplastic cell, and PD-1 would be the antigen presenting cells. The
PD-1 will be?
On the antigen presenting cells.
So huge round of applause for them. That's the correct answer. PD-1 is on T cells and PD-L1 is usually on the tumor cells or the neoplastic cells. So question 3 for you. She received the drug at 3 mg per kg for 2 doses, and the patient's family developed a URI with cough and cold with influenza B on biofire positive. It persisted for 7 days. She developed similar symptoms as well, and fatigue was there. Physical examination showed rales in the bilateral middle and lower lung fields, a high BP, tachycardia, tachypnea. Oxygen saturation was 82%, which improved on 6-liter O2. A BAL was done. PCR on BAL was negative for RSV, influenza A, and influenza B. This is a case of nivolumab pneumonitis. So what is the characteristic BAL finding of a nivolumab pneumonitis? 40 seconds start.
Activated lymphocytes would be...
Anything more specific? We know we'll not get a neutrophilic picture. We know that. Something specific about their lymphocytes.
CD4 activated CD4 infiltrates.
So actually I will give you 5 marks for that. A round of applause for picking that question, but it's actually not CD4. You get a predominance of CD8 cells, but it is a lymphocytic alveolitis. So that's why I give you 5 marks for that question. So is the quiz master? Yeah. So question 4, 5 plus 5. Mention the duration of steroids for this side effect of nivolumab, and mention one drug with role in the treatment in steroid refractory cases of nivolumab-induced pneumonitis.
1 mg per kg methylprednisolone starting for at least first 3 days.
Perfect.
And
duration?
Duration total would be 14 to 21 days.
Okay, next.
And, tocilizumab in the refractory.
Sorry?
Tocilizumab in the refractory.
Okay, so unfortunately no, both the answers are wrong. The average duration of steroids is methylpred to start with, as correctly pointed, but you give it for 4 to 6 weeks because it's alveolitis and you have got a deeper problem. And one drug with a role in steroid refractory cases for a pneumonitis is infliximab. So a huge round of applause for them for attempting this quiz beautifully. Well done. And we have taken enough knowledge. Audience question. After an episode of immune-mediated pneumonitis, do you re-challenge nivolumab? You can raise the hands, answer the question, take the chocolate, and sit back. Anyone? So we actually do, I eat the chocolate? No, they have enough questions for the chocolate. I don't want any diabetic cases on the stage. So we actually grade it, and if it is, there are few grading criteria, and if it is grade 2, you can actually withhold the dose. If it is grade 3 or 4, you have to permanently discontinue. Round 1, team B, are we ready? So 3-year-old male child, firstborn, 12 kg, diagnosed with a FLT3 positive AML in Jan 2025 this year. He received a 3+7 based chemotherapy, and a post-induction MRD was 1.2%. He also developed a fungal pneumonia on day 14 of induction and was started on therapeutic voriconazole. For further management, we planned venetoclax, and we also planned a type 2 FLT3 inhibitor, which was orally twice daily dosing. Identify the drug.
Midostaurin?
Unfortunately, no. So the question bounces to the audience. Orally twice daily dosing, type 2 FLT3 inhibitor. It is actually sorafenib. And what is the meaning of type 2 FLT3 inhibitor? The question is not yours anymore. I'm sorry. Anybody from the audience want to take this? What is the meaning of a type 2 FLT3 inhibitor? And why is a dose escalation strategy followed when you give venetoclax? Why is it 100, 200, 400? Perfect, because of tumor lysis syndrome. So the chocolate go there. Is Kanika having the chocolates? She's kept all in her pocket. She might not give you. Mention the CD markers corresponding to the FLT3 receptor on flow cytometry. Anyone? So it's actually CD135, and the type 1 and type 2 inhibitors are separated, and sorafenib is a type 2 first generation which is used. Round 1, team C, are we ready? She was born ready, I think. 22 months old female child, case of standard risk B-ALL, CNS negative, ALL PCR negative, cytogenetics XX. Treated on a BFM 2002 protocol. Complications: 2 episodes of GNB sepsis, 1 episode of mild drug-induced pancreatitis. Relapsed. A combined medullary and a CNS relapse. Flow cytometry showed 22, 19, 10 positivity. Started on agent A antibody conjugate, scheduled weekly. Identify the drug. Perfect. A huge round of applause for her for opening the question. Question 2 for you. Why is a weekly dosing schedule preferred over one dose every 3 to 4 weeks? It would be easy, it would be less daycare admissions, but I give you options for that. Spread out the efficacy over a long time. Or CD22 re-expression happens in 2 weeks. So it was found in studies that a weekly dosing ensures fewer CD22 negative relapses. A less risk of VOD or a myelosuppression is less with weekly dosing.
Less risk of VOD.
Perfect. A huge round of applause. So, third question for you. Day 8 of treatment, child presents with abdominal distension, pain, malaise, fever. Weight on day 8 was 13.2. Day 9, vomiting, decreased urine output. On examination, ascites and tender hepatomegaly. Day 11, respiratory distress, low oxygen saturation, tachypnea, tachycardia. She was transferred to ICU. We all know what is going on here. Which zone of hepatic SNI is affected by the mentioned drug to cause this mentioned side effect?
Zone 3.
Perfect. A huge round of applause for her. Somebody claiming for the chocolate? Who answered? I'll tell you who answered. So good. Zone 3 is the one which is affected. Last question for you. 5 plus 5. Mention the dose of defibrotide when there is an established BOD. Mention any one more agent not related to this case but implicated in causing BOD when used in pre-HSCT remission induction. She can handle it on her own.
The dose is 25 mg per kg in 3 to 4 divided doses, and other agent which can cause is gemtuzumab.
Okay, perfect. A huge round of applause. So they get full marks through this. The dose is 25 mg per kg, and as he was highlighting, it is divided into 4 doses, 6.25 mg per kg, but 3 to 4 is fair enough. So should I take the score back from her because you were pointing anyone? But it's okay. 3 to 4 is perfectly fine. It is 6.25, and one more agent is gemtuzumab for emission induction. Other agents are busulfan, a TBI-based conditioning. Well done, Team C, for that opening round. And we all know that VOD is a very big problem we see, and we are always pocket tight when it comes to treating VOD. Audience question. EBMT proposes that remove one criteria from adult VOD diagnostic criteria when it comes to pediatric VOD. What is it? Hyperbilirubinemia, they always say. So chocolates to them, I'm lenient with the chocolates. Hyperbilirubinemia, they say, is no. Hyperbilirubinemia, they say, is obligatory for pediatric VODs because anectic VOD is more commonly seen in pediatric cases. Round 1, Team D, are we ready? 1-year-old male child, case of BALL, CNS negative, ALL PCR showing KMT2A rearranged, cytogenetics XY. TLC diagnosis 4.5 lakh, hepatosplenomegaly test is normal. Flow cytometry showing a CD19 positivity of 84%, CD10 negative. Treated on interferon protocol, received induction, and started on agent A infusion therapy planned for 28 continuous days. All of you know the answer, but directed to Team D, identify the drug.
Blina.
Perfect. So the drug is blinatumomab. In the mechanism of action of drug, 2 CD markers are involved. Identify the markers, identify the cells. We can remove the table from between them actually. They're too far.
CD19 and CD3.
Perfect. A huge round of applause. CD19 on the B cells and CD3 on cytotoxic T cells. What is the half-life of the drug or immunotherapy involved? "40 seconds only for the question.
Six to 12 hours.
Sorry?
6 to 12 hours.
No, so that's wrong. So we end the question for you here. The half-life is actually 1.2 to 2 hours, and that is why it is given over this continuous infusion, and you don't get question 4 for you, sorry. But he's receiving this first cycle, and there is an event of ICANS. I'll quickly take you through there. There's an event of ICANS at day 5 of status epilepticus. I'll bounce to the audience. Drug of choice for this grade of ICANS when there's a status epilepticus. Dexamethasone, do I hear dexamethasone? Unfortunately, that's the incorrect answer. The drug of choice when there's a status epilepticus, you're dealing with a higher stage and it comes to grade 4, so you have to give methylpred. I can see you mumble there. Methylpred, you can give the chocolate to team A. They're not receiving chocolates, I'm sad now. So that's why you have to give methylpred. Audience question, mention any one more IL-6 anti-drug apart from tocilizumab, and that's your hint. The smart boy, handsome boy. Anyone? We really need tea or coffee in this room. Something else is not allowed till 8:30 when we start the gala dinner. So the drug is actually cetuximab or chocolate. More chocolates to team A. Cetuximab, that is also an anti-IL-6 and it is known to be better as compared to tocilizumab. So score at the end of round 1 and a huge round of applause for playing that well.
Marks, and team B is yet to open their account. So yeah, hopefully they'll do this in next round.
Next round. Here we go to round 2, which is Meet the Saviors. You all have your notepads with you? Can we have the notepads, please? Do you all have your pen? Pen, pencil, everything? Lucky pens are not allowed. Any AI pens are not allowed. Any shakalaka boom boom pens are not allowed. Okay, round 2, Meet the Savior. So it is a team directed question. We go from A to D in this as well. But it is open for all in all the questions. So all of you, starting from your question, are supposed to write the answer. First, write the name of your team, A, B, C, D, very clearly. Then write down 1, 2, 3, 4, because there are 4 questions in each question. We collect the chits, and I assume I'll get help from you. We'll collect the chits the moment question is finished. We will read the answers from the team first, because it will not take double time. We'll read the answers from team A first for the first round. And if team A has wrong answers, only those questions are bounced to you. The questions will not be bounced once the answer to them is taken. I'll collect the chits one and for all. Am I clear? I'll collect the chits the moment I finish reading the question. I'll read all the 4 questions, 1, 2, 3, 4. Write down the answer with very clearly mentioning your team is A, B, C or D. There are no negative marks, but your questions bounced are only those which the team A or the team directed has not answered. Am I clear? Yeah. So if they answer correctly, all 4 questions, it is plus 10. If the other team's answers, that is also plus 10. No plus 5s here. Yeah, I'll give 3 minutes after question 4. Okay. So round 2, Savior 1, team A. 11 months old male child, case of abdominal mass noted 1 month ago. The CBC was normal. The alpha fetoprotein was 3,27,222. LFT was suggestive of total bilirubin of 2.2, a GGT of 234. Biopsy was deferred and a PET scan is shown. He was started on a protocol with a 6-hour infusion of drug A. IV fluids were continued, which had DNS, mannitol, KCl, magnesium sulfate. Drug B was given 6 hours after drug A as a protective savior of the single dose of drug A. Round 2, team A, question 1. Identify the drug B. Question 2. Monitoring is advised with drug B, a stringent monitoring of 2 things. Mention those 2 things, it is 5 plus 5. Round 2, team A. What is drug B protecting? We know that. That is not your question. Mention the name of the scale used to measure hearing assessment, because drug B is protecting something related to that. The child completed the treatment of 4 cycles followed by surgery and 2 cycles. AFP monitoring was recommended for 5 years post completion of treatment. One serum electrolyte monitoring was also yearly recommended for this kid. Mention this electrolyte. 40 seconds from now and your time finishes and chits will be collected. You can use the full chits. We'll give you more chits. Don't tear chits. Time up? Time up. Please collect the chits. So for team A, they have correctly answered that first drug B is sodium thiosulfate. Huge round of applause. The answer 2 is unfortunately wrong, so it is bounced to all the other 3 teams. Please check. Question 3, they have correctly answered, which is Brock's grading. And question 4, magnesium and potassium. I asked for 1 serum electrolyte. Should I give you that? What does the audience say? Should I give them that? So only question 2 is bounced to the other teams, and 30 marks for team A. So team B answered wrong, team C answered unfortunately wrong, team D also unfortunately answered wrong. So monitoring with drug B advised is that of BP and serum sodium. Urine output, pH urine, okay, yes, pH urine, agreed. Urine output, again agreed, but stringent monitoring required of sodium, serum sodium, 6 hours, 4 hours, 30 minutes, and stringent monitoring of BP. If you get the BP gets high, you have to give it antihypertensive and keep on monitoring for 48 hours post-infusion. Okay? So huge round of applause for team A. Very beautifully taken. And round 2, Savior B, team B. 10-year-old male child, pain and limping of left lower limb for 4 months. Swelling and palpable mass in left eye leg region. Left-sided eye leg bone biopsy was done and suggestive of this, which is a NKX 2.2 positive, CD99 positive, and a PET scan shows an extensive disease. Child was started on the protocol. Cycle 1 was uneventful. Cycle 2 was planned. Drug A was given with IV fluids. Drug B was planned 6 hours, 4 doses. 6 hourly for 4 doses. Round 2, team B, 30 seconds, identify the drug B. Write it down, all of you. Next question, mention the pharmacological name of drug B. Next question. The patient develops blood in urine on day 9 of discharge. What is the chemical compound culprit for this blood in urine? And question 4, what is the minimum dose of drug B as compared to drug A? Minimum dose. "30 seconds from now and the chits will be collected. Thank you so much. So, drug B is Mesna, correct? Team B. Mercapto, very beautiful handwriting, Team B. Is it deliberate?
No, it was.
I'm sorry. Mercapto ethanol sulfonic acid. So no, that is not the compound name. But should I give them that? It's like more complex than that.
Sulfonic sodium.
Okay, it's actually sodium 2 mercaptoethane 1 sulfonate, but I can give you mercaptoethane sulfonic acid. At least the chemicals are picked correct. So the compound culprit for blood in urine is acrolein, correct, and minimum dose. No, we'll give them marks. We'll give them marks, and minimum dose is 60%, correct. So they've opened their bank account here. So huge round of applause for Team B. And now to the audience. We all know we are dealing with Mesna. After gross hematuria, the charting of drug B is actually changed for the future cycles as per COG protocol. What is the change that is given in the COG protocol? If you have a gross hematuria in a cycle 2. So we actually start with a 120% dosing, or we give an infusion. A huge round of applause once again, and we go down to Savior 3 Team C. 3-year-old male, I'm sorry for rushing through the quiz because I have paucity of time. 3-year-old male, stage 4, INRG classification, MINC amplified. Primary was adrenal, PET scan is attached. Started on frontline regimen, rapid Kojak, underwent surgery with 70% tumor reduction, suggestive of poorly differentiated neuroblastoma. Unfortunately, before HSCT had abdominal distension, new onset raccoon eyes, PET scan confirmed a relapse. Started on a salvage chemo, which was a 5-day protocol, with a topoisomerase 1 inhibitor, which is drug A. Drug B is started before drug A and given orally as a 3-day prior, 10-day later regimen. All of you, all hands on your chits, identify drug B. Next question. Patient faced diarrheal episodes, 100 to 150 ml per loose stool, yellow, watery, 10 episodes per day, starting on day 3 of the protocol. Mention the chemical compound of drug A responsible for causing this diarrhea. The chemical formulation. Next question. Prophylactic antibiotics are given as saviors. A preventive measure to avoid the diarrheas to convert SN38G to SN38. Mention the enzyme which is involved in this conversion, and that is why you're hitting that enzyme. Last question. First line therapeutic agent for treating delayed diarrhea caused by drug A. 30 seconds from now and the chits will be collected.
Done. So,
timer, please collect the chits. Team C first. Team C have finished their chits. Can they get more chits? So Team C, the first question, coming back to the question, drug B started before drug A, and unfortunately the answer is cefexime or cefpodoxime because the antibiotics are started prior so that the enzymes are inhibited earlier and antibiotics are continued for long, so the enzyme inhibition continues. So unfortunately you got the first answer wrong and that is bounced, and Team A gets a +10, Dr. Prashant, and only Team A gets a +10. So coming back to Team C, 2 2 is not topotecan, unfortunately. The question was the chemical compound of drug A responsible for causing the diarrhea. Is anyone? It is not SN38, otherwise I would have not mentioned that in third question. I'm not that simple.
Anyone from the audience?
So even I have to check it. I'm sorry for keeping this question, but the compound is 7-ethyl-10-hydroxycaptothecene, which is actually the chemical formula of SN38. I'm really sorry. The enzyme involved is beta-glucan. Nobody gets that correct, Dr. Prashant? Okay. Question 2, everyone is out. Question 3, the enzyme involved is actually beta-glucuronidase. Team C does not get it. It is not saccharose, it is not lactase. Nobody gets it. Answer 4 is not octreotide. I'm sorry. The first line agent is loperamide, which is your first answer actually. So the team C does not get it. The first line agent for treating irinotecan diarrhea is a high dose loperamide. It is a very high dose, and for adults the recommended dose is 4 mg start followed by 2 mg every 6 hourly, which is a very high dose. So team C does not get it. Team A gets a +10. That's it. Team A is really scoring in this one. They have some irinotecan thesis going on? No. So huge round of applause for all the teams.
Team A neurons are working quite fast.
The chocolates is working, right? The sugars are working. We should distribute more chocolates to other teams. The sugar rush should work. So here we go towards team D. Round 2, Savior 4, team D. L is a 4-year, 3 months. Beta thalassemia major kid, was diagnosed at 6 months of age and is on regular blood transfusion since then. The transfusions given are packed at red blood cell every 3 to 4 weeks, and the pre-transfusion hemoglobin is maintained of about 9.5. A folic acid supplementation is given. A serum ferritin is 2800. He receives drug A once daily to manage iron overload in the body. All hands on your chits. Identify the drug A. I think that's a simple one. Team C is really looking me into the eyes now. I'm scared. Oh, this one has gone off. I'm sorry. Can we have this functional again? No problem. I'll just tell you they're taking drug A once daily regimen. So you have to identify the drug A. The second question for your chits is correct way for a patient to take the tablet formulation of drug A. There are 5 things given in the protocol. Even if you write 1 or 2 correct, I'll give you the marks. Correct way of taking that tablet. Third question for you. The FDA approval of drug A is above a certain age, though we want that to change. What is that age? I can see ma'am smiling at me from the distance. And what is the dosing of drug A in NTDT in mg per kg? 30 seconds from now and the chits will be collected. The chit tore really fast. We can collect it fast. I can have more answers from the audience. I'll be more than happy. Time up. Chits go here. Team D, can I have your chit? Time up, time up. PMT exam, time up. Okay, so here we go, Team D. So the first answer is Decirox, that's correct, plus 10 for Team D. Huge round of applause. Second answer, to dissolve in an orange juice, not to be diluted in a metal glass. So perfect, that's correct. The answer is you have to use a plastic stirrer. You have to use a juice, apple juice or orange juice. And you have to take it empty stomach. But I give you that. I have specified that. I can give you that. The FDA approval is above 2 years, correct for Team D. Again, huge round of applause. And the dosing in NTDT is 10 mg per kg to start with. That's also correct. A huge round of applause for Team D to take all the questions correctly for this. So, round for the audience. Mention the instruction for chelation therapy when it comes to a thalassemia patient during febrile illness. We always tell, no, maintenance 6 MP methotrexate, band. When it comes to thalassemics, they have febrile illness in and out. So what is the instruction you'll give during the febrile illness for a chelating agent? Anyone from the audience? No mumbling, raise hands. Yeah, please.
They are taking deferriprone, they have to stop it during the febrile
Okay.
illness.
And what about the other two if they are taking ox or oxamine?
Oxamine is also stopped.
Okay, and ox?
But I'm not sure.
Okay, but huge round of applause and 2 chocolates to her. They've been pretty low during the quiz. So actually, the TIF guidelines recommend that you have to temporarily discontinue DFO when there is a febrile illness because you don't know which pathogen is causing it. Non-siderophoric iron chelators like deferricerox, which is correct, and deferriprone, if you have normal counts, can be continued. So I'll take the half bite of that chocolate. Okay. So round 3 is one of the flipping rounds. Everybody is taking a seat back. Yeah, we are ready to go. Dr. Prashant, the stage is yours. So we have a rapid fire round, which we have to start with team audience first because the audience have been pretty low. So this round is for you.
So at the end of round 2, team A is leading with 75 marks, followed by team D, they are on 60 marks, and team C and B is on third with 40 marks each. So I think this rapid fire is really going to be interesting. And for this, we have total 10 questions that we'll be asking in next 3 minutes, right, Swati? Yeah. So I'll be giving like questions. You can say pass, and if there is time permits, then we can go back to that question. So it's better if you don't know the answer, just say pass, and you can then come again to the question, so that at least you try all the questions. And so we'll start with the audience, I guess. So audience, simple questions for you for the chocolates. So mention the value of salary that is enough to make a post FNB and DM happy. I think senior consultant must, JP sir can answer that question. So I think, Swati, you want to take this question? So mention the AQI around West in Gurugram today. I mean 300, 400, how much it is? Okay, so I think we can directly go to the question. The audience seems less interested in these questions, I guess. So we'll start with team D, right? So team D, who is Swati? You are checking the time, right? So I'll be starting the questions, and your time starts now. Mechanism of action of crenalazumab.
Pass.
FOS aprepitant works by blocking NK4 receptor.
False.
Full form of NRAS.
Pass.
Name one black box warning of eculizumab.
Pass.
What is the standard formulation of 6-MP suspension which is available now?
10 mg per 1 ml.
Wrong answer. Tower trial is associated with which drug?
Pass.
A pathologist finding of giant cell platelets is associated with comparison to which structure in the peripheral smear? Which structure of the cell he compares it with?
Lymphocyte.
Wrong. Flow cytometry finding of CD10 negative ALL corresponds to which molecular subtype?
Pass.
So, as a pre-transplant regime, one drug was given to this patient, and this patient develops this classical rash. What is the drug that has been the offending agent in this rash? Name the drug.
Pass.
So, pick the wrong prescription. Resident had written this prescription. Can you mention which part of this prescription is wrong? Supportive care, day 1, day 2, day 3. Which part is wrong? The prescription for carboplatin and etoposide.
Can you repeat from first question?
Yeah. So first question you want? Okay, so here we go. Mechanism of action of crenalazumab.
P-selectin inhibitor.
Yeah, that's the right answer. So FOS aprepitant works by blocking NK4 receptor.
False.
Pass. So full form of
False. It is false.
False, right? It's the right answer. Okay, full form of NRAS. and RAS.
Pass.
Pass. Black box warning for eculizumab.
Answer for seventh question is neutrophil.
Answer for this seventh question. No, you have told the wrong answer, I guess, for seventh. You won't, that answer you can't give. Only those you have passed, you will be.
Fourth question, thrombosis.
Fourth question is?
Thrombosis.
So eculizumab you are saying?
Yes.
No. Wrong answer. Any more passes, Deborah?
Sixth question.
You want to try sixth question?
Question 6.
There is no negative marking for this, right? So tower trial is associated with which drug?
Eighth question, Kala positive.
CD negative ALL corresponds to which molecular subtype is Kala positive? No, wrong answer.
Ninth.
I think. Yeah, ninth. Yeah, this is the ninth. Name the drug which is responsible for this rash. 3 minutes is too a long time for, I think. So time up, 3 minutes up. Okay. So finally, how many questions they have got correct? No, correct questions. Only 2 they got correct. No, they. After that they answered other questions also. No? Oh, okay. So okay. So now I'll go to team. So should I say the answers also? Last may I'll tell the answer, right? So coming to the team C, right? So ready? So team C, your time starts now. Mechanism of action of Lusparta receptor
TGF beta receptor
is the right answer. Olanzapine works by antagonizing 5-HT4 receptor. True or false?
false.
True. Full form of KMT2A, I mean, which is seen in leukemias.
Pass.
So what is the one black box warning of emicizumab?
Pass.
Name one dietary advice which you will prescribe a patient of on 6-MP associated with hypoglycemias.
Pass.
Okay. Name Avalon trial is associated with which drug?
Pass.
A pathologist finding of microcytosis is associated in comparison to which structure in peripheral smear? He compares to which cell when he calls it?
Lymphocyte.
Pardon?
Lymphocyte.
Right answer. A pathologist mention the CD markers for monocytic variant
11
of AML.
14 lysozyme.
Pardon?
11C 14 lysozyme.
Okay, right answer. Coming to the 9th questions. Identify the drug associated with this rash in a leukemia patients. Which drug he has received?
Cytarabine.
Cytarabine, no, you don't see this rash with cytarabine. Wrong. Now coming to the last questions, pick the wrong in the medication chart. You can take your time. So you can see the prescription. Fludarabine and cytarabine as a part of FLAG-IDA protocol, I guess it was prescribed. No, not FLAG-IDA. Fludarabine and cytarabine has been given. So you can tell me what part of the prescription is wrong.
Fludarabine is given first, followed by cytarabine.
True, right answer.
Perfect.
So you want to go to question?
Yes.
3 that you have said passed, right?
Mixed lineage leukemia for KMT2A.
So I'm asking KMT2A full form, not the MLL full form. So you're playing games with me, right? I understand. That was the old name. So question 4, black box warning with emicizumab.
Thrombosis.
Right, thrombotic microangiopathy and thrombosis. You're right. Question 5, hypoglycemia associated with 6-MP. Which advice would you give to the patient?
Question 6.
Avalon trial.
6. This is a very famous trial, Avalon trial. Which drug? Time?
That's it.
Time's up. Okay, so they got how many questions correct?
5.
Okay, so coming to the yeah.
So this partnership they got correct.
Olanzapine, yeah.
And KMT2A lysine specifically had transferase, which is wrong.
4th they got correct. I mean
They
MSism.
got correct.
Yeah.
6-MP you have to avoid fasting.
No, they.
And snacking.
Right.
Avalon trial is
Venetoclax.
And actually for the 7th, it is a nucleus of a small lymphocyte and not a lymphocyte per se.
They told lymphocyte just. Okay, okay.
Lymphocyte. Ma, we told.
They told a small lymphocyte. I think we should give marks. He told specifically the small lymphocyte, right? I think we should give them the marks.
Monocytic markers are correct.
Yeah.
The drug is actually sorafenib, which is known as hand-foot mouth type of illness, and fludarabine is correct. So it is 1, 2, 3, 4, 5, 6.
6, total 6. Okay. Right. So after this, I'll go to team B, right? Ready? Yes. So your time starts now. Mechanism of action of rivaroxaban.
It is a 10A inhibitor.
Correct answer. Dexamethasone dose is reduced by 20% when used with fosaprepitant. True or false? True. False. I mean, you are wrong. Full form of FLT3.
FMF like tyrosine kinase.
Right answer. Name one warning with use of mitapivant. Mitapivant.
Pass.
Mention the 6-MP metabolite associated with efficacy in ALL. The metabolite of 6-MP, which is responsible.
Hyaguanin.
6-thioguanine.
Yeah, right answer. Einstein trial is associated with which drug?
Rivaroxaban.
Right answer. A pathologist finding of macrocytosis is associated in comparison to which structure on peripheral smear?
Nucleus of a small lymphocyte. Lymphocyte.
Right. Flow cytometry finding of CD66C is associated with which molecular subtype? This is an easy one.
AMKL.
No, wrong answer. Identify the drug associated with this rash in a lymphoma patient. Which drug?
Vincristine.
Vincristine causing this rash. So you're wrong. I mean, coming to the 10th, pick the wrong prescription. So this is the like on discharge advice has been given by a resident. Can you pick which is wrong in this prescription?
Septran galat. Septran oral twice a day. Septran is wrong. Septran is given thrice weekly or 4 times in a week.
No,
they have written twice a day.
No. You can give like OD, BD, twice weekly or like Saturday or Sunday also. So wrong answer. So total they have got how many answers correct?
Question 4.
Okay. They have time. Okay. So,
Question 4 is only one to pass.
so one warning with use of mitapivant. They cause hemolysis actually.
So first one we got correct, which is a 10 inhibitor. False is correct for them. False is wrong for
Wrong
them.
for them. FLT3 they got correct.
2 questions correct. 5th question is correct. 6 TG is correct. Rivaroxaban is correct. And actually it is compared to a size of an entire small lymphocyte.
They told small lymphocytes only.
Small lymphocytes. We changed the answer to small lymphocytes.
No, they change. It's fine. I mean, we also considered for them because as small lymphocyte I could not.
So we can give them. The fusion is BCR-ABL for CD66, which is wrong. The next is a very important finding we see for the image. Dr. Prashant can highlight that. And the next is vincristine and voriconazole are given on the same day.
That is wrong. Okay. So after
So they got 5 correct.
5 correct. Okay, fine.
A huge round of applause for them.
So finally we have team A. Ready? So your time starts now. Mechanism of action of emicizumab.
Pass.
Dexamethasone dose is reduced by 50% when used with rolapitant. True or false?
False.
Right. Full form of P10.
Pass.
Name one black box warning of luspatarcept.
Pass.
Name one indication of giving 6-MP with allopurinol.
Pancreatitis. 6-MP pancreatitis.
Right answer. Radius trial is associated with which drug?
Pass.
Radius trial.
Pass.
Peripheral smear cutoff of cystiocyte index to be significant. How much percentage is significant?
1%.
Right answer. Mention the DNA index cutoff on flow cytometry for hyperdiploid ALL.
Pass.
Mention the name of these lines seen in cancer patients. What are these lines? you seen many drugs?
Pass.
Identify the drug associated with distress in lymphoma patients. Oh, okay, anyways. Pick the wrong prescription. 10th question is pick the wrong prescription. So relapsed refractory T lymphoblastic lymphoma, this prescription has been prescribed, and you can see the day 1, day 2, day 3.
Vincristine dose,
How much?
2 mg maximum.
Okay, right answer. So you can go to your questions.
Question 1.
Question 1, mechanism of action of MSC-Zumab.
Bridging between factor 10 and it's a bypassing agent. It's a bypassing
Right,
agent.
and bridging between?
Factor 10.
A kind of, I mean, I won't say because there is no conflict of interest. You want to, we don't give marks for them, right?
It's a bridging.
I don't want to be the devil here. I'm letting you be the devil.
No, I mean, audience can decide. Any other questions they have left?
Question 3.
Question 3, full form of P10.
Question 4.
DNA index also 8, question 8. I mean, this you should answer, yeah.
Question 6.
Radius trial. Question 6, 8.
Question 9.
1.1%. 1.
Pardon, sorry, yeah?
For hyperdiploid, 1.1.
1.1.
Right answer.
And question 9.
What is this line?
View lines.
Blue lines.
Okay, I think time
Time's up.
is
Okay.
up. Yeah.
So they got how many correct answer? 5.
5
Okay.
correct for them.
Okay, so
Finally, we have
a huge round of applause for all the teams. And that's the end of the quiz, right?
So we can go on to the next session and we'll announce the prizes after that session.
We will announce the winner later on. So the next
Immediately after this session, we'll announce.
Sure. The next session we have Dr. Vignesh Pandaranjan. He's an associate professor, PGI Chandigarh, and he's going to talk about primary immunodeficiencies, old wine in new glass. So can we have Dr. Vignesh on stage, please? I want everyone to settle down for a session, please.
Okay. Just tell me when to start. I can start. Okay. So, thank you, organizers Dr. Vikas and Dr. Swati for having me here. So, I am the odd person here. So, okay. So, I'm an immunologist. I'm not a hematologist. So, I can see some familiar faces who have done MD Pediatrics from PGI Chandigarh. So, I'm from PGI. I'm an additional professor in the Allergy Immunology Unit, Department of Pediatrics. So, okay, so the topic for today given to me is primary immunodeficiencies, old wine in a new glass. I have nothing to disclose. So this is going to be the outline of my talk. So I'm going to focus on what are the new updates in inborn errors of immunity with the specific focus for you audience, that is the hematology or oncology presentation of inborn errors of immunity. So just now we saw a wonderful quiz. So let us start with the quiz. So what is the first inborn error of immunity to be identified or to be recognized? It's something related to hemato-oncology. How many of you think it is XLA, X-linked agammaglobulinemia? It is actually neutropenia. It was the first, it was not recognized to be an inborn error of immunity to begin with or a PID, but historically this is the first PID to be described. Okay, so we have seen a huge boom in the number of PIDs in the last decade. This is because of the expansion in the availability of genetic testing available and the considerable reduction in the cost of the next generation sequencing. So that is the reason for this rise in the number of monogenic defects in the immune system which has been identified these days. So let us focus on neutropenia. I'm not going to talk about febrile neutropenia. This is congenital neutropenia. So these are characterized by myeloid maturation arrest at the pro-myelocyte stage of development. The ANCs are going to be very few, usually less than 200, and symptoms usually start very early in the age. And so these are the disorders of neutrophil production. So they have a higher risk of bacterial and fungal infections. And usually they present with the skin ulcers or skin cutaneous cellulitis like lesions without formation of pus, because neutrophils are very important cells for pus formation. So this is how usually they present. They present with erosive gingivitis or oral ulcers, rectal ulcers, sinusitis, pneumonia, and septicemia are not that common, but it can be seen. But the most common manifestations are these mucocutaneous manifestation. And this is one typical picture which can, as a spotter for severe congenital neutropenia, how does it present? So you can see a ulcer here, a deep ulcer, and this patient also had pneumonia. And C, the panel C is a peripheral smear where you don't see any neutrophils, just see other leukocytes. And panel D, E, and F, these are the bone marrow pictures, which shows it is a eosinophilic marrow. You don't see any mature neutrophils there. You can see occasional promyelocytes, but you don't. So this is the typical severe congenital neutropenia. And these are the cellulitis-like lesion in a child. So this is a 3-year-old girl who presented with such lesions. And this is how a typical CBC looks like. So you have a gross reduction in the polymorphonuclear the neutrophils. But if you see the monocytes and eosinophils, they are very high. So there will be a relative monocytosis and eosinophilia. The other counts are going to be normal. Immunoglobulins are going to be normal. So the next investigation which we do in such case, especially with an older child, is the cyclicity, which we look at. And this child had a considerable drop and a rise over the last 6 weeks. So this is a cyclical neutropenia, which is typically associated with a Elaine defect. And bone marrow has to be done at the nadir of neutropenia, not when the neutrophil counts are rising, to demonstrate a maturation arrest. So this is the 2025 update for neutropenia genes. So Elaine is the most common, that is autosomal dominant inherited. We have an X-linked form of neutropenia, that is the VAS, gain of function. We have several other defects which are autosomal recessive in condition. We also have syndrome-associated neutropenia like Schwackman-Diamond, glycogen storage 1b. So there is a huge list of defect. So one has to look for the syndromic features and proceed with the whole exome sequencing whenever we identify in these patients. Now moving on from neutrophils to thrombocytes, the platelets. So Viscott-Aldrich, the typical triad we already know, but you should also remember persistent thrombocytopenia in a male child could well be a Viscott-Aldrich, which we previously used to call as X-linked thrombocytopenia. So this is the largest cohort of Viscott-Aldrich published from India. In these 42 patients have been described, and 8 of these 42 patients were initially diagnosed and managed as ITP. So whenever you have a ITP, especially male ITP, when their platelet counts don't cross beyond 1 lakh in your clinic, always do an exome to identify a Viscott-Aldrich syndrome. Of course, you do have other autoimmune manifestations in severe Viscotts like autoimmune hemolytic anemia, vasculitis, and others. So moving on with autoimmune cytopenia, so you can have defects. So I've grouped them into 5 different categories. So one is that there could be a problem with T cell tolerance, so which happens with central T cell tolerance or a peripheral T cell tolerance or T cell development itself, because VDJ recombination is very important for development of tolerance to self antigen. So whenever you have defects in these genes, you can develop autoimmunity. Or there could be a defective in T cell signaling where you have a hyperactivated T cells, the excessive activation of T cells, which happens due to APDS, the CTLA4. Or there could be a interferon signaling disorder like type 1 interferonopathies like ACP5 defect. Or there could be a defect in the resolution of inflammation where there is an apoptosis defect in the lymphocytes, which happens with autoimmune lymphoproliferative syndromes. So what is important for a clinician? The leading autoimmune manifestations in IEI, the most common is going to be the cytopenia. The others are enteropathies and endocrinopathies. The most commonly, the autoimmune cytopenias that are reported in PIDs are the autoimmune hemolytic anemia and ITP. Autoimmune neutropenia occasionally have been described, and Evans syndrome is a PID unless proved otherwise. So this is one seminal paper published in 2017, and this is a French registry paper, where they have shown 26.2, around one-fourth of the patients were noted to have autoimmune or inflammatory complications, and the risk of autoimmune cytopenias was 120 times higher in patients with IEI as compared to the general population, and the risk of inflammatory bowel disease was 80 times higher. When we look at the type of the PIDs, the cytopenias are most common. In the older age group, it is the B cell CVID, that is the common variable immunodeficiencies. In the early age, in the children, what we see is the T cell deficiencies, which commonly presents with autoimmune cytopenia. The inflammatory bowel disease is most common in the innate immune deficiencies. So this is another study of Evans syndrome, where almost two-thirds of the patients with early onset Evans syndrome had a monogenic cause related to inborn errors of immunity. So this is a huge number. So genetic findings have a prognostic significance, and it guides the physician's choice of targeted treatment, which I would come to you later. So this is a representative case, a case which we managed in PGI. So this is a boy, 4-year-old boy, who came with Evans syndrome, in fact pancytopenia, but he had autoimmune hemolytic anemia and thrombocytopenia. His DCT was positive. He was given loads of steroids, IVIG, he was given rituximab, no response. And when we did the immunological evaluation, he had high IgG levels, he had high vitamin B12 levels, the DNTs, that is the CD3 positive, TCR alpha beta positive, 4 negative, 8 negative T cells, those are elevated. And soluble Fas ligand is high. The whole exome is normal. So what is the diagnosis here? It's autoimmune lymphoproliferative syndrome, but this patient had a somatic variant. So there comes the role of targeted gene panel. So whenever you encounter autoimmune lymphoproliferative syndrome, it is always better to go for a targeted gene panel because it has a greater depth. And this child was diagnosed with ALPS and was started on sirolimus, and we could still come down on steroids, and this patient had a good quality of life thereon. So this is the project which we did it in PGI. So 31 children presenting with autoimmune cytopenias were evaluated for possible inborn error of immunity. So this data is compiled with the help of the hemato-oncology unit as well. So in which 46 patients had a genetic mutation in known PID genes. So these were well categorized PID. 5 were PID by phenotype, but genetics we are not sure. 11 was no PID. So almost two-thirds have an inborn error of immunity. The most common were the severe combined immunodeficiency, ALPS, and the immune regulatory, the LRBA, 3 each. If we look at the features of lymphoproliferation, recurrent infections, low IgG, or immunological abnormalities such as low CD3 or 4 T cells are seen in the PID cohort. And this is the data compiled from 2 different centers. One is from the Bangalore and the other one from PGI. So patients who presented with autoimmune cytopenia who were identified to have PID, you should see that the combined immunodeficiencies and diseases of immune regulation are most common in these patients. So these are the targeted therapies. So why we need to do genetics in case of autoimmune cytopenia? You can target the immunological aberration. If it is a CTLA4 or a LRBA defect, you can target the therapy by using abatacept or a sirolimus followed by a HSCT. If it is a STAT1, STAT3 gain of function, you can use JAK-inhibs. If it is a ALPS, sirolimus or everolimus is a better choice, followed by HSCT if needed. If it is a type 1 interferonopathy, you will go for JAK-inhibs. If it is a STAT3 gain of function, tocilizumab would be a good option. And if it is a SCID, obviously we'll do a hematopoietic stem cell transplantation. Okay, so we discussed about neutropenia, we saw autoimmune cytopenias. Let us move to familial HLH. So familial HLH, this is the current update. We have 3 more new genes that have been added to this group. So we can differentiate based upon if the patient is having hypopigmentation or a hyperpigmentation or without hypopigmentation. So the important addition here is the GMAP6 deficiency and the DPP9 defect. So let's move on to this case. So this is an infant with progressive cytopenia. This is a 2-month-old male child with a fever and rapid breathing for 20 days, was tachypnic, had hepatosplenomegaly. This is the family history. So what is the mode of inheritance by looking at this family tree? Yes, it's X-linked. So multiple male siblings are affected, mothers are carriers, maternal uncles have died. So these are the investigations. So this patient had a high white cell count, which progressed to leukopenia, progressive anemia, progressive drop in platelets, high serum triglycerides, high CRP, low ESR, low fibrinogen. So what is happening here? HLH, okay. So what HLH do you think? This is a 2 months old boy. Sorry? Primary HLH. Which primary HLH will be X-linked? We saw the family history. So moving on, this patient also had a high ferritin, blood culture showed candida, and ET aspirate showed Klebsiella pneumoniae. EBV, CMV were negative. This patient actually had a chronic granulomatous disease. So IgG levels were high, IgM was high, NBT there was no reduction. Dihydrorhodamine, there is no shift to the right in the patient, and the mother had a mosaic pattern of DHR. The B558 staining in neutrophils was considerably reduced in this patient, suggestive of X-linked CGD. So HLH can be a presenting manifestation of CGD, especially in X-linked CGD. So two patients we have noted, fulminant infantile presentation. Sorry. Okay, I will rush it up, don't worry. So two children had HLH as a predominant presenting manifestation, mimicking a congenital HLH. So the important clue comes from the family history, if you say X-linked history, or if there is an associated infection. So, and these children usually need both antimicrobials and corticosteroids, they don't need etoposide. SCID could also present with HLH. 6 patients we have seen presenting with HLH in the infancy. The clue comes from the BCG. So disseminated BCG usually lands these patients with HLH. This is very common in our country. This description you will not see in the Western textbooks because they don't give BCG there. So with BCG, with disseminated BCG, especially in X-linked form of SCID, they do present with HLH. So whenever you encounter an infantile HLH, always watch for disseminated BCG and the underlying SCID. Now we have EBV susceptibility genes with HLH presenting with EBV driven HLH. Previously we used to have only XLP1 and 2. Now we have an autosomal recessive condition, the CD27 deficiency. We also have EBV associated lymphoproliferation and EBV associated lymphoma as a predominant manifestation of IEI. They don't come up with HLH usually. The important one are the X-Men, which comes with viral infections, progressive hypogam, and low CD4. We have several other defects, but I think X-Men is something which more commonly we see. So coming to my final slide, the congenital neutropenia, should remember they don't come with no pus. They come with severe ulcers and severe neutropenia with monocytosis and eosinophilia. Evans syndrome or severe autoimmune hemolytic anemia in childhood is high likely to be a PID. You should do an immunological investigation, and genetics is needed in most of the cases. Persistent thrombocytopenia in a male child, think of viscotile-rich, and early onset HLH, do think of CGD and SCID, especially if there is a suggestive family history of or associated infections. So with this, I acknowledge my unit faculty, my unit residents, the allied departments, the funding agencies. This is the whole team with Dr. Sujit Singh in the middle, who is my mentor, and also our collaborators. Thank you for your patience.
Thank you so much, Dr. Vignesh, and thank you for your cooperation. Next, we have Dr. Amita Mahajan with us. She's a senior SO consultant pediatric hematology and oncology in the Presta Apollo hospitals. And she's going to talk about infantile leukemias, what next in 2025. Please welcome. Can we have a big round of applause for her, please?
I think it's really hard to ask people to applaud after such a long day and for such a heavy topic. All they want waiting for is the gala dinner. And I think big applause will come only when we close the session. So this topic has been assigned to me. I know you've all had a very long day. I'll try to be as brief and crisp as possible and just cover what is new. So I can't really say what is new in 2025, but I can definitely say that what we know as of in 2025, some of it may have happened a couple of years ago. So very little has happened within this year, but some things have happened fairly recently. So we all know that infant leukemia is rare. It accounts for 2 to 5% of pediatric ALL and about 10% of pediatric ALL. And apart from that, it can be undifferentiated or mixed lineage or mixed phenotypic acute leukemia. We know that it is usually the first trigger has almost certainly occurred in utero, and as for congenital leukemia, almost all one or two events, whatever the hits the child baby has had, has happened in utero because the baby is born with leukemia. So they have this classical clinical presentation of very high initial white count, and U3, 4, 5 lakhs is not surprising. They have massive organomegaly. Organomegaly itself may be causing respiratory distress. They have early CNS involvement. Even in infant AML, up to 50% may have CNS involvement, and leukemia cutis, which is classically seen with infant AML. Their prognosis is much worse, we all know that, and especially for congenital leukemia. So this is a child who presented to us about 4 weeks ago at 20 days of age, very sick looking, these classical clinical, nodules or leukemia cutis. He had presented with a white cell count of 4 lakhs. He was AML on flow cytometry, and despite giving an extremely guarded prognosis, this was the couple's first child. They insisted on starting chemotherapy. But his TLC progressed very rapidly, and he within the first week of starting therapy, we lost the baby with worsening hyperleukocytosis. One can say that we could have offered plasmapheresis or other things, but really we did not see a positive outcome. In fact, this NGS report just came yesterday, which showed that he had, even within infant AML, he had a mutation which is, carries an extremely poor prognosis, and almost all cases are fatal. So it was not surprising the outcome that this baby had. So infant AML, we know, is all characterized by the KMT2A rearrangements in 80%. 20% are non-KMT2A rearranged, and they actually do as well as ALL in slightly older children. The classical immunophenotype is CD10 negative, CD19 positive, HLA-DR positive with minimally differentiated early B cell precursors. They often co-express myeloid-related antigens much more than older children with leukemia. And until recently, and that's what's new, until recently, the 3-year event-free survival had been 40 to 50%, despite what protocols you use, despite which cohorts you take to transplant, and in addition were associated with high toxic mortality, relapse rate very high, and happening very early, usually on treatment. The non-KMT2A subtype accounts for about 20%, usually will present with later infancy and with a more mature CD10 positive B cell precursor subtype, and shares similar features as ALL in slightly older children, and is associated with better outcomes. So in terms of treatment, 3 groups have worked in consecutive trials with infant ALL. The first group is COG, which attempted a shortened intensified therapy with elimination of age and weight related dose reductions, because they felt the outcome was poor because we were actually delivering very little chemotherapy, and perhaps the answer lied in intensifying doses of the same drug. Unfortunately, the toxic mortality was so high that the protocol had to be modified 3 times. So they actually ended up with 3 cohorts with different doses given even within the same protocol. But they could recognize that babies who present within 90 days of birth at diagnosis resulted with as the most adverse prognostic indicator, and they had a survival of just 15.5% on this protocol compared to nearly 50% of those who presented after 3 months of age. But the event-free survival remained less than 50% overall in KMT2A rearranged ALL patients. The other group was the Japanese group, and in their consecutive trials, initially they tried to give allo stem cell transplant to every child. after intensive chemotherapy. But even with this was their intention to treat, there was very early relapse even before they could take the child to stem cell transplant, resulting in unsatisfactory outcomes. So, but those children who could actually reach transplant, about 2/3 of them had a 3-year event-free survival. In their subsequent study, the MLL03, they tried to give high-dose cytarabine pre-transplant so that they could actually take more children to transplant, and this strategy also resulted in just event-free survival of 43.2%. Finally, in the MLL10 study, they limited the indication to transplant to only those patients who were considered to have high risk infant ALL, which was based on KMT2A status, age, and presence of CNS leukemia. And the event-free survival of this cohort, which, until we used immunotherapy, this was the best survival that had been reported for infant ALL, with restricting stem cell transplant to only the high-risk cohort, and they got this, 66.2% event-free survival. The Interfund study is the one that we are most familiar with, and most of us have used that. So this, the Interfund 99 had 482 patients over a very, over a 6-year period. They classified them as standard risk and high risk based on good or poor steroid response. High risk patients received allo transplant wherever it was feasible, and they also evaluated whether late intensification prior to transplant benefited, and it was found that it was not very useful. So the 5-year event-free survival for this study was again 46% with overall survival of 55%. And again, they could summarize that patients with unfavorable prognostic features, younger age, very high white cell count, poor steroid response appeared to benefit from allo stem cell transplant. And if you attempt to transplant everybody, in fact, outcomes may be inferior because of toxic mortality. The Interfund 06 study assessed 651 infants, and they classified them as having low risk, non-KMT2A rearranged, high risk, and those that did not fall into any category as in medium or intermediate risk. The medium and high risk were randomly assigned to receive either a lymphoid course kind of thing after the initial treatment, or a very intensive myeloid kind treatment with ADE and mitoxantrone based cycles. And the principal aims were to assess whether early intensification with post-induction myeloid type regimen would improve outcome. And this, they could show that it did not improve outcome for infant ALL compared with lymphoid course, the 1B that we are more familiar with. And there was no significant difference in the 6-year EFS comparing this study to their previous study. A post hoc analysis of this study, however, showed that the outcome according to received treatment was influenced by end of induction MRD response. So patients who had MRD levels, who had high MRD or well more than 0.05% had better survival rates with myeloid consolidation, while those who had negative MRD had better outcomes with a lymphoid consolidation. And patients with high end of induction MRD more often exhibited co-expression of myeloid markers. So there is probably a lineage issue there, so that they don't respond to our initial therapy, which is basically ALL-directed therapy. And this may well fit the hypothesis that relapse-initiating cells represent a stem cell-like phenotype that grants these cells the plasticity to thrive either as lymphoblastic or myeloid leukemia. So this was something that we learned subsequently on post hoc analysis. And it was obvious with all these trials that further improvement in outcomes cannot be achieved without introduction of novel strategies, just with intensification of conventional chemotherapy. So what we've learned new is, and the COG has been really driving these trials. Not all of them have ended with positive outcomes, but there have been new approaches to address this issue. So lestartunib was one of the first COG trials. It is a FLT3 inhibitor, and it was based on the fact that KMT2A rearranged ALL has high expression of the FLT3 gene. But unfortunately, the addition of this drug did not show any convincing benefit, in the COG study. They also looked at, I mean, azacitidine is very much playing a big role in elderly AML. So it was looked at whether azacitidine or histone deacetylase inhibitors, they seem to be very attractive agents for targeting infant KMT2A rearranged ALL. But again, this study had a negative outcome. So patients who had received at least one dose of azacitidine, the outcomes still were poorer than what we had achieved prior. So a pilot study of decitabine and vorinostat combined with reinduction therapy with relapsed ALL led to infectious toxicity. So again, that's that line of, it's not being actively followed as yet. So what's really changed is blinatumomab, and it started with, like a desperate measure. It was being used, and retrospective analysis of a very small cohort of 11 patients treated with blinatumomab for MRD reduction prior to BMT showed a 100% response rate, with 9 patients actually achieving MRD negativity, and the 3-year event-free survival and overall survival post-transplant was 47 and 81%. So with this, more sort of prospective data started coming in. So Interfan group conducted a single-arm pilot phase 2 study to evaluate the role of blinatumomab combined with the Interfan 06 chemotherapy backbone, and documented a remarkable 2-year disease-free survival of 81.6% in 30 infants and an overall survival of 93%. So given the promising results of this pilot study, blinatumomab combined therapy is being evaluated in a larger cohort of patients in the ongoing international non-randomized phase 3 study, the Interfan 21. The COG investigators are also currently investigating BCL2 inhibitor venetoclax on top of Interfan backbone chemotherapy combined with blinatumomab in their next frontline infant ALL trial. Menin inhibitors are designed to bind KMT2A pocket on menin, preventing the formation of the fusion protein complex that leads to rapid inhibition of its expression. And this interaction is critical for the abnormal gene pattern observed in this cohort of patients. A phase 2 study, the AALL2121 for relapsed refractory infant ALL, evaluating the revumenib in combination with chemotherapy, has been initiated. The results are awaited. In fact, there are no preliminary results as well. I just wanted to share that multiple approaches are being looked at to see how can we optimize outcomes for this cohort with extremely, suboptimal survival at the moment. So CAR-T has been evaluated in the PLAT2 and PLAT5 studies investigating the feasibility and efficiency of CD19, CD22 specific CAR-T cells, again in a relapsed refractory cohort with infant ALL, and among 18 infants, it was successfully manufactured in most of them, and at a median follow-up of 26.9 months, 93.3% achieved MRD negativity by day 21, and this is kind of one of the best outcomes seen so far. And 1 year leukemia free survival of 66.7%. And in another study, 13 infants achieved a 2-year relapse-free survival of 67%. But the issue with using CAR-T cells in this cohort is that they have high risk of relapses due to the myeloid leukemia switch, because again, based on the stem cell, they have the propensity that they can thrive either as a lymphoblastic or a myeloid cell line. So this is a space that we have to watch for and, see how it shapes up. Clofarabine, unfortunately, we don't have, we used to have access to it. We don't know, but, this has also been evaluated. It was found to be efficacious, but a very high treatment-related infectious mortality, and all groups feel that they should be reserved as a salvage alternative due to the high toxic mortality rather than using in frontline setting. The role of stem cell transplant in all these studies, it continues to be a little bit, ambivalent as to who exactly likely to benefit. So the precise role is uncertain, but we know for sure that the cohort of patients that we label as high risk, a very young age, very high WBC, persistence of MRD, and CNS involvement,
does benefit from stem cell transplant, because otherwise their outcome is really extremely guarded. But the current international practice is to have a multidisciplinary discussion involving all the stakeholders involved, look at the cytogenetics, look at the MRD, and take a decision regarding transplant on a case-to-case basis. So this is the summary of the current consensus treatment strategies for high, consider a transplant; for intermediate, infant induction, intensive chemotherapy, and where feasible, blinatumomab is now, at least in the ongoing study, it is Interfan 21, this is being added. So these are the current recommended approaches, but these are all the different pathways through which we are trying to address this, but not yet. I think we have to wait the next few years to see which approach will pan out the best. But blinatumomab at least seems something that that's feasible, that may be doable. Infant AML is usually either acute monocytic or megakaryoblast. They dominate this group. The transient abnormal myelopoiesis that we see in Down syndrome, 20% will evolve into AML. And just a word about the acute megakaryoblast leukemia, which is classically seen in Down syndrome, just that it can be extremely difficult to diagnose because the number of blasts both in the peripheral blood and marrow is small. The bone marrow itself may be difficult because of extensive fibrosis there. So it is really, we depend on the cytogenetics or the presence of GATA mutation. But just for the fellows again, that there are some classical features on morphology: cytoplasmic blebs, clumping, and binucleation. So the cytoplasmic blebs, if you get in your OSCE or in your exam, that is acute megakaryoblast leukemia. Congenital AML is again extremely aggressive with CNS infiltration in around 50%. Subcutaneous infiltrates very commonly seen. Intracerebral scleroma is also not uncommon, and this group of patients we recommend to have CNS imaging at the time of presentation. So in terms of infant AML, again 55% are KMT2A rearranged, but they otherwise, compared to adult AML or older children AML, they have a huge paucity of mutational burden, so not that many targets that one can target. The treatment for infant AML is currently the same as that we use for older children and adolescents. Some collaborate groups have identified AML less than 1 as high risk, and they use even more intensified treatment than we use for older children. But doses have to be adapted due to the pharmacokinetic and pharmacodynamic profiles of the infants. No protocol has been designed for this specific subgroup. I think I am on virtually the last slide. GEO, again, it has been used and it has been shown to, slightly improve survival, but these are just trends and no significant statistically outcome. BCL2 inhibitors have again been used in a very, in various case series with, again, it is very early to say whether they can help us in this cohort of patient. And menin inhibitors are again, like for infant ALL, are being tried in this cohort as well. So for transplant in infant AML, again, the same indications as for older children, but just a very recent paper showed that if we were to choose to take an infant AML to transplant, BuCy-mel is superior to BuMel as conditioning regimen, and that was just published in June this year. So to summarize, it is one of the most difficult clinical situations that we encounter in pediatric oncology. Standard approaches still do not cure the vast majority of patients. Further intensification of existing chemotherapy protocols is unlikely to be beneficial. And though most treatment failures are due to relapse, treatment-related mortality continues to be an issue. But recent discovery regarding the unique biology of these leukemias is fueling development of exciting drugs. Blinatumomab definitely seems exciting and are increasingly being incorporated into clinical trials. And hopefully 5 years from now, we would have different curves to show. Thank you.
Thank you so much, ma'am, for such a knowledgeable insight, and thank you for cooperating with us. Before we move on to the next session, we have the prize distribution for the Ignite quiz. And may I call upon Dr. Prashant, Dr. Swati, Dr. Vikas Dua, and Dr. Rahul Bhargava on stage, please, to give away the prizes. Okay, so the third winner of the Ignite quiz is Shriram and Labanya from Apollo, and it's a tie between Saurabh and Abhinav from AIMS, Dr. Saurabh and Dr. Abhinav, and Dr. Shriram and Dr. Labanya from Apollo. Can we please have a good round of applause for them? We're just about to finish the event, so a little, appreciation and a little energy won't harm anyone. So it's a tie. Good job done, doctors. The second prize goes to Mehek and Shubham, Dr. Mehek and Dr. Shubham from AIMS. Congratulations, doctors. Congratulations. And not to mention, the first prize goes to Dr. Nikita and Dr. Shavani from AIMS. They deserve a much better applause than this, guys. Congratulations to both of you. Thank you so much, everyone. So the next session, we have a debate by Dr. Sohini Chakrabarti, who is a senior consultant hematology oncology BMT FMRI, and Dr. Dhwani Thakur, who is a consultant and at Medanta. So can we have both of them on stage, please? Without any excuse, I would like to say that we are running short of time, so they might skip or be a little fast with their slides.
Good evening, everyone. I will be speaking on TCR alpha beta depleted haploidentical hematopoietic stem cell transplantation in pediatric acute leukemia. So as we know, allogenic transplants are indicated in children with high risk, relapsed or refractory acute leukemia. In the absence of an HLA matched donor, HLA haploidentical relatives are now being exponentially used to offer the chance of an allograft to any patient in need of a transplant. Haploidentical transplant has several advantages such as the graft versus leukemia effect, motivated donors, rapid and economical graft acquisition, and donor availability for cellular therapies post-transplant. Haploidentical transplants can basically be divided into two kinds: T-cell depleted, which is done by ex vivo depletion of GVHD causing T-cell subsets, or the T-cell replete transplants either using post-transplant cyclophosphamide or by using the Beijing protocol, which uses the approach of modulation of T-cell alloreactivity. So while there's enough evidence that low grades of acute GVHD and chronic GVHD are beneficial by the GVL effect that they help in, however, severe GVHD actually overrides this benefit and leads to increased non-relapse mortality and decreased survival. Hence, the goal for transplant is to retain the GVL effect while limiting or eliminating GVHD. Graft engineering is the key to attain this fine balance, and TCR alpha beta depletion is one of the strategies that can be used. So T-cell depleted transplant started way back in 1995 with CD34 positive selection. However, delayed immune recovery, high rates of infections and relapses were the major challenges. Later in the early 2000s came the negative selection leading to CD3, CD19 depletion, which was somewhat better, but however, infections and relapse rates were still high. Later in 2011 came the TCR alpha beta depletion technique, where the alpha beta T cells were depleted and the beneficial gamma delta T cells were retained in the product, which actually enhanced immune recovery and also reduced the rates of relapse. And now we also have CD45 RA depletion, where specifically the naive CD45 RA cells are depleted and the memory CD45 RO cells are given to the patient, which has further reduced the incidence of infections. So TCR alpha beta depletion is done via the Clinimax device, where the alpha beta T cells are bound by an antibody attached several factors that may influence GVHD. However, in general, the cumulative incidence rates of severe grade 3-4 acute GVHD as well as chronic GVHD has been seen to be significantly higher with the PTCY platform as compared to the TCR alpha beta. Particularly, chronic GVHD rates are much lower in the T-cell depleted platform. This is a study which has shown significantly reduced rates of grade 3-4 and chronic GVHD. But when we compare several studies as shown in these tables, we can see that the acute GVHD and chronic GVHD rates with the TCR alpha beta depleted transplant is definitely low in comparison to the post-transplant cyclophosphamide platform. These forest plots also show the same thing, where very low rates of grade 3-4 acute GVHD have been seen. Coming to engraftment and graft failure, we see faster engraftment with the TCR alpha beta platform, hence reducing the period of neutropenia and reduced incidence of bacterial infections. Primary graft failures were a challenge earlier, but now with the modifications in the cell dose that we use and the conditioning, primary graft engraftment rates are very good now as comparable with the PTCY platform. Immune reconstitution. With this technique, the early wave of TCR gamma delta T cells in parallel to the NK cell reconstitution actually help prevent infections and have a GVL effect. And now with the addition of the CD45 RA depletion, the things are much better. So CD45 RO cells can actually be infused to the patient along with the stem cells, which help in reducing the incidence of infections, can be used as a preventive strategy, has been used as donor lymphocyte infusions. Instead of the conventional DLI, we can use the CD45 RA cells in malignancies without the risk of GVHD, and they have also been used for treatment of infections. Relapse, overall survival and disease-free survival are pretty good and comparable with the PTCY platform. More importantly, transplant-related mortality is very, very low, as we can see in this forest plot, as low as 11%. Overall, when we compare studies, the disease-free survival and overall survival are comparable across the platforms with much reduced non-relapse mortality in the T-cell depleted platform. Coming to the cost effectiveness, which is always a major concern for us, although the upfront cost of PTCY is significantly less as compared to T-cell depletion, but perhaps there is more than what meets the eye. When we think about the associated need of prolonged immunosuppression, VOD, hemorrhagic cystitis, and the GVHD, which is associated with the PTCY platform, the cost is actually much higher. And therefore, besides initial transplant costs, the long-term management of patients and subsequent expenses need to be considered when we are aiming for a realistic calculation. Hence, to conclude, there is no unequivocal superiority over one approach over another. However, this does have a reduced risk of complications and a reduced need for prolonged immunosuppression, hence minimizing the associated side effects. Historical concerns of uncontrollable infections are no longer reflected in the real world with the advent of graft engineering techniques, availability of letermovir, and also viral-specific cytotoxic T lymphocytes, which are now available. Graft manipulation strategies are feasible that can help us achieve GVL without the detrimental effect of GVHD. However, lab facilities and specialized techniques are still a concern. Although the lower immediate expenses, the toxicities of PTCY and management of GVHD may level up the differences in the cost in the long term. However, we need randomized studies directly comparing these two platforms, which will give us a clearer picture in the future. With this, I conclude. I would like to thank my entire team and thank you all.
Is there a pointer? Is there a pointer? Is there a pointer? No, it's okay. It's okay. Even if it's not. It's okay.
Here,
Take this one.
green one.
All right. Thank you. Thank you. Good evening, everyone. I'm Dr. Dhwani, and I thank you all for staying back for the last talk of the day. I'll try and be crisp. So, my topic is PTCY in haplotransplants in pediatric acute leukemias. I have nothing to disclose. So we all know, and we've already heard that because of the dearth of donors for allo-BMT, which is actually curative for a lot of conditions, malignant and non-malignant, with that actually haplotransplant took flight, and we've seen this platform coming up more and more in the current times. We know that haplotransplant widens the pool of donors, where the treatment of allogenic transplant becomes more and more possible for many patients who actually need it. They are easily accessible. It is beneficial for patients, especially leukemia patients who need this transplant urgently. However, it is fraught with a lot of other concerns like GVHD, graft failure, TRMs, etc. So it's important to understand how we can control the alloreactivity to eliminate the toxicities, but also maintain a balance with immune reconstitution and GVTs. So there have been several platforms that have been developed for haplotransplants. One is the T-cell depletion ex vivo, and the others are the T-replete transplant with the smart drug PTCY. So with the recent advances, the last decade has witnessed major improvements in haplotransplants, leading to results which are parallel to even matched sibling and merged transplants. So this is a brief overview of the haplo PTCY evolution, where in the lab initially the investigators found that by giving PTCY post mismatched transplants, we could actually achieve engraftment, and there were outcomes which were okay. And then it was Leo Luznik's group who actually transplanted high-risk leukemias with PTCY and non-myeloablative conditioning, and then it has been improved later on, and the rest is history. This is the basic mechanism how PTCY works. It works by selective depletion of alloreactive T cells that are responsible for GVHD and graft rejection, and it preserves the non-alloreactive resting memory T cells responsible for adaptive immunity. So that challenge is taken care of. The Tregs are spared, which helps in immune tolerance, and the HSCs, which are necessary for successful engraftment, are also spared. So there is no concern with engraftment. And immune tolerance develops by the three-step mechanism, which we see on the right-hand side diagram. So I thought we should look at a few studies. So we all know that there are no head-to-head comparisons of the two platforms, that is TCR alpha beta and PTCY. But now data is coming up with a lot of prospective and retrospective trials. So this is the first prospective PTCT trial of myeloablative haplotransplants with PTCY in use. So I would like to highlight that this study was done with 32 children across all types of leukemias with myeloablative conditioning. If you can see this, the TRM in this study was 0. And the severe GVHDs were 0. The chronic GVHD was less, and also now the data is building up, which says that patients who develop little amount of chronic GVHD do not relapse. So that's what we want for our acute leukemia patients, no relapse. The overall survival was quite good, around 70% and northwards, and the relapse rate was 30%, but they were successfully engrafted later. So this has led to a successful phase 3 trial comparing myeloablative conditioning haplo-BMT versus even MUD in the COG trials. This is the Spanish group, where they have transplanted around 200 children with both the platforms, PTCY and TCR alpha beta. And what they found is that the relapse rates and the TRMs were less with the PTCY group, but we know that this was not statistically significant. They found almost equal overall survival and the disease-free survival. This is the Korean data, which was for 34 patients, 23 being malignant, with myeloablative conditioning PTCY platform, with manageable GVHD, no severe GVHD, and chronic GVHD, which was similar to other platforms. They had a very good survival of around 85%. Then I thought we should look closer home and look at a few papers from India, where the leading groups have transplanted children with PTCY platform. So this is the data from Dr. Suparno's group, where they have had a good overall survival of 60-70%. This is the data from Dr. Yadav's group, which is also showing an overall survival of 70% manageable GVHD, and patients who developed chronic GVHD had limited GVHD, no severe GVHD, no severe acute GVHD, and a good outcome. This is the data from Dr. Vikas Dua's group, where they have transplanted several patients with PTCY platform with a very good outcome of overall survival of 83%. These are all these studies which have been published with PTCY platform. These are the major studies with all the three platforms, where we see that outcomes are more or less the same. So as we understand that there are different profiles to both the platforms, and we have to find a fine-tuned balance. So we know that PTCY offers a better and faster immune reconstitution. The infections are less as compared to TCR alpha beta, and we all know that we are dealing with day-to-day dealing with MDR sepsis in our wards, where nothing works for these patients, and we need quick engraftments. The GVHD rates are comparable, and the disease progression is less likely with PTCY. Coming to the very, very important aspect of cost and scalability. So PTCY does not need any ex vivo processing, does not need big infrastructure, does not need any processing. The setup is our standard BMT setups. The turnaround is very fast. It is equally applicable across all the centers, and the cost is maybe a tenth of what we would spend on alpha beta depletion. So this is a platform which we can actually consider for applying all across the centers. It does not need major specializations. We just leave it to the smart drug to do its work. These are the broader applications of haplo-PTCY, and it has been used beyond acute leukemias also in the non-malignant setups and conditions. So to conclude, PTCY is a safe option. It has a very good efficacy. It is universally available. It is a simple method, feasible across the centers, and the first slide that I came to, that it makes haplotransplant accessible to all. So I would like to conclude with this paper from the stalwarts in pediatric transplants, that both TCR alpha beta and PTCY platforms have broadened the applicability of haplotransplants. It's for us to choose based on what we have as resources, what we have as expertise, as donors. PTCY is a simpler approach for all practical standpoint. Currently in acute leukemia, it is something which is applicable and doable. It is less expensive, and the availability is widespread. And with this, I would like to end.
Thank you so much.
Thank you for your time and attention.
Thank you so much, Dr. Sohini and Dr. Dhwani, for this valuable insight. Now I would like to call upon Dr. Biju George on stage, please. And he's going to talk on the pancreas of conditioning regimens. Can you have a big round of applause for the doctor, please?
Thank you. So I'm going to be just talking briefly. I know it's time for dinner, so I'll keep it very short. We're going to look at triosulfan. So I think when we look at transplant and conditioning regimens, we sort of have to. So let me just get my. So we have to balance between having very intensive conditioning regimens where you have more non-relapse mortality due to regimen-related toxicity, which could either be SOS due to busulfan, the cyclophosphamide causing hemorrhagic cystitis, or the use of TBI causing interstitial pneumonitis. But on the other hand, when you come down on your conditioning regimen, you may have probably higher risk of relapse and graft rejection. So the question is there a sweet spot in between where both can be balanced out? And so if you look at different conditioning regimens based upon toxicity and based upon the myelosuppression and immunosuppression, the standard what we use, the BuSci ATG or the Site TBI, are probably the ones which have the highest myeloablation along with flu-bu, and somewhere in between is the flu triosulfan, which is myeloablative but still reduced toxicity. So if you look at what is the advantage of triosulfan over the others, so compared to melphalan, it is more lymphotoxic and myelosuppressive. Compared to busulfan, it is similar lymphotoxic and myelosuppressive, but have lower side effects, and it causes good engraftment with high levels of donor chimerism. And so it has become the standard of what we call as reduced toxicity myeloablative conditioning therapy. Now, so what is the data in children? I will just briefly talk about malignant and non-malignant diseases. So this is from the European group led by Ajay Vora, looking at about 70 children in 5 European countries, essentially children with ALL, AML, MDS, JMML, looking at whether you could use triosulfan based conditioning, and the dose is basically based upon body surface area, engraftment in about 98%, non-relapse mortality about 3%, acute GVHD is about 26%, relapse at about 21%. And importantly, the outcomes in terms of overall survival, if you look at the graph, is actually quite good, more than 80%, and the lower doses actually having better outcomes. They finally also looked at comparing the busulfan based conditioning with triosulfan based conditioning. So this is looking at flu-thiotepa busulfan versus flu-thiotepa triosulfan in about 128 patients with ALL, and essentially showing that both were similar. So you found there was no difference between busulfan or triosulfan based conditioning, especially when thiotepa was added. This is a publication from the Spanish group of GET, which looked at about 160 children transplanted for both malignant and non-malignant disease, and essentially showing that engraftment was seen quite high and failure was only in about 3 to 4%, very low incidence of VOD, having good low rates of acute and chronic GVHD, and survival of close to 80% with a disease-free survival of 70%. Triosulfan based conditioning has been used in inborn errors of immunity, and this is actually meta-analysis of the studies that were done. And if you just look at the right side, you find that most of the studies where they've looked at inborn errors of immunity, you're getting close to about 80% survival, ranging from 70 to 100%. There was one randomized trial looking at triosulfan versus busulfan, again by the same groups in Europe, looking at which one was better, and there was no difference. They looked at primary immune, basically looking at immunodeficiencies, hemoglobinopathies, bone marrow failure syndromes, essentially showing that the triosulfan had better freedom, transplant related mortality was lower, so it was about 10% in busulfan, 0 in the triosulfan group. The overall survival was similar, but what is important to note is this, that in the triosulfan group you always have a higher incidence of primary and secondary graft failure. And they showed that triosulfan was associated with less toxicity and less TRM but higher graft failure. So triosulfan is an excellent alternative to busulfan in non-malignant disease. The UK pediatric BMT group looked at the incidence of endothelial cell dysfunction and TRM, because that's one of the problems when you use busulfan, and they looked at patients with malignant and non-malignant diseases. Neutrophil and platelet engraftment were good. The incidence of endothelial dysfunction was only 5%, which is very lower than the 15% that you get with busulfan based regimens with very good outcomes. So at CMC, we realized a long time back that our class 3 thalassemias were doing very poorly with the standard conditioning of busulfan and cyclophosphamide. And studies from our own center showed that all class 3 patients are not the same. We identified a low risk and a high risk group. The high risk group being a group of patients who had a liver more than 5 centimeters and age more than 7 years at the time of transplantation, and the rest were low risk. And clearly we showed that the low risk actually did quite well, about 70%, while the high risk did very poorly at 23%, and outcomes were very similar to class 2. So what could we do for this class 3 where we were not getting that good results? So we started looking at a triosulfan based conditioning, looking at the combination of thiotepa, fludarabine with triosulfan, and we sort of replaced the bone marrow with the peripheral blood stem cell graft. We had, so we looked at about 202 class 3 patients, of which 139 received BUSI and 50 received the FTT protocol, and of this 82 were class 3 high risk. Now, essentially, we found that the time to platelet engraftment was shorter in the triosulfan. The incidence of sinusoidal obstruction syndrome was lower, and the overall survival was markedly different. So we got an overall survival of about 87% with the flu trio as compared to 63 with the BUSI. So overall, it was very different, both the overall survival and the thalassemia-free survival. And importantly, when we looked at the class 3 high-risk group, where we were getting only 40%, the triosulfan, we managed to push up the overall survival to almost 86%, with the thalassemia-free survival being at about 77%. So this seemed to do well. What we wanted to then look at was, when we go to older children, that means patients who are more than 13 years old and young adults, and we see now a lot of them who are coming for transplant, saying they want to have a transplant, what was their outcome. So there were about 124 patients whom we transplanted above the age of 13 out of the 770 that we have transplanted for thalassemia. Of this, 110 were class 3. We had about 73 which were flu trio, 46 with the BUSI, about 90% engraftment, and all of them engrafted by day 16. Acute GVHD about 34%. For the entire group, the overall survival was about 63%. Remember, this is people above the age of 12. But very importantly, when we had a triosulfan-based regimen, we had much better outcomes of close to 72% as compared to the BUSI, which was about 54%, and similarly 70% with triosulfan as compared to BUSI. So even in the older children, we could transplant successfully about 70 to 75% of patients who came to us. The oldest THAL that we have done is about 29 years, so we can easily take up these patients for transplant. And this is data on looking at the high risk, the velour high risk. So with the flu trio, we're getting almost 75% as compared to the 40% with BUSI. We also looked at, if you went above 18 years, what were the outcomes? And this is actually the outcomes in those who are more than 18 years old with triosulfan, which is about 74% as compared to about 50% when you looked at patients where we gave busulfan. So definitely the use of a triosulfan-based protocol has not only helped in improving the outcomes of class 3 thalassemia, but has also helped us to transplant older patients with thalassemia with successful outcomes of more than 70%. We also looked at patients who had a graft failure, and then we wanted to take them up for a second transplant and see what were the outcomes. And this was a publication which was, I think, about 4 or 5 years back. We had about 62 patients who had a primary graft failure, and then we had to take up for a second transplant, out of which we had about 12 patients who had a triosulfan-based conditioning as compared to busulfan-based conditioning. And even in a second transplant, we are getting close to about 80% survival in that group of patients. So a triosulfan-based conditioning is also useful, despite them having, many of them having a trio-based conditioning in the first time. We actually could get that even in the second time around for the second transplant. We looked at also for the other indications. So this is 100 transplants done for inborn errors of immunity. We did about 42 matched sibling, 18 MUDs, and 40 haplos. Of this 179, we used triosulfan-based conditioning, basically based upon the EBMT recommendations. We use PBSC in most of them, and engraftment in about 88%. We have about 70% with matched sibling, 53% with MUDs, and 45% with haplos. Remember, a lot of them are patients who come in with infections, and so the outcomes are definitely lower. We also looked at about 20 patients with the diamond blackfan anemia, whom we have transplanted with a median age of 5, a ferritin of 20, 72, all had failed steroids before we took them up. There was about primary graft failure in about 10%, overall survival about 60%, and importantly, if you had a matched sibling donor, we have about a 75% chance of cure with trio-based conditioning. In a MUD, 4 out of 4 are all alive and well, and in the haplo, it's about 60%. So conclude by saying that triosulfan-based conditioning has established itself as a good myeloablative non-toxic regimen. It's useful in both malignant and benign disease, has lower levels of SOS and non-relapse mortality compared to BU-based conditioning. Late graft failure is a concern and needs to be carefully monitored. Unlike the BU, where if you get a day 30 chimerism which is complete, the chance it will drop off down the line is less. It is exactly the opposite in trio. So you may have day 30, 60 which is complete, and by 90 it may start dropping off. Recently we had a patient who had a MUD transplant, and 5 years has been having complete chimerism. Now in the 6th year has started dropping this chimerism. So in trio, it's something very important that you should not just leave them off. You have to keep monitoring them and intervene if you get a mixed chimerism. Unlike busulfan, right now triosulfan pharmacokinetics is not in a standard practice, but there is a lot of data coming out saying that you can actually look at triosulfan PK and predict who's likely to have graft failure. And so hopefully down the line, like what we do for busulfan, where we adjust doses, we may be able to adjust doses of triosulfan in the future. With this, I'll stop, and I'll be happy to take any questions, if any.
So much. Thank you so much, Dr. Biju George. And with this, last but not the least, we come to the last session, and that is a talk. And the panelist is Dr. Vikas Dua. So he's going to announce the name of the panelist.
Thank you, Kanika.
Yeah.
So this is the last session of the day, friends, and we are not between dinner and you. I am between you and cocktail. So there are 50 people waiting outside so that the cocktail can be started in this room. So we'll try to wind off early in next 10 to 15 minutes. So my request to all my esteemed panelists to be short and brief. Can we have the PPT, please? All right, so the task given to me is to have a panel discussion on chimerism, rebalancing mixed chimerism post HSCT, and we have got 4 fantastic panelists with us. First one, Dr. Arun Daneva, who is a senior consultant in the Department of Pediatric Hemonc at FMRI. Next is Dr. Ravi Shankar. Third one, Dr. Neeraj, and last but not the least, Dr. Parminder Pal Singh. So we all as pediatric hematologists, oncologists, and transplant physicians, when we are doing transplants, we do see problems like this. Chimerism initially fine, and then after some time, chimerism dropping. Whether you're doing a transplant for a malignant disorder or for a non-malignant disorder, these issues, mixed chimerism issues, are very common. And how to tackle that? Whether the approach to manage a patient with mixed chimerism, hematological malignancies or benign hematological disorders would remain the same, or you have a different approach in managing these patients. That's what we are going to have a panel discussion on. So let's move on to the questions. So my first question to Dr. Parminder Pal Singh, what is chimerism? How do you define chimerism in a post-transplant setting, Parminder?
Good evening, everybody. So chimerism is something which basically tells about the proportions of the various, the proportion of the donor cell and the proportion of the recipient cell post-transplant. And regarding the chimerism, we say complete full donor chimerism when both the components in myeloid and lymphoid, the chimerism is more than 95%. mixed chimerism is defined when the proportion of the donor cell is between 5 to 95%. Absent donor chimerism is when the proportion of the donor chimerism is less than 5%. And split chimerism, if we have different degree of chimerism in both, like if we have different chimerism in the myeloid component and if we have different chimerism in the lymphoid component.
Right. So you don't need to have a 100% chimerism or a score of 100 out of 100. Even if you have a 95%, more than 95% chimerism, you call it full donor chimerism. Anything between hovering between 5 to 95 is mixed. And if you have a donor chimerism which is less than 5%, that means probably you have lost a graft. And then nowadays we have a concept of split chimerism. We'll talk about that also in detail. When we talk about a transplant, when we talk about chimerism, when we talk about mixed chimerism, the idea of treating a patient of hematological malignancy, a benign disorder, is different, because in a malignant disorder you need to have very good chimerism. You cannot just you say that there's a 95%, 96% chimerism and there is no chances of relapse. It is always good to have, I would say, more than 99% chimerism, so that there are no recipient cells in the marrow which are mutated cells and which can bring the disease back. So in a malignant setting, in a patient of ALL or AML, if you have even a little bit of chimerism of the recipient, you have a chance of relapse. Whereas in many of the benign hematological disorders, a stable, I would say, a stable mixed chimerism can do the job. So Ravi, if you can answer this, what are the risk factors in general for mixed chimerism or secondary graft failure, I would say?
So there are basically pre-transplant and peri-transplant and post-transplant factors, and these can be certain again classified as modifiable and non-modifiable. So in pre-transplant factors which can affect graft failure or mixed chimerism is HLA mismatch, non-malignant diseases, advanced diseases, extensive marrow fibrosis, age of the patient, and pre-transplant iron overload, anti-HLA antibodies can affect the graft failure. And the modifiable factors are like T-cell depletion, conditioning, and the graft source. And peri-transplant is again the stem cell count, viral infections, drug toxicity, GVHD risk factors.
So youngsters, please remember this thing. More and more alternate donor transplants, more and more chance of mixed chimerism. Non-malignant disorders, benign disorders, you see more of mixed chimerism. Advanced disease, extensive marrow fibrosis, older donor age, a big spleen, more chance of rejection or a mixed chimerism. Please remember this when you are doing a transplant and you are in the initial stage of doing these things. And when we talk about chimerism, Parminder, can you just tell everybody what are the various methods of doing chimerism? Because there was a time when we did our transplant training, we just knew the fact that you can do chimerism by fish method if you have a sex mismatch, or a different method which you're going to tell us.
So the various methods, the most common method which all of the world is using is the STR chimerism. STR-PCR chimerism, that is short tandem repeat chimerism. This is the most common used, even in developed country, it is used most commonly. The other methods are quantity PCR chimerism and the newer methods, the digital droplet PCR and the chimerism by NGS. The old method, which sir also told, was about the fish chimerism, which the new UK guidelines consider to be obsolete.
Yes, I think some centers, even we, are doing fish chimerism if you have a sex mismatch, but UK guidelines says that you should not do a fish chimerism, better to use a STR technique. But there must be some advantages and challenges of these new tests, Neeraj, if you can just elaborate on that.
So the utility of this chimerism testing is to detect the percentage, and we should know whether these tests are going to be reproducible, what is the cost of these treatments, and what interventions we can take. What is the treatment thresholds for different types of chimerism testings. So essentially, it should be informative, means these tests should be sensitive enough to mention about the percentage of chimerism. Secondly, it should be sensitive and they should be accurate. And as I said, it should be cost effective and reproducible as well. These newer techniques of chimerisms are sensitive, more sensitive than the STR chimerism, but we don't know what is the exact threshold for interventions in these techniques. And also the long-term data and the interventions are not well established in these techniques like digital PCRs and NGS-based chimerism testing.
Absolutely on the nail. So, and these are I would say time consuming, costly as well, and we don't know how to intervene with these new fancy tests. So at the present no time, I think majority of the centers in this country are using the STR techniques to do chimerism testing. Then these are some of the recommendations of which are being given by the UK Society, yeah, United Kingdom Society. They have come up with these recommendations. I can just read for you. There was a group of around 21 adult hematologists, 9 pediatric hematologists, some lab hematologists who sat together, and they agreed upon 80% of them agreed upon these points. And the point number 1 is peripheral blood is a specimen of choice. You don't have to puncture the marrow to do a chimerism, but in case the counts are low, you feel that you will not get sufficient yield, then you can do a bone marrow chimerism. Then the STR method remains the standard of care, and you need to have more data, more answers to tell whether PCR or NGS based chimerism testing would take over the STR technology or not. And the turnaround time, when you talk about chimerism testing, you need to see how early you need to intervene. If it's a malignant disorder, you need to get the answer within 5 days, whereas in a benign disorder you can wait for 2 weeks. That's what the UK people say. Neeraj, again to you, how frequently should chimerism be monitored post transplant, specifically in children?
So the specific guidelines, the time duration, the time points at which the chimerism has to be tested depends on specific guidelines. As per we say ASTCT guidelines, it says the transplant, post-transplant, the chimerism should be monitored at 1, 3, 6 and 12 months. But whereas the UK guidelines says to test is every month for first 6 months, and then 2 to 3 months for 1 year, and 3 monthly during the second year, and then annually till 5 years.
Yes, I don't know how many of us are following this, but at our center we do chimerism on day 30, day 60, day 100, day 180, 1 year post-transplant. And if it's a benign disorder, if you are talking about a thal transplant, a sickle transplant, you can have mixed chimerisms happening later as well. So it's important to continue monitoring these patients at least for 5 years. Whereas,
yes,
is that right?
Yes, sir, that's right. Because 1/3, it says 20% of late relapses in hemoglobinopathies, as sir said, occurs more than later after 1 year of transplant.
Absolutely, and that's what Dr. Biju was also pointing out, that they have seen mixed chimerism dropping even after 5 years of transplant. Whereas if you have a patient of, let's say, of leukemia, a high-risk leukemia, for whom you've been monitoring, if for first 2 years your chimerism is more than 100%, then you can say that your patient is cured and you don't have to regularly look for the chimerism. Again to, okay, this time to Dr. Arun. What are the lineage specific chimerism requirements and necessary level of donor chimerism for successful transplant outcomes, specifically when it comes to non-malignant disorders?
So as we discussed in malignant, the target is more than 99%, but there are particular non-malignant condition if where the stable mixed chimerism is there, so there are threshold is there, so that is good enough to elevate the disease symptom. Like in the sickle cell disease, if chimerism is more than 20%, that is documented, that is enough, and CGD, and there is 30%, the chimerism is enough. So these are, but it should be stable mixed chimerism, as this table is showing in non-malignant condition. It is not like more than 95% or 99% like in the malignant conditions.
Absolutely. For the youngsters, just remember this slide, that for hemoglobinopathies, if you have a myeloid chimerism of more than 20-25%, that is good enough, whether it is sickle or a thal. Whereas in a bone marrow failure syndrome or a idiopathic aplastic anemia in pediatric patient, you need to have a myeloid chimerism of 100%. If that doesn't happen, then you may land up in a trouble. Can you elaborate on these points, Dr. Arun, specifically when it comes to acquired aplastic anemia and inherited inborn errors of metabolism? Inborn errors of immunity.
So basically in these conditions, in which compartment the problem is there, the particular lineage we require in a sufficient amount. So it will depend upon your conditioning and the time post-transplant and all these things.
Yes, I think the most important point which I would like to highlight here is there's so aplastic anemia, we have been doing transplants left and right for aplastic anemia patients, and there is a common practice that without looking at the mixed chimerism, we try to withdraw the immunosuppression. When the chimerism is dropping, we try to withdraw the immunosuppression. That should not be done. Better you do a split chimerism. If your myeloids are good, your T cells are on a lower side, don't be in a hurry to reduce immunosuppression. You might land up in a trouble, your patient might get GVHD, and you will not gain anything out of that. So aplastic anemia, very common condition. For a transplant, you need to have a good myeloid chimerism and not to worry too much about the T cell chimerism. I think these things we have already discussed. Again to you, Dr. Arun, how will you manage non-relapse cytopenias post allo transplant?
So whenever cytopenia post-transplant, the first worry is again the chimerism. If your chimerism is okay, your donor cells are okay, then we have to think the alternative. It can be because of any drugs like ganciclovir or Jakavi which we are using. It can be because of your endotheliopathies. Sometimes GVHD itself can cause cytopenias. So we, other than the chimerism, we have to rule out the alternative if your chimerism is okay. And your chimerism is okay, still cytopenia is going on, then it will fit into the definition of poor graft function. So these are the reason: infection, drug, poor graft function for non-relapse cytopenias.
Ravi, if I have to ask you, poor graft function, all of us as transplant physicians and doing more and more alternate donor transplants, we see this problem, a new thing, poor graft function. So how will you define poor graft function, and how do you manage a patient who has got poor graft function at your center?
So basically, poor graft function is like the donor chimerism is good, but the counts are not improving. Yeah. And in that case, we'll check with the chimerism, and we can do a bone marrow to see the relapse of the disease. And when if we find that it is a poor graft function, we can either give the stem cell boost or we can plan for salvage HSCTs.
Yes. So you in poor graft function, your marrow is empty, but the donor cells are 100%. So in that case, you can think of a CD34 stem cell boost. There is a data, there is a literature coming up in which you can use thrombopoietin analogs. Thrombopoietin analogs can help in reversing poor graft function. So friends, please remember, poor graft function is not a rejection. It is the immunology, the biology is actually different. Again to you, any one of you can answer. Arun or Ravi, how will you monitor and manage mixed chimerism children who has undergone an allo transplant for sickle or for thal?
So basically, we'll do split chimerisms initially, and we'll see whether the T and the myeloid proportion, which is falling, which is more, if they are more than 90%, less than 90%, different scenarios can arise. So at 28-day or 30-day chimerism, we'll see the split chimerism. If they are more than 90%, we can start weaning off the immunosuppression with MMF, and then again we can check at 180-day. If it remains unchanged, then we can wean off the sirolimus subsequently. But if the T is falling below 90% and myeloid is more than 90%, then we can restart MMF and again assess bi-weekly chimerism. And if the chimerism continues to remain low, then we can give T cell fraction. We can wean off MMF again. And so if the graft function is not improving, then we can think of graft.
Difficult to remember, you can take a picture of this, that in case your myeloids are more than 90, T cells are more than 90, you need to follow this algorithm. In case you have a different scenario in which you have something like this. Arun.
So first I would like to say that these scenario taken from Josu de la Fonte. He proposed these various scenarios, although there is no consensus how to manage, still there is controversy. But this new concept is coming up. When your chimerism is falling, you are increasing the immunosuppression. So basically the concept behind this scenario, if your myeloid chimerism is good and your T cell chimerism is falling, try to increase the immunosuppression, monitor the chimerism, and if this trick succeeds, then continue and then later on wean off. But if your T cell chimerism is go below 30%, then try to ablate these T cells so that the host, they reconstitute the new T cells. So basically, in the third scenario, if myeloid is low, then try to wean off immunosuppressant as soon as possible. So these are, if T cell is low but more than 30%, try to increase the immunosuppressant. If myeloid is low, try to wean off the immunosuppressant as soon as possible.
Right, rightly said. And in case your myeloids are low and T cells are good, then what to do?
So that's why I'm telling. If the myeloid is low and T cell is high, then try to reduce the immunosuppression quickly.
Correct. Yeah,
quickly.
And check for the cellularity, and then you
Yes.
decide whether you want to give a stem cell boost or a TCR alpha beta depleted transplant you want to do again. Let's look at the case scenario. I can ask Neeraj, a 5-year-old boy, a case of high risk B cell ALL, underwent a haplo transplant, and on day 28, unfortunately, you have a mixed chimerism of 88%, but the bone marrow is in remission. The MRD is negative. How will you manage? It's a 1 month post transplant patient with mixed chimerism, but there is no disease in the marrow. You have done a marrow. You have documented that the MRD is less than 0.01.
So in this setting, you have said MRD's point less
0.01, less than,
okay,
it's a ALL by mistake. That's by mistake.
Okay.
So B cell ALL MRD is less than 0.01%.
Okay. Right. So in this case, the MRD is negative and there is mixed chimerism. So first step I will suggest is to do a split chimerism if possible.
Mhm.
And we can also do a bone marrow chimerism in this setting.
Okay.
We can do a bone marrow, and obviously there will be close monitoring in this case, and we need to repeat this chimerism frequently, maybe in a 2 weeks period. And if this chimerism...
Sorry to intervene. Would you get some additional information by doing a split chimerism here?
Sir, in this case, we can do a B lymphocyte chimerism, split chimer TB, NK.
I don't know whether that is available or not. I don't know. Lal people were here, so I don't think we do NK B cell chimerism. We can do
NK B cell. Okay,
You
B
said-
cell chimerism is not. Okay.
No. We can do a T cell chimerism.
T
we can
myeloid
do
side.
myeloid chimerism.
Oh, B.
But B and NK, we don't have a facility of
Okay.
doing that chimerism here.
Okay. So in this case, the MRD is negative, and we have to look at the trend of the chimerisms. If it is a stable chimerism and MRD persists to be negative, we can just carry on with the observations.
Yes, right.
Whereas if there is increasing chimerism, then we have to do some interventions in these cases.
That's right. I think day 28, 88%, it's not too bad. I think, and the MRD is negative. We can repeat a chimerism after 2 weeks. If it is rising and your MRD remains negative, you can just observe. But the matter of concern is if the chimerism is dropping and the MRD is positive, then you need to intervene. Intervene by?
So interventions in this case, if I think it is day plus 28, so the child is already on immunosuppressions. So in this case, we can do one thing. We can taper the immunosuppressions, or we can opt for preemptive DLIs.
Yeah.
But because already he's on immunosuppression, so I will think that DLI is not a good option. And that's it, sir.
I think you're right. Most of us, when we talk about a haplo transplant for ALL, majority of the centers are doing a PTCY based transplant, and it's a day 28 chimerism. Anyways, you are going to withdraw MMF. On day 28, we start withdrawing MMF, and we try to stop that by day 35. If you do that, in many of the cases, in majority of the cases, you may see a rise. In case that is not happening, then you can think of giving DLI to that patient. Yeah. Any different thoughts, Arun? Same. Ravi? All right. Post-transplant chimerism monitoring. I think we should wind off because there are people who are waiting to get in. Any take-home for the youngsters? All of you. Any take-homes? Should we do split chimerism or not?
So we should do in case of there is a trend. So first I will say the take home message is this: chimerism is not an absolute investigation. It is the trend. It is a dynamic biomarker post transplant. So we should take it as a trend rather than an absolute value. And if there is a trend of downward decreasing chimerism, then of course we should go for the split chimerism, sir. Because even though maybe the interventions may not be possible, as we cannot do subsets of B and NK, but it predicts the possibility of any relapses later on. And also the interventions can be done based on split chimerisms.
Arun, your take?
should not jump on just based on the single reading, and we should see the trend and all the scenario we should take into the
Absolutely, Ravi. Absolutely, yeah. Absolutely. I think when you see a patient of any patient who has undergone a transplant has got mixed chimerism, don't be jittery. Don't be jittery, because each and everything has got goods and bads. Decreasing immunosuppression, increasing immunosuppression, giving DLI, not giving DLI. So manage each and every case. It should be a tailor-made therapy. You should not be following one. Every patient should not be treated as a single case under one umbrella. You should have a tailor-made therapy for each and every case. And with that, I would like to thank you everybody, and everybody for patient hearing. And I think we can all wind off today's day one meeting, and we can all join for the dinner and cocktail. Thank you.
Thank you. Thank you very much.
कौन होगा पता नहीं बस बार बार